Check, 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 check. Check, 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 check. Check, 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 check. અરે બકા લાઈવ માં આવે ને અત્યારે हाँ अजगावकर ચેક 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 નીરવ તને સંભળાય છે
जी हेलो
I think they are. Let's get the program. Good afternoon, everybody, and welcome back. We regret we're 10 minutes late, which I thought somebody else will be there because I was going to do talk next. So we come to now we have three halls parallelly running. One, the Shaukat Sadikot Hall, Dr. Bajaj Hall, and Dr. Ajgaonkar Hall. Now, so today we have the chairperson of the first session, are Bhavesh Patil, a diabetologist, and Amit Kumar De is a geriatrician and diabetologist, practices in Kerala. Over to the chairperson, please. I think. You need to keep it there. You don't have it there. Hello.
Good afternoon, everyone. Good afternoon, everyone. Welcome to the post-lunch session. Hope you all are in hyperglycemic as well as hyperinsulinemic phase of post-lunch. And relevant topic, the first speaker, Dr. Sandeep Mathur, lipodystrophy and thin fat phenotype, what is common within them. I invite Dr. Sandeep Mathur. He is a senior professor and head of the Department of Endocrinology and in charge Molecular Genetic Research Lab, SMS Medical College, Jaipur. His key interest is molecular genetics of hormone and metabolic disease as well as adipose tissue biology research. He is a recipient of Commonwealth Academic Staff Fellowship, Travel Award by AS USA, and Merit Award by Government of Rajasthan in Republic Day, and several other awards like Times of India and Economic Times. He has multiple publications in the national as well as international journals. He has a research achievement like reported Chapter 14 CNP syndrome, so-called Turner syndrome spectrum disorder. Concept of Indian thin fat is a functional defect of lipodystrophy gene and decoded cellular as well as molecular basis of thin fat phenotype, etc. Over to you, sir. Thank you.
Thank you very much, and thanks to organizers and thanks to chairperson and thanks to the audience, the very thin audience, and Dr. Yagnik sir, I requested him because I will learn from him after this work. So actually, thin fat phenotype, we talk about it a lot, but is any common thread between this phenotype in our country and a rare genetic disorder, sometimes acquired disorder related to autoimmunity, and that is your lipodystrophy? What is actually common thread between two disorders? Number two, sir, what I want to point out, in which way is our epidemic of T2DM, metabolic syndrome, dyspepsia, everything, is in epidemic of functional lipodystrophy? So what I want to come with a new concept of the disease, because that is a complex trait, so many genes, so many noise. But if you narrow down to few tracks, rare disease, 30-35 disease, and there is a scope to develop diagnostic and therapeutic strategy very specific. So the complex trait can be simplified. Lipodystrophies are heterogeneous group of disorders. Characteristic feature is fat loss, insulin resistance related metabolic complication, inherited or acquired, characterized by absence of adipose tissue. That is their character. Subcutaneous fat is not there. And these are your famous DEXA pictures, though we are now doing MRI, we are not focusing DEXA. And there is a loss of
इनपुट में ये क्यों आ रहा है?
What other facet of the coin is that in all these disorders,
फ्रिज क्या है क्या कुछ? आउटपुट नहीं आ रहा है ठीक से.
but simultaneously
अरे आ नहीं रहा है यहाँ पे.
subscapular as well as your visceral fat. So it is redistribution of the fat. But problem start from where? Subcutaneous fat.
आगे
Actually, I am raising a serious question of visceral fat theory of type 2 diabetes and all these things. So, Yagnik sir, I will now most stringent comment
बेटा तुम
from
नाम तो
you,
नाके दीस ना
best criticism so that I can do better.
हाँ जो वीडियो कैप्चर ले आना
You see,
ऐड
there are
करवाना
four categories of
वीडियो
syndrome.
कैमरा
They
ले
are congenital, either
ओके करवाना
generalized or familial partial. They may be acquired lipodystrophy.
अब
Some
तो सेट कर ली
disorders
इसने
are associated with autoimmune
बस
disorders.
अब तो नाम नाके
This is
दे
the classification of these disorders. And individual disease genetic basis is very well
कैमरा नहीं फीड आ
understood.
रही है ना
For
मेन
that
में
is well
कैमरा
known
अच्छा
this
है
limitation because this information has come from family studies. They identified in the linkage analysis in the family, they identified the genes in the lipodystrophy families. And these syndromes have some peculiar clinical features which you should know about and you can pick up the patient in your practice. But you see, most important characteristic loss of subcutaneous fat. But what I want to find is mechanism category. This is basically disorder of triglyceride handling in your subcutaneous adipose tissue. That is the main defect. Either it's a failure of triglyceride synthesis, lipid droplet dysfunction, and poor adipogenesis. The whole story is focusing on the one single process, adipogenesis. Sir, actually in next Pune I will speak on that point. Whole story of Indian epidemics focus on one cellular process, adipogenesis. And that if you correct that, many problems can be sorted out. And your all stories of insulin, DLP and Paltis, all the story will be your supportive therapy like paracetamol in your malaria. So perturbed cavular is one of the mechanism. In different diseases, genetic basis is known and the defects are again in the triglyceride handling in adipocyte, either nuclear annular perturbation, defect in adipogenesis, lipid droplet dysfunction, and so on. And some processes are related to DNA repair also, because molecular biology going to the extent of DNA repair and all these things, they are actually windows through we can look for gene therapy and gene manipulation. So this whole story is around your triglyceride handling and particularly the process of adipogenesis or lipid droplet formation. So adipocyte difference regulation is the basis of all lipodystrophies, and most of the gene converge on the pathway either adipocyte development by adipogenesis or adipocyte storage of triglyceride. The whole story now I want to tell you is that this is similar to your type 2 metabolic syndrome pathophysiology or adiposopathy. I will talk about that in Pune. So same mechanism, your adipocytes can't hold your triglyceride and fat. Because it can't hold it, it goes to ectopic site and create all the problems. And this mechanism is shared by both obesity. Obesity, the problem is, sir, Yagnik sir, your theory, load and capacity. Load is heavy, capacity is also good but exhausted, obesity and your dysmetabolism. When the capacity is very low in terms of your adipocyte handling of the triglyceride, and I have evidence to that, how it is important, most important, and this capacity is shrunken, and that leads to, even with the normal load, it becomes dysfunctional. So this is the balance of these two things. Now, is limitation, so inference is it is limitation of adipose tissue to store triglyceride that is underlying pathophysiologic defect of both lipodystrophy, obesity, insulin resistant state and metabolic syndrome. So they have common, very common pathophysiologic thread, both of them. What is the clinical manifestation of lipodystrophy syndrome? You see, these clinical manifestations are almost similar to your metabolic syndrome manifestations, you know, but there are a few differences. What I want to tell you, I will come to that point. Now, one important pertinent clinical question to general practice, how to recognize these syndromes in your practice. You see, there are few fundamental differences in lipodystrophy and your insulin resistant and metabolic syndrome. That lipodystrophy are relatively severe syndromes. When we come to, we diagnose through family tree. You know, family we diagnose and we come to the, we do genetic testing and come to a syndrome. They have very serious problem, but you see, loss of fat and low weight are characteristic of lipodystrophies. Number two, leptin is low in your lipodystrophy, it is high in metabolic syndrome. So these are few fundamental differences. The percentage fat is lipodystrophy much less in your subcutaneous. Waist circumference is very low. So whenever see a patient with very poor waist circumference, always think of lipodystrophy. Actually, these are Western countries things. When we come to our country, you may have so many patients in your practice. I'm coming to that point. And severity of hypertriglyceridemia, all the things are there in lipodystrophy syndromes. And when to suspect, American, at the Endocrine Society given guidelines, they say generalized or regional absence of body fat. You don't find any fat around here, anywhere in the body. But failure to thrive in infants and children who has diabetes, prominent muscles, your prominent veins, severe acanthosis nigricans, eruptive xanthomas, Cushingoid appearance. Sometimes we suspect Cushing and Cushing does not turn out, there could be lipodystrophy and we miss the diagnosis. Acromegaloid appearance, many patients, diabetic comes to us who are acromegaloid appearance, their fat is prominent and their jaw is large. They might be suffering from lipodystrophy and we should think in terms of that. Similarly, if a patient requires more than 2 units of insulin per kilogram body weight, seriously consider lipodystrophy, or they require more than 200 units of insulin, or triglyceride more than 500. I know many patients I treated hypertriglyceridemia and with so many medicine, all these things, and they were suffering from lipodystrophy, and we were treating with insulin and other things without realizing, and the whole family was suffering. So, and number 2, they have voracious appetite. So I have shown this picture. If you find very thin limbs and a fold of fat on the abdomen, or in you pick up it like this, it's like your Cushingoid. It's like you can pick it up like a very thin fold of skin. No fat here in the cheeks. Prominent muscular appearance, diabetic, looks very muscular, consider lipodystrophy. Acromegaloid appearance of the hands. I've seen many patients who are diabetic who have acromegaloid appearance in the hand and their IGF-1 is normal. Similarly, if the patient has early aging, he looks very old when he's 35 years, he is bald and he looks all these features of the obesity there. Then hypertriglyceridemia, this gentilashma, and prominent veins. These are the physical signs you should suspect this syndrome. Now approach. Here it is very important. If you clinically suspect lipodystrophy, look into the family history, then go for genotyping. Actually, if you ask me application of genetics, apart from Moody, I would consider, actually I am working on this project also at this moment, that lipodystrophy syndrome could be picked by your whole genome sequencing, whole exome sequencing. But, sir, what I want to do, I want to develop our own database of genetic polymorphs. That's why I was out of diabetes for 2-3 years, because I am busy in that project actually. We have our own database because we are entirely different than the Caucasians. We are not same, because this lipodystrophy syndrome might be there in their population, not that so common, but it is very common in our country. So, there is a track. If there is an autoimmune for thyroid problem with diabetes, consider autoimmune lipodystrophy syndrome in these patients. Many patients have vitiligo, diabetes, hypothyroidism. Consider lipodystrophy, then you go for lipodystrophy marker. But leptin, unfortunately, is still not a very good diagnostic test because its levels overlap a lot. Now, these are certain clinical conditions. They also have loss of fat. They also mimic lipodystrophy in clinical grounds. Now, lipodystrophy mimic metabolic syndrome, insulin resistance state clinically, but one should have eye-index suspicion. And what is Indian fat phenotype? We always talk visceral fat, abdominal fat, abdominal fat. The whole story is everyone's mind is only not beyond this. But you see, we did this work. Unfortunately, sir, this slide is little in the sense, this is taken from the poster. This paper was accepted for presentation during Endocrine Society. We could not attend there, we created the poster. Now, full text is submitted to +1. What we find, definitely diabetics had higher visceral fat. This is MRI study. We did on 130 patients, actually MRI. And what you find, diabetes higher visceral fat, a little higher subcutaneous fat. Ectopic fat was also very high in diabetics, so this was expected. Similarly, metabolic syndrome, all three compartments higher fat. But when it comes to correlation, HOMA-IR correlates with your ectopic fat, metabolic syndrome correlates to ectopic fat, not to the intra-abdominal non-subcutaneous fat. There is no correlation. Number 2, in this category, even your visceral fat is protected with low actually HOMA-IR, and it is very pathologic in higher. So this picture is the correct picture. I can tell you, sir, have a look at it. Visceral fat amount increase, the quartiles of HOMA-IR. Actually, nobody has actually attempted this, dividing patient according to quartiles of HOMA-IR. We divided. We did not find any such work in the literature. What happens? as your ectopic fat rises, your HOMA-IR goes up. Same time, your subcutaneous fat amount goes down. So what we call nutrient overflow is basically a feature of your highest quartile of your HOMA-IR. It is not for everyone. And visceral fat, initially it is protective. So nutrient overflow hypothesis, if your nutrient goes from subcutaneous compartment to your ectopic compartments, this is the main culprit of all the problems. And you remember, surgical removal of omentum has no benefit. That is, I think, the best evidence. The whole story of your visceral fat ends here. So, this is nutrient overflow hypothesis is correct. It is not visceral fat. We call intra-abdominal fat. That has nothing to do with your problem. Or whatever it does is very limited. But we have to do some more studies. Actually, Dr. Kochupilli told me long back to take samples of, adipose cytokine during cardiac cath studies and all this. I will do that and prove that, actually, at the next step. And I will look for your guidance, sir, at this, for that. Kochupilli told me that idea long back. Now, is it peripheral fat? Yes. Let us look at most prominent, most well quoted Indian study. Dr. Anup Mishra's study, he said it is, yes, they have more hepatic fat, pancreatic volume, and all these things, but see, their peripheral fat was less in their study. And there was not much talk about in the discussion. Similarly, the landmark study, sir, you must be knowing about it, this is the early life study. Everybody talk about subscapular fat, nobody talk about less triceps fat. Indian children at the birth as well at the 4 years of age had less fat in their upper limbs. That was not even talked much about. And that was something, because all were obsessed with the idea of visceral fat, central fat, because that is close to your liver. So, it is thin fat phenotype is basically a partial lipodystrophy. Now I am coming to the main point of my presentation. Is it partial lipodystrophy? What is the cellular basis less peripheral fat? Actually, we took up our own data. Unfortunately, its full text is still in final preparation to submit, but we presented a poster during Endocrine Society meeting, and we could not present, but virtually it was presented. What we find, adipocyte size is the best marker of adipogenesis. Poor adipogenesis, in my opinion, is the main culprit. So I look for adipocyte size. Adipocyte size was higher only in the peripheral subcutaneous fat, not in the abdominal fat, or it was marginally high. So pathology was more in peripheral fat, but there are different cohorts of patients, not in the abdominal compartment. Number two, it is the adipocyte size that correlated with not only your BMI, waist circumference, waist ratio, HOMA-IR, it correlated in the thigh. So, sir, what we presume, more abdominal fat, it is not quantity, it is adipocyte size, and poor adipogenesis we measure. I am not discouraging the concept of waist circumference, because this reflects your adipocyte size, and we can have more data, sir, with you and with some better technologies. So basically what comes here around is basically your adipocyte size, because this could not grow. These cells are increasing in size, and that is manifesting here. This is not the amount of fat in your MRI, which is all in the omentum. Similarly, what we find, definitely adipocytes are correlated abdominal basal subcutaneous, but that adipocyte size does not correlate with HOMA-IR. That means even enlarged adipocytes with basal subcutaneous doesn't much of the role. So, conclude that the thigh adipocyte size is significantly large in diabetics, and diabetic patient thigh adipocyte size was positively correlated to HOMA-IR waist circumference. So, we measure HOMA-IR waist circumference. This is the reflection of adipocyte size in your thigh fat, not in a visceral and subcutaneous abdominal fat. And I am replicating this for it. Secondly, gene showing correlation. Because we are in functional genomics, and gene showing correlation with adipose size and the adipogenesis, lipolysis, and adipose tissue inflammation related pathway. So this reflects a pathology in peripheral fat. It is not a pathology of abdominal subcutaneous visceral fat. Third point, lipogenesis pathway was affected in peripheral fat in a divergent manner. It was upgraded in your peripheral and downgraded. So more on fat go deposit because of this, and I will look for genetics associated. That will be ultimate to find the genes for Indian diabetes mellitus and Indian epidemics. Now coming to the another point, pioglitazone we use. Sir, you rightly said last night, this strategy is not very good. There are so many effects of the drugs, but what we find that when we treated our patient with pioglitazone before and after we did DEXA, what we find,
improvement in HOMA-IR is strongly correlated with increase in peripheral fat amount. So whatever the best effect of pyruvate, they are because of adipogenesis enhancement in peripheral fat. So that is an indirect evidence, and I will prove on now on multi-omics now, as you told me last time. But you are very right, I should have a good lifestyle intervention also in that case to prove that concept. Now, what is the molecular basis of this? So we are the first one in the world literature to report transcriptomics of peripheral adipose tissue, and we find that peripheral fat is pathologic in diabetics in terms of adipocyte hypertrophy and inflammation. Not only this, modules of co-expressed gene. If you ask me the functional unit of all this matter, they are the modules of co-expressed genes, because they are regulated by single transcription factor. So I have one paper in Nature Scientific Report where I documented it. So these modules correlate with all intermediate phenotype, adipose tissue pathology, adipocyte size, HOMA-IR, your adipocytokine, and your HbA1c level. The whole trajectory is now seen through this molecular function. In my Nature Scientific Report, I go into the genetic mapping of those also. That I will discuss in Pune next week. So, number one. Number two, the same study we replicated, we find these all genes which are expression profiling, because we are expert in transcription profiling, multi-omics, and gene expression patterns and molecular function, and these molecular functions basically converge on the process of adipogenesis. I have shown in the cell cellular level and molecular level also find it is poor adipogenesis of peripheral fat that is playing a role, that is mimicking your lipodystrophy syndrome. So this is how it mimics. Is phenol lipodystrophy genetically distinct entities? No. This is literature, insulin resistant score from your Jivas. Sir. Jivas is something obsolete, I will say, but it has a background information, and it's a score of insulin resistant Jiva in a gene dose score was associated with lower BMI. You know, genes which are making susceptible to diabetes, they are having associated with lower BMI and glutofemoral, less glutofemoral face mass. So gene association study also proved the same thing. It is less fat in the periphery. Similarly, this Nature Genetics paper 2017, I can come to the conclusion, 53 genomic regions associated with insulin-resistant phenotype and association with lower adipose tissue mass in peripheral compartment was shown. Even gene association level also said this, your dysmethylation correlated with less peripheral fat. And also familiar partial lipodystrophy genes, and they were converging on each other. Actually, they could not do functional genomics. We are done the functional genomics. Now we come to our own concept. One afternoon, my resident Hardeva Ram was speaking here around, I think not in this hall, the lipodystrophy, this gene, I was listing this. I said, oh, lipodystrophy can be functional defect of your lipodystrophy gene, type 2 diabetes. Because I had a data of transcription profiling for fat tissue. So what we did, we looked in gene mania. Gene mania is actually, our strength is gene network analysis. Actually, no gene works in isolation. Gene works in a network. So our strength is gene network analysis, and we look for gene network of metabolic syndrome related genes. But we find all 7, 8, 9 genes were there in that gene mania of metabolic syndrome related this. So that means this is functional defect. And we find all the genes which are causing lipodystrophy converge on adipose tissue differentiation and adiposis apoptosis pathways. So lipodystrophies are experiment of the nature, genetic polymorphs of the genes which are playing role in adipose tissue development and functioning and death. So nature's experiment, deleterious mutation lead to severe disease. With this concept, I developed a network of lipodystrophy gene, and look, I find many of genes were upregulated in our database. So we came with the concept, idea that type 2 diabetes may be functional defect of lipodystrophy gene. If this gene is defective protein structure, it will lead to lipodystrophy. Its expression is less. It is there, it is normal structure, but the expression that will lead to your type 2 diabetes. Because I change the story from complex state of type 2 diabetes to peripheral fat leads to some lipodystrophy genes, and can it help in its functional defect. So in the second experiment, what we did, we looked for common pathophysiological thread between Indian diabetics thin fat phenotype and partial lipodystrophy, peripheral tissue transcriptomic evidences. We developed actually a network of lipodystrophy gene, looked for X expression. Simultaneously, we look for expression of, I can come to the next slide. There was a 18% overlap between network of lipodystrophy gene and differential expressed gene in peripheral tissue. This is so much, 18% common thread is there, because in any tissue there are so many other pathways are acting place, but 18% overlap. So this is a good overlap. Secondly, I tried to classify, this is a more important part of my presentation. Fortunately, I got a grant from RSCJ, thanks to Dr. Bansi. That I got a grant from RSCJ, and I have replicated this work, and hopefully I will present during next this RSCJ meeting. I can subcluster my diabetic patient on the basis of expression of these genes. So complex trait, 23,000 genes, permutation combination, 6,000 genetic polymorph study, it will converge on the few genes. And other way around, next phase I will be coming with the lipodystrophy genes coming out of my transcript profiling, and we will search for lipodystrophy in our patient. That's why I'm interested in general practicing doctor. Please pick up lipodystrophy, and I can have more pedigrees. A transcription profiling identified gene, and I will look in the gene sequence or gene regulator in those families. So we will have a large, so whatever epidemic today is a lipodystrophy epidemic, functional lipodystrophy epidemic. So I've come to this point. Any specific treatment? Yes, I think I can omit these slides. What happens, lipodystrophy has something common with the treatment part also, because metformin, insulin, and thiazolidinins are used for lipodystrophy also. Many of dyslipidemia, hypertension, liver disease, lipodystrophy, same as we do in type 2 diabetes. Maternal leptin is a drug which was developed for actual lipodystrophy syndrome. Unfortunately, this drug was not much helpful in the management of diabetes mellitus. So both lipodystrophies and thin fat phenotype, I am talking therapeutic part, complications like T2D, hypertension, dyslipidemia are treated on same lines, but a specific drug developed for lipodystrophy is not effective for management of T2D, because there is a mechanism difference, because that acts on only leptin level, no other pathway of your lipodystrophy syndrome. So conclusion is that lipodystrophy is a relatively rare and heterogeneous group of disorder. They could be genetic or acquired, cardinal feature of which is complete or partial loss of adipose tissue. This phenotype, particularly partial lipodystrophy, resembles thin fat diabetic. The central pathophysiology mechanism of thin fat phenotype is failure of peripheral adipose tissue to store fat. The underlying pathophysiological mechanism both includes impaired adipogenesis and other lipid storage defects in peripheral adipose tissue, glutathione adipose tissue. Both of them not only resemble phenotypically, they share genetics predisposition and functional genomic mechanisms, and lipodystrophy need to be diagnosed in clinical practice because there are specific and effective therapy available for them like maternal leptin. So thank you very much for your patience hearing.
Thank you sir for a wonderful, very lucid and informative talk on lipodystrophy, and you have very simplified to identify the lipodystrophy and its clinical relevance. Thank you, sir. We have a discussion session after all the three. Okay. Then any question?
Maybe a quick comment from our esteemed senior faculties, because I think this is a very offbeat topic for most of our clinicians, and sir has presented it in a fantastic way. So a quick comment, and then I would request sir to once again, just as you said, sir, that lipodystrophy needs a very high index of suspicion. So for the primary care physicians, if you could just quickly sort of give us a few points that they should look into their patients to identify lipodystrophy.
Yeah.
To summarize. Yes, sir, any comments?
Your
Sir?
Sir, I want to ask.
Just after.
Do you mean to say that all these individuals would have dysfunction in the adipose?
yes,
All these
yes,
so practically the whole country would get in.
yes. Yeah, that is something we have to do in our country. We are not talking about what ADA says, what FDA approved, all these things. We should think about our country and our products. I think Dr. Mohan did a wonderful work that he did clustering of Indian phenotype, clustering three basically functional diabetes. Because many patients have inducible phenotype, aging and diabetes. But those who are getting in early ages, what I can do in our country, they are awesome. Those in BMI less than 27.
Something like a lot.
Yeah, LADA is different. That is autoimmune.
Not a
But you see, sometimes we will look for the LADA category also, because autoimmune process and lipodystrophy also go together. Pancreatitis is there in some of the patients. So that is something need to be explored actually.
Okay, have you seen our clusters paper? It's in Diabetology 6 months ago.
Yeah.
And 63% of patients in Pune
Yeah.
diagnosed with type 2 diabetes before 45 years of age are so-called SIDD, severe insulin deficient diabetes.
Okay.
We just are working out its genetics. We're working out different aspects of fat, including liver and other things. And I think we'll know more about it. My take on thin fat originally was that it's an epigenetic thing driven by intrauterine undernutrition, and that still stands. I mean, this Kitty's paper which you showed was actually driven by me. In the sense that after I wrote my paper, I was looking for data sets where similar measurements were made. And that showed same thing. So triceps and subscapular
Yes.
in our measurements. Subscapular was the best preserved, triceps was the less preserved. And low peripheral fat we have shown in a number of studies. In the sense that that's relatively well known. People who have less fat in the legs are more likely to have, in other words, fat in the legs is protected.
Yes.
I mean, that's how I teach students. And again, my take on this was on epigenetic, driven by intrauterine, whatever things are happening. Currently, we have what called the transcriptomics, proteomics, and a number of things in a B12 trial. And transcriptomics has shown some quite amazing results about change in the cell cycle parameters with B12 supplementation with or without antimicronutrients. Proteomics and other things have started showing things. So I think multiomics is quite right. Then recently there is a paper from Hani Yahudkar. I don't know if you've seen it. And it actually is what you should very definitely read. She used to work in Exeter with Tim. Now she is in a university in London, and she has described protective phenotypes, protective polymorphs, which give you very different distribution of body fat. So she is talking about protective, you will talk of predisposing, so it will be the other side of the coin. That's being mapped out. We have full exome sequencing, we have Affymetrix JVAS, so you are most welcome to actually come to us, we can do that analysis, but that's in a population-based cohort, the Pune maternal nutrition study. And at 18 years, we did the MRI, and what we found was the strongest associations with whole cardiometabolic risk factors were not with visceral fat, but were with the subcutaneous fat in that study. Yeah. So our conclusion is saying the subcutaneous fat in Indians is more pathogenic than visceral fat. Though just now we are trying to understand this more in collaboration with Westminster University, who are really the leaders of body composition by imaging. So I'll connect you with them so that we can also learn their interpretations. So there are a whole lot of things here which I think we can go on discussing. I need to understand this because it was quite a bit for me to take in. But this we had raised right at the beginning with Laminar. And that was my sort of influence of Andrew Hattersley on me, that he was asking me to actually look for these Dystrophy sort of genes in the Indians. We didn't find association that time, but I think with now modern sort of NGS and this and larger number, we could do that.
So actually I have already done it.
Yeah.
I'm analyzing the data. LNNA gene is showing altered expression in most of the patients. Actually, the most commonly differentially expressed gene in your thin fat phenotypes.
Right.
So I will share my data and I am happy to publish with you, sir.
Perfect. And whenever expression is different, I always think of
Because my
epigenetic.
story is function of a gene, epigenomics, or is it gene sequence, or some transcription factor, or some kinase, or some microRNA. That is something which we are now going to discover.
So you've seen our paper in Journal of Blood last month.
or the mRNAs which are introduced by the diabetes.
I went through the abstract.
Yeah, and in
So what I will suggest you, sir, sorry, for me to just submission to you. Sir, let us have whole transcriptome analysis rather than few microRNA. Because few microRNAs I have already done for this lipodystrophy gene and other my lab. But future is whole transcript, whole mRNA sequence. And not amino. Sir, my collaborator did something unique. It is not mRNA sequence, mRNA expression, mRNA tertiary structure which is not coded by the gene code. So we are working on all those concepts. So I will be interested in whatever you are doing. So if you want to do multi-omics, we can assist you in doing interpretation of the gene. And secondly, clinical identification, very shortly I will tell you. A patient who has, you look at the hand, if it is very thin, if veins are prominent, jaw is large, and protuberant. So that is not culprit, that is a consequence of this. And prominent adipose inheritance. If you find a margin between less fat and increased fat, Cushing white not having Cushing, always come. Triglyceride more than 400, always suspected. And last and most important, a patient who requires more than 2 units per kilogram body weight, always considered lipodystrophy. So these are the guidelines. Thank you. Thanks for coming.
How can you protect if you want to send some patients data?
I'm very much interested in Pan-India study. I'm very much interested under the guidance of Sir. Because, Sir, under your guidance, if you permit, we can have some large studies we can do. And we can have a larger grants also. And actually, I am expecting one grant from state government, actually 122 crores for all the work. So if we get it there, then we can do anything. So you can all have search my email ID on Google. Just show your interest through email. Those who are interested, most welcome. We can have a larger consumption.
And for this, sir, you just have a Google form for this lipodystrophy so that we can circulate, and whenever we get data, directly it will be coming to you because you have generated that form.
Yeah. First, let me know who are interested. Once I know the people who are interested, I can generate a Google form. We can draft a protocol. We have to do ethical clearance, and then we will cluster our patient according to fat distribution and dysmetabolism. All laboratory tests can be done in my laboratory because I am doing all with IgIB, all omics and other things. We very frequently send our sample there, or some work is done in my lab. So my lab do all hormones, cytokines and everything. So all can be done here. So those who are interested, please email me and I will make a consortium. I will be happy to do it. Thank you.
Thank you.
Thank you, sir, for the wonderful talk. So, moving on, we move on to a very interesting, perhaps the most talked or most hyped topic of the day, that would be reversal of diabetes. And it is an honor for me to introduce a speaker. It's a person who needs no introduction. Dr. S.R. Arvind, sir, is the president of Diabetes India. He is a director and chief diabetologist at Diamond Hospital, Bangalore. He's also been the course director, postgraduate studies of Health University in RGUS and also in RSSDI. He's been the past president of RSSDI 2015 and 16. He has over 100 papers and has conducted over 100 phase 2 and 3 clinical trials. So without much delay, over to you, sir.
Thank you. I think Sandeep's talk was too technical. So much of science and I could see, okay, this is going to be quite simple, and then this is a talk that my daughter was supposed to do, Dr. Bhavna Sosle, and she could not make it in the last minute, so she asked me if I can do this one. So I'm doing the talk for her, actually. So let's talk about diabetic reversal because it's a very interesting topic, as you very rightly said. I just added one slide to what my daughter had done. Okay. So this is the overview. We go through introduction, what's reversal, is it reversal, remission, understanding mechanism, quick evidence, strategies, factors contributing to success, and conclusion. Okay. So this is the slide that I introduced. Google search, 0.39 seconds, 57 crore hits. And that's how popular diabetes reversal is. Okay, now everybody is talking about diabetes reversal. Okay. Now let's start with the story. I mean, we know that type 2 diabetes is a chronic disease of insulin deficiency and progressive beta cell loss. And everybody talks about a reduction of 50% beta cell numbers right at diagnosis. It's been talked about for the last 20 years at least. Now the question is, what is this loss? Is it apoptosis? Or can the beta cell dysfunction be reversed? Okay. We all talk to our patients and say, look, 50 to 60% of your beta cell is gone. I mean, where is it gone? I mean, is it apoptosis? It's dysfunctional? Will it start working all over again? You know, these are the questions. Okay, when differences is gone, means how differences? Differences is gone means it's gone. You know, this is how the world has reacted so much. Okay, with that we will start. Simple terms for clinicians who are practicing diabetes. You have hyperglycemia on right side. You start the medication. Will it end where you can stop all the medications and you have normoglycemia? Now, if you have a HbA1c of less than 6.5, yes, it is still in the diabetes level. If it is less than 5.7, probably it's normoglycemia, and if it persists for more than 1 year, probably you can call it as reversal. Now, the next question is, use the word reversal or remission. Okay, there's a big debate that's been going on. So the general description, every time you have a major conference where there is a consensus statement, then they will say, okay, now less than 5.7 for more than 1 year off medication, fine, I think you can probably call it as reversal. I would still say remission, I think is the right word. Now, is it possible, now the next question, with all the combined efforts of diet and exercise and meal plan, can we actually reverse diabetes, or can we keep it in remission for long periods of time? We know it's chronic. If the measures used to achieve normoglycemia are not sustained, then the diabetes can always come back. And there's enough of evidence and proof. Even if weight loss is sustained, hyperglycemia can resurface due to progressive beta cell dysfunction over time. We have evidence even for this. So at this point of time, I don't think we should use the word reversal. Probably remission is probably a better word. But from the marketing perspective, when a technology specialist is creating something, he would love to use the word reversal because that sells. So people would like to buy that app. I mean, I don't know how CGM helps, Glucometer helps. There are programs and apps and all these things are there. So they are using this word reversal. Okay, now what are we trying to reverse? Okay, I love the talk of Sandeep actually, understanding the mechanism that causes hyperglycemia, but I'll not go into his adipocyte theory. It's a very simple thing, twin cycle hypothesis and a personal fat threshold. Okay, I'll simply bring this in because this clearly tells us that when you put on weight, you develop type 2 diabetes. Simple, positive calorie balance, increased liver fat, resistance to insulin suppression of glucose production, increase in the basal insulin secretion. So this cycle is on the liver side. Then you also have increased triglyceride and the subcutaneous fat storage capacity is exceeded. So the fat gets into the islet cells, so there is a decreased insulin response, and that's a pancreatic cycle where you have postprandial hyperglycemia, and with the plasma glucose levels increasing, then again you have increased basal secretion. So this is the twin cycle hypothesis, which clearly tells us that there is a positive calorie balance, and there is hepatic fat, and there is pancreatic fat, and you have type 2 diabetes. And what is this personal fat threshold? Now this is interesting, and this is where all the researchers can actually come in and contribute over a period of time. It is a concept that type 2 diabetes develops when an individual acquires more fat than the individual can tolerate, even at a BMI which is in the non-obese category or range. Now, type 2 is a disease of overnutrition, positive calorie balance, and each person has their own level of liposusceptibility. And there is a potential for reversibility is independent of the BMI. Now, on the scatter graph on the right side, right on top, only the red dots. Now, the middle one is, what you see in the blue here is the same set of patients as the first set before they put on weight. Okay. So when they put on weight, the shift to the right happens. And the bottommost is a very interesting theory that if you have three groups of people, extreme left, underweight, in the middle, normal weight, and on to the right, overweight, a shift in the weight to the right actually triggers type 2 diabetes, irrespective of your basic weight. So that means each individual has his own or her own level of liposusceptibility. All right. Now, there have been a number of strategies to prove this. The first one is a simple negative calorie balance, diet, exercise, weight loss of 15 kgs or more, and that's the weight loss required for your remission. It's far greater than what is needed to control diabetes with medication. So, if you want your HbA1c less than 5.7, if you want to get rid of the tablets, if you have to maintain it, the weight loss has to be at least 15 kgs or more. Anything less, well, you can still control diabetes very well, but then it's not called reversal. So, type 2 diabetes and remission, very simple. You put on weight, then you lose weight, and then your blood sugars start to come down. And if the weight loss is more than 15 kgs, it's absolutely brilliant. Now, another interesting thing happens as you start losing weight. There is normalization of the functional beta cell mass, and this is being shown. And the improvement in the beta cell mass, the first phase insulin release, all that has been shown. And this is after the bypass graft, the bariatric surgery. All this has been shown that clearly you lose weight, first phase insulin release is there, functional beta cell mass actually improves by almost 100%, your insulin release becomes normal, and again if you put on weight, all this becomes bad. So the second evidence, of course the first evidence has come from bariatric surgery, then the low calorie diets and a very low calorie diet, a very low carbohydrate diet of less than 50 grams, which is very, very difficult, but then you can try it out on some patients. In the bariatric surgery, whether it is RNY or gastric bypass or a sleeve gastrectomy, the initial type 2 remission rate is up to 80%. Long term, 5 years is about 30 to 40% remission. And this is the mechanism by which it works. Now let's just look at this counterpoint study. This is quite interesting. 600 kilocalorie liquid diet, non-starchy vegetables, 11 people, 8 weeks, weight loss was 15 kgs. That is about 15 to 20% of the body weight. And on the right side where you see all the graphs, the decrease in the fasting plasma, the basal hepatic glucose production came down, and the liver triglyceride content actually started to drop. So that means you can make somebody lose weight quickly and you can reverse all the metabolic changes of type 2 diabetes. And then you have a counterbalance study. You have a counterpoint study and a counterbalance study. 30 people, duration of diabetes 6 months to 23 years, 800 calorie diet, 8-week study, weight loss of 15 kgs. Now 40% remission in 8 weeks. You follow them up for 6 months, 43% remission. Now remission persisted in those who had no weight gain at 6 months. Obviously, again, if you put on weight, again your metabolic issues start coming down. And on the right side, ABC, you can see all the parameters coming down. Now there's an interesting direct study, diabetes remission clinical trial, 306 people, less than 6 years, 800 calories. 1 year remission is 46%. 2 year remission is 36%. Now, there is also the question of how fast is the response to caloric restriction. Now this is very, very interesting. Reduction in hepatic gluconeogenesis, normal fasting in 7 days. Reduction in intrahepatic fat content by more than 30% in 7 days. Improvement in first phase insulin secretion, 8 weeks. Normal beta cell function, more than 5 months to a year. So, it is possible to give this kind of a calorie restriction to make them lose weight and to reverse the metabolic changes. Now the question is, can we do it in real life? Can we do it in our patients? Research has proved that it is possible at this level to actually make changes. Now the factors of success: less than 5 kg weight loss, remission is only 7%. More than 15 kgs weight loss, remission is 86%. And duration of diabetes is a very important thing, because the capacity to recover decreases with increased duration. That means if somebody, you try this remission in him after 7, 8, 9 years of diabetes, the success rate is not the same as what happens in the first 1 to 2 years. So if the diabetes is more than 8 years, there's only 21% remission in the counterbalance study. And the baseline beta cell function is something that's very important, and unfortunately we can't be measuring it in all of our patients in the clinic. Baseline hepatic and pancreatic fat. Now this is where I was coming that looking at Sandeep. Is there a way in which we can measure? Okay, if there is a way, I mean, especially the baseline hepatic and pancreatic fat, I think this can be a national level, research project that everybody can participate, and then try to see what happens if there is weight loss in such patients, and who responded, who did not respond, and things like that. Okay, so that will be a great lecture to listen to anyway. The conclusion is, okay, type 2 is potentially reversible metabolic state caused by excess intraorgan fat. Why does the liposusceptibility change in individuals? There's a question mark. Maybe genetic, or maybe we don't know, or I will look for answers from the other leaders here. And remission can be achieved with a negative calorie balance and substantial weight loss. But can they continue the diet for long periods of time? Now that's the big questions. And before I close, after 2020 Diabetes India conference that happened just before March, end of February, Dr. Sanjay Reddy, who was actually another 10 kgs more or 15 kgs more, had a long chat, again went into a serious diet, and then lost 24 kgs. 24 kgs in 4 to 5 months. And then the COVID happened. And then the disease came. Andhra food is very tasty. Everything happened. Okay. And I had gone through the same thing, put on weight, and then in 6 months I kind of lose weight. And again it's a yo-yo effect, and invariably you end up eating, or you find excuses to eat. So the long-term remission requires a continuous effort, motivation and support. That's the most difficult thing. Anyway, all the best to all those who are making the apps. Anyway, I don't believe in any of these apps which can actually do that, but a huge amount of money is being spent. The valuation of this app is so many crores, that app is so many crores. I hope things will settle down over a period of time. So thank you very much.
Thank you, sir, for this crisp discussion and dissociating the facts from the myths. So I'm sure there should be some questions from our audience. So we'll put it to our audience first. If there are any questions, comments?
15 kg is for people with average weight of 100 kg.
Sorry, sir?
15 kg weight loss is for people who started with 100 kg.
Correct. So it was
Our people are going to be between 60, 70.
70. Yes, I think that.
And as I said, 2/3 of our young type 2 diabetic patients, where it would be very interesting to do this, were severely insulin deficient. And of course, so I'm actually collaborating with them. We are going to do a trial called Indirect. It's Indian Direct trial.
Right.
But I am very careful at my age. So I'm going to do a feasibility and pilot to actually test these ideas, because that hypothesis we had written about what he also mentioned, capacity and load, which starts from intrauterine life. And if you see our paper, nobody seems to read our papers. In December diabetes care, we have a big paper on pre-diabetes in our cohort. 30% at 18 years of age, with people who had average BMI of 19. So it's a very different thing we are talking about.
Yeah.
And very interesting thing is 30 years ago I had, like many other things, a brilliant idea of measuring intra-abdominal organ size in utero. And today I can also give what a reward. Those who had pre-diabetes had slower growth of the liver in the third trimester, but they had a relatively larger size at 18 years, though it was not a fatty liver. So we are now describing something which is even preceding the fatty liver, but it's all driven by intrauterine poor development of the organs. So they are dealing with end-stage disease. I am more fond of primordial prevention, and therefore in 10 years time we might have actually improving maternal nutrition to improve intra-abdominal growth of the aliens, so that that fat threshold increases. Yeah, so this is all a clinic driven thing, but community based thing will be primordial prevention and resetting the whole mechanism.
Yes, please.
Sir, in clinical practice, we see like they have come with 6.5, 7 HbA1c, and after counseling 3-4 months of therapy, they start touching 5.5, 5.6. So we wait for a year to see if it's a remission. Then how can we proceed further to stop the drugs and see if they are bouncing back or they're...
No, I mean, if they're intelligent patients, many times, if it's just an SGLT2 with metformin, some of them, themselves have actually stopped the medication and they may even lie to you. Okay? Now, when once the HbA1c comes down, the initial weight loss of 6-8 kgs is happening with SGLT2, you can definitely stop and see what happens in that patient. Okay, and many of them, as long as they are motivated and continue to exercise, and as long as they don't put on weight, they remain in that same situation. I think that has happened in C. But again, there are so many festivals and so many marriages and so many relatives come and go. There is always a very standard excuse for Indians. No, I never wanted and somebody forced and so you find all kinds of excuses from India. It's very difficult to stay away from this. Food is a way of life for Indians. We're all waiting for dinner today. Okay, so it's like it's a way of life. So when you're having breakfast, you're discussing lunch. Then you're having lunch. What is happening? Yes.
So what about ghrelin?
Which one?
Ghrelin response, because sustainability of diet. All right,
I mean, what I've read about ghrelin response is only from some of these studies, but I mean, I haven't done any of this. I'm sure ghrelin response, if I think he has done it. What ghrelin response I can only quote from...
very easily, Elijah kits are there.
Yeah.
Okay. So I am doing left-wing adipose acting. In fact, COVID was cytokine was done in my lab because I was doing in diabetics.
No, after you do this ghrelin levels, how do you measure satiety? That changes so much from person to person. How do you measure satiety in clinical practice?
These are all peripheral measurements, and what you measure in circulation is only a broad indication of what's happening there.
Into the brain, okay.
Yeah. But I think what
really question is
in Indians at a body weight of 60, are we able to cause a remission, and how long will it last? I mean, the real question, like you very rightly said, how long will it last? Because I have seen patients for last 40 years who are very vigorous. First 3 months, 6 months, UK PDS का देखो ग्राफ कि पहले नीचे जाता है फिर ऊपर जाता है. So that's true everywhere. Now we are using words which are very attractive. Yeah. So,
doctors are using the words, but someone else is making the money.
Exactly.
So I am raising one point. When you advise diabetes remission to a normal patient, normal BMI, not for most patients,
That's exactly some of these trials have shown, even with low body weight. That's what Sir is now going to try out. Low body weight patients with a 19 BMI, normal BMI of 23, and even higher BMI. If they have diabetes, I think diet exercise has to help them in some way or the other. If it is not helping to at least reverse a remission, that means the beta cell reserves are very low. I think you should put them on diet and exercises. All the patients.
I'm raising one point here.
Yeah.
How can we increase the capacity to hold the fat? That should be the right strategy. What this white is working nothing but increase the load, and he has seen a benefit. Obese state is something which nobody can change. Obese state is linked to your satiety as well your sense of pleasure. Any medicine that on obese state and suppresses your appetite will lead to suicidal tendency. This is a law of nature.
I mean, two questions. I mean, I always wanted to know about this satiety. I mean, why the hunger is so much for one group and not so much? I mean, you can measure ghrelin and other things. I also don't know why the hunger actually increases in pregnancy. So you can tell us. I mean, is it just that there is another fetus which is growing, and is that the need to eat more that improves the?
It is very nice work from MD. It is done by London School of Hygiene, Andrew Prentice. They have set up a unit there for last 60 years. And one of the most interesting epigenetic programming by maternal undernutrition, and which is what I call hungry fetus, is MC4R receptors in the brain, which are the melanocortin 4 receptor. Now, if you go to last time, 19, Steve O'Reilly, he talks of mutations in these genes which produce extreme phenotypes. But intrauterine undernutrition produces an epigenetic phenotype which, if it is hungry in utero, remains hungry for the rest of the life. That's what you're asking.
Yes.
So if you can actually map this, then we can, if it's a girl who has a baby, when the baby comes out, and then we can tell the boys, be careful, don't get tired. She can be hungry not just for food, for so many other things. So we can do mapping there.
Gopalan oration 2 years ago was called The Story of Hungry Indian Fetus.
Nandita, you have daughter or sons? Okay, so we'll have to map them now and we'll try to see.
So, again, the solutions you are trying to discuss at end stage in clinic, which is attractive to earn money, or the profession. I am talking of a community solution which will try to solve the problem. And there is another thing, if by treating in clinic, you are dealing with the extreme right features. We want to shift the compliment that Jeffrey Rose approach. If you do this, millions of people will be affected. Here, you might be able to help them.
And this is Sandeep, I think just like RSSDI, we're all a part of the research group there, and then there's a huge amount of minds there. Even Diabetes India is also setting up advanced group so that there will be not basic research. But this is exactly what
Yes, Mr.
And we want the basic research to be
I'm in conference, so
basic science.
is there anything urgent? Because I'm in conference right now. So can I call you free time? Sure, okay. Thank you.
Wonderful informative discussion. Now we move on our third talk, which is very important in your clinical day-to-day practice, the secondary diabetes and LADA. And for that, I invite Dr. Sanjay Reddy from Bangalore. Dr. Sanjay Reddy is MBBS and MD in General Medicine. He is a consultant diabetologist at Center for Diabetes and Endocrine Care at Bangalore, and also consultant diabetologist at Fortis Hospital, Cunningham Road, Bangalore. Over to you.
Thank you, Chair. Thank you, Chairperson. Give me a minute. Thank you, Chairperson. And my talk is different. It's not a weight, which I like to love to talk about, and also talk why we fail so badly with all the diets present. I reviewed sometimes 16,000 different types of diet.
I think over the years, at this, we get more than 50, more than 5 crores, 50 crores of Google hits, something like that on that. But this is something else. I'm just going to do a clinical talk based on what we have. But in today's clustering of diabetes, which is more prominent, I don't know how the relevance of LADA, but you have to know it. The reason is, a lot of patients who come to us, first and foremost, I remember all teachers telling us, take a good history, take a good family history. If you want to look at monogenic forms of diabetes, or you want to classify some of the diabetes. But over the years, now we've learned a lot of clustering which is there, and sir's new paper, I've not read it, sir, no, but you told me the 60%, whereas in some other studies, the severe insulin deficient type is almost 22%. Now, LADA is latent autoimmune diabetes in adults, which is often diagnosed in individuals who are older than the usual age of onset for type 1 diabetes, often mistaken to be type 2 diabetes, progresses to insulin requirement within 6 years, and could be prevalent 2 to 12%, but I think with, maybe more than that in our population. I'm really not sure of. There are papers earlier, but the data still says it's around 12%. Now, how do you distinguish in the clinic if it is between LADA and type 2 diabetes? These are some pointers over here. Age of onset is usually about 30 years. Type 2 diabetes I'm not going to talk about. You all know very well. Family history could be negative or positive. HLA susceptibility is increased. Subclinical, rarely acute. Likewise, if you look at most of type 1, sometime can present acutely. Rate of long-term complication at diagnosis is low. Rate of acute complication at diagnosis is low compared to type 2 diabetes. C-peptide level at diagnosis is decreased, but still detectable. Ketosis is rare. There's increased insulin resistance, so sometimes no change. Beta cell function definitely is decreased. Insulin requirement greater than 6 months after diagnosis. Body mass index normal. Rarely overweight or obese. These are the 10 individuals. So if somebody is coming with a low BMI, whatever age group, please suspect LADA. That's very unique. In our patient, you have thin type 2 also, but suspicion of a patient walking with a low BMI should always be there for LADA. Increased cardiovascular risk, and anybody with hypertriglyceridemia to normal triglyceridemia, but most important is the BMI. Now, what is the etiology factor? As I was telling, it's autoimmune. So if you have a genetic susceptibility and all the genes present this side, and all the lifestyle factors, definitely this is something similar to, it's sometimes called 1.5 diabetes, because you don't know whether it's 1 or 2 and in between. So if there is islet cell autoimmunity, then insulin deficiency, they may be insulin resistant or may not be, but most of the drugs used, some of the drugs which I'll tell you later, used for diabetes, for LADA, work. And so the pathophysiological mechanism, as usual, there should be some specific trigger, or it could be a low-grade infection, and this causes insulitis, GADA positive, or islet cell antibody positive, insulin deficiency, and impaired insulin action. Now, this is the pathogenetic feature. It can overlap anything, type 1, LADA, normal, type 2. So it's very confusing for the day one to make a diagnosis without following the patient. If you follow this patient going to come back to you and you follow them, then you could suspect. But a lot of clinics measure GAD antibodies as routine. Many centers measure GAD antibodies as routine. Now we have a smaller, affordable machine which we use now, and it's cheap, so you can measure GAD antibodies. Unlike earlier days, you need to use bigger machines and very expensive to have at the clinic. C-peptide and GAD can be measured in point-of-care devices, which are fairly accurate. I'm not telling they're in comparison with the third-generation chemiluminescence machines, but if you use them, and you can in the clinic, we'd use that, but preferably a fasting and a stimulated C-peptide. But even a fasting C-peptide will do, C-peptide and GAD antibodies, but make sure that the fastings are well controlled if you want to do that. need not make the diagnosis in the day one he's coming and sitting in front of you. Take your time, depending on his A1C, treat him, and then later you can follow up. LADA involves both autoimmunity and metabolic derangements of insulin resistance. Now, these are common symptoms of, they're nothing different in presentation than a normal this one, but if this is the diagnostic criteria set up by the immunological division of the Diabetes Society, 3 specific criteria: age more than 35 years, positive autoantibodies to islet beta cell, insulin independence for at least the initial 6 months after initial diagnosis. So this is one thing. But remember, if your LADA patient also can come to your clinic, a clinical scenario where you come with A1C of 12, maybe you want to give him insulin for 6 weeks, but then shift him over to tablets. So, so this criteria are, but that means he can be independent of insulin. You can use insulin in the beginning if the A1C is high, but if he's 6 months off insulin, this is what it is. I'm not going to go here. So this is an algorithm helping you to say, when do you suspect? If you suspect LADA, most important is age and BMI. And if there are any other autoimmune disease and clinical presentation is similar except for the BMI, I don't see anything different in LADA patients in clinical practice. This age, BMI are 2 things which strike. And if you measure GAD antibodies, and if they're positive, measure C-peptide, and then you can decide what you want to do. Now, treatment, they respond to metformin, they respond to glitazones. You can treat them with DPP-4 inhibitors, but eventually you will require insulin. So these 4 things are proven. There's data among all of this. I'm not going to go into details with paucity of time. Sulfonylureas, everything can be used, but SGLT2 inhibitors, there is no data as such, but rosiglitazone is the only studied in LADA, and it did have promising effects, but it had ultimately to be pulled off. That means you can use glitazone too. So SGLT2 inhibitors have not been studied in LADA. However, some case reports of euglycemic ketoacidosis have appeared. Therefore, this category right now is there's no recommendation. We can also think of now complications are similar, but they have more neuropathic complications. Please remember this. So in summary, suspect LADA in a patient who's young, 30 years and above, but no family history, not very typical type 2 diabetes, but comes into your clinic, and if he's first 6 months, if he doesn't require, and then they may require insulin very early. So suspicion is the key, and looking at these factors. But apart from that, nothing. And the other thing is, one is the most important: suspect, look for, and if you can measure GAD antibodies, majority of clinics do it, and that helps them actually even in the initial phases. But if you're following the patient carefully, you need not make, as I told you, a diagnosis initially. You can get to there. Now, secondary diabetes is like, now most of the secondary diabetes is apart from type 1 and type 2. Anything you think of, or any condition which leads to hyperglycemic state, is secondary diabetes. So these are the causes. Now we have pancreatic causes. You have abnormalities of the endocrine pancreas and the endocrine gut. They are all the glucogonoma, stomatitoma. I don't know how many we see, but most common things which you see are pancreatic disorders, probably liver disorders, the genetic syndromes associated with this, or an endocrine excess, endocrinopathies like acromegaly. They are all less than 1%. Even all the hyperparathyroidism or hyperthyroidism is one which is more common. So if you see these, think of secondary diabetes in them. So if you have a patient with hypothyroid, make sure that you're measuring glucose regularly, or any of these other things, other syndromes associated with diabetes. Let me go to 2 things. Acute pancreatitis, very important if you have to pick up. Now the suspicion of pancreatitis, many of the time pancreatitis is missed, especially chronic pancreatitis, mistaken as gastritis and keep on treating with some abdominal pain, but please look for malnutrition and so on. But acute pancreatitis, hyperglycemia has been correlated with tissue necrosis and higher mortality. And usually subjects within weeks of the acute attack will become. So if you have a pancreatitis, maybe you may not have during the admission, it goes back home, but make sure you follow this patient for development of diabetes. 24 to 35% of patients have glucose intolerance, and 12% have diabetes mellitus following a single bout of pancreatitis. Now, recently I was talking to a pediatrician friend. He told me we're seeing a lot of pancreatitis in post-COVID in children. There was a sudden increase of pancreatitis which happened over there, but I don't know if the data is there. But this was a general observation. We found pancreatitis occurring in children post-COVID more. So chronic pancreatitis, see here most important thing is ask for somebody complaining of indigestion. So suspicion here, again talking to the patient really helps. And another thing in chronic pancreatitis is alcohol use. If the patient is a chronic, also alcoholic, or there is a lot of alcohol use can cause this. So diabetes caused by chronic pancreatitis requires insulin therapy because of beta cell destruction. Although lack of immunological destruction may contribute to a slower destruction of the beta cells in chronic pancreatitis than in type 1 diabetes with greater preservation of beta cell function. Remember something, appetite in chronic pancreatitis is there, but patient is afraid to eat and because of the pain which develops. Now, pancreatic cancer, this also is associated with abnormal islet cell function by primary alteration of islet cells by carcinogen, secondary damage by cancer cells, or stimulation of islet amyloid polypeptide. So that causes cytotoxicity and apoptosis. So here also, and post-pancreatectomy is another thing. And previously, one of the things, X-ray of the abdomen. Please take this, and we've seen a lot of data. Taking an X-ray of the abdomen to see, especially in patients, if you suspect chronic pancreatitis. That is the simplest you can do. I know that's not the right imaging modality now, but that's the one you need to do. Post-pancreatectomy, so depending on, and cystic fibrosis, not very common, but if a patient with cystic fibrosis is there, early in the course of the disease, the beta cells may appear normal. The idea is to put up all this is to see that these patients are followed up to pick up diabetes earlier and treat it early. And early insulin use is better in them. Hemochromatosis, again, I was PG teaching, if you have patients, usually we get these patients from the neurology ward or a gastroenterologist who worked up for hematochromatosis, and these patients are referred to you. So please make sure you have them. And then all the hepatitis. So these frequency of pancreatic disorders are acute pancreatitis, chronic pancreatitis, all of these, and the development of diabetes and all these pancreatitis very high. So please keep a watch on them. And I'm not going to go much into the endocrine tumors of the non-beta cell of the pancreas or the gut that cause glucose intolerance or secondary diabetes. Mention some of them. So now carcinoid, NFLD, no, this is hepatitis C, even chronic hepatitis, please make sure. But one thing I want to mention, drug-induced diabetes. I think this is very common. So please note and keep, one of the commonest thing you get is steroid abuse, but look at all these, interferon, cyclosporin, diazoxide, pentamidine, HIV, protease inhibitors. You have patients coming in with retroviral, oral contraceptive pills. Now, they also have contributed to these beta blockers, which we all know, thiazide, calcium channel blockers. All of them have been implicated, but keep an eye on this. So I'll make a comment here. Acute ingestion of alcohol has been associated with hypoglycemia due to its inhibitory effect on gluconeogenesis. The effect is seen in fasted individuals with depleted glycogen stores who are dependent on gluconeogenesis to maintain hepatic glucose production. Acute large alcohol intake can cause insulin resistance peripheral tissue, particularly in the muscles. When ingested on a chronic basis, excessive alcohol intake has been associated with moderate to severe insulin resistance and glucose intolerance. So beta-arrhythmic blocker, I'm not going to the endocrinopathies, and I just like it becomes like this. I'm going to give you a lecture on just a rewind as to say that we should not forget secondary diabetes, LADA. They're all important parts of classification of diabetes. So I rest my case here. Thank you very much.
Thank you, sir. Thank you for highlighting the very salient points on, and I think LADA is something that we often overlook into our clinical practice. So just because of the lack of time, we can take one question from the audience, if there is any. All right. So if there's not, sir, just a quick summary from your end again for primary clinicians as to what should be the
most important thing is never forget the basis of medicine. Please put down what drugs he's taking in the past. First one, look at his BMI correctly, family history, and third, it is not necessary that you make the diagnosis in one go. Treat the diabetes first, follow it up, and then probably will come, the story unfolds better over time. That's what I can tell you.
See, there's an interesting example. British Prime Minister Theresa May was treated as type 2 diabetes for 3 to 4 years after diagnosis and then found to be GAD. So she is the best known example of that.
And GAD positivity can there is studies which I think Dr. Prasanna also published earlier during, but I don't remember how many percentage, if anybody can remember how many percent of normal people.
Normal people we're just now doing it, then each Bhatia is doing it in HGPCR, and we have now realized that our cut points for GAD, IA2 and zinc will be different.
That's an interesting outcome because the earlier studies which I looked at GAD antibodies did show that normal people had, and now nobody followed them up, we don't know what happened to them. So it's around some 12 to, I really don't know the figure, but it's around 12 to 14% of like anti-TPO antibodies can be present in 20 to 26% people. So we don't, and that could be the reason, the cutoff for the GAD.
Yeah, therefore diabetic person who also seems to have a falsely positive GAD can be labeled as LADA. That's Andrew Itis' idea.
Oh.
He doesn't believe in LADA at all. But Leif Group, my other collaborator, is the one who did his PhD on this.
Okay.
So there are people who come from different angles. But for Indians, we need to define population prevalence of these antibodies before we accept results of the Western kids.
And also the methodology how we measure GAD. There's a lot of change in the way they're doing it in the past too. Yeah. So I think now we can measure even very minute quantity which was not there in the past. So thank you. But for those who are interested, there's a point of care machine to measure GAD. Not expensive, it's sensitive, yes, sensitive and also.
You name the machine.
And give you a minute. I can use it later.
They are not sponsors with diabetes.
Very valid question. They're not diabetes reversal. They're unable to sell the machine because if small clinics can't afford bigger. I used to send my GAD antibodies outside, and it takes only 20 minutes to get it. So that's why there's
What was the cost and fraud-based cost?
Sir, cost of the machine was 1.5 lakh, and the cost of the strip was something like 400 rupees to 500 rupees. You can Google, you can talk to Dr. P.V. Rao. Actually, he's the one. The company's name is Proteomics. It's a US-based company which has an office.
Okay, thank you. Thank you everyone. Now we close the session and move on to the next session, and for that I invite the chairperson for next session, Dr. P.G. Sundaram from Chennai and Dr. Isisa Sachdev from Mumbai. Good afternoon, everybody. First of all, I must thank the Diabetes India, the organizing committee, who's giving this opportunity to be here for you. In fact, clinical debates is to enrich our knowledge, and these debates will definitely pave way for better understanding and also to evolve the treatment of these conditions. So the first topic will be introduced by Dr. Rishika.
So technology is constantly evolving. Now, what is in practice today might not be tomorrow. So let's have a very interesting discussion between Dr. Arun and Dr. Jimit. Dr. Arun Raghavan, he's a consultant diabetologist at Dr. A.R. Chandran's Diabetes Hospital. He's received multiple awards for his contribution, and especially his contribution during the COVID times. Dr. Jimit is fellowship in endocrinology, diabetes and metabolism, and he's practicing at Surat. We welcome you, sir.
I think I'll just highlight how we proceed this. Each speaker will be having 10 minutes of his talk, and about 1 to 2 minutes of rebuttal. We can have 2 responses for the talk and final conclusion after that. So total 25 minutes. So I think Dr. Arun will start. After the technical clauses.
We can talk about technology. Something is wrong uploading.
So can we go for the talk against it?
No, second debate, whole session.
Okay, we go for second debate.
Yeah. No, how can you do it reverse? Yeah. Reverse, you can
education for the speaker, so how he reflects and how he takes on.
What's happening? 2 minutes? No, go. No.
It's okay.
What are you doing?
Thank you, chairpersons. Thank you for the introduction to the topic. And at the outset, I would also like to thank the organizers of Diabetes India of giving me this opportunity. So the topic that's been assigned to me is whether do we need blood glucose monitoring in an era where we have the flash glucose monitoring, Cgms have flashed into the scene, and indeed they have transformed diabetes care. We were also discussing about certain platforms, apps that are heavily hinging on this technology, and there are some million-dollar startups which only rely on Cgms. So we do know that they have transformed diabetes care. But is it fair to say that they can completely replace blood glucose monitoring? Perhaps not. So on that note, I think all of us are aware that blood glucose monitors have been used in all major glucose lowering trials. All the glucose lowering trials have used as a core component of effective management of diabetes. So on that note, let me take you back in the memory lane. Glucometers have been around for over half a century. The first glucometer is shown in this first image, which is AMS reflectance glucometer, which was developed by Anton H. Clemens. Interestingly, the first reported patient, the small story to it, who used it was Richard Bernstein. This gentleman was so fascinated with this glucometer. He was a type 1 diabetic patient. With a lot of trial and error, he started adjusting his insulin dose, and then he became accomplished in managing his own disease. And then, to his dismay, the medical fraternity did not listen to him. He said blood glucose meter is extremely useful in managing medicines. Nobody listened to him, which in fact prompted him to pursue a medical degree, and finally he published a lot of papers, subsequent to which AD also accepted as a standard of care. And this is the gentleman himself. He's about 87 years old, and this itself is a testament, validation in the fact that glucometer was indeed a life changer for him. So this is Richard K. Bernstein. And he still, suggested he has written a lot of books and papers on blood glucose meter. So who needs a glucose monitor? Pretty much all patients with diabetes. However, type 1 diabetic patients, all of us, if I see a patient with type 1 diabetes, the first thing I tell the patient is that you have to get a glucometer, because it is a very important critical part of any journey, any patient's journey with type 1 diabetes. However much data that we could have, the glucose meter is only going to help the patient to manage disease more effectively, and sometimes they learn the craft even better. They learn to monitor the blood glucose depending upon their food intake, exercise, so on and so forth. And obviously this gives us way more variability, variability in patients with type 1 diabetes. Type 2 diabetic patients, the data suggests that patients with secretagogues, insulin, there is a lot of data to show improvement in outcomes. However, in patients with non-hypoproducing agents, there is not much of data, but still we know for a fact that it could still be useful in patients who are even on incretin-based therapies and metformin, so on and so forth. However, in patients, as I said, who are on insulin, who are on secretagogues, with the hypoproducing agents like sulfonylureas, they should have a glucometer. And of course, in patients with pregnancy, stringent targets are always enforced, and again, glucometers are used. Now, coming to the main fundamental difference between a blood glucometer and a Cgms. Now, interstitial fluid is where the sensors are, right? Because the monofilament is about 5 millimeter, and the filament survives longer in the interstitial fluid than in the blood. So that's why we have a little different technology here, and all of us should be aware that the truest number of glucose levels is in the blood. The blood glucose meter reading from a blood sample gives us the most accurate glucose reading. However, glucose over time diffuses out of the capillaries into the interstitial fluid, where a Cgms then can read it. So there is always a delay, at least about a 15 to 20 minute lag. So it is not always accurate. It gives us the estimation, but it is not accurate. And BGM, CGM numbers are more likely to be different in an hour or two after eating, when blood sugar is quickly rising or falling. So particularly in a patient who's exercising or frequently eating, there you would have more fluctuations between BGM and CGM, particularly when there's a lag. And coming to the glucometers, the FDA as well as the ISO gives us about 20% of variation, but today's glucometers are much more accurate. The percentage of variation is very, very less, up to even about 5%. There are glucometers which have only about 5% variation in today's era. So Where we need increased accuracy is patients who have hyperglycemia unawareness, patients who have, again, we've seen through this data, patients who are pregnant, patients with the history of severe hyperglycemia, and more often these patients would need more accurate glucometers. So some information on what impacts blood glucose meter accuracy. Manufacturing defects as well as test strip lot-to-lot variations can also impact blood glucose meter accuracy. And the other factors which could also influence test results would be competing blood substrates such as maltose, vitamin C, uric acid, galactose, acetaminophen, ascorbic acid, as well as environmental issues such as cold temperature, high altitude, other contaminants in the skin from food sources and lotions. All these could actually impact the test results. So this is another important information. Although we have devices which are approved, there is a study to show that more than 40% of meters actually failed to meet the standard at which they had first gotten approval. So this is something that we have to be aware of when we use glucometers. Yearly once calibration is something that perhaps is required. I'm going to show you some data to enforce how glucometers have played a role, blood glucose monitoring have played a role. Frequency of SMPG correlates with HbA1c and acute complications in children and adolescents with type 1 diabetes. So in this study, more frequent SMPG in fact improved outcomes in terms of HbA1c reduction in patients with type 1 diabetes. Similarly, structured self-monitoring of blood glucose also significantly reduced A1C levels in poorly controlled non-insulin type 2 diabetic patients. And another data to show a stronger association between frequency of self-monitoring of blood glucose and A1C in type 1 diabetic patients. So there's multiple data, and there is also this suggesting that Cgms cannot be used as a replacement of glucose meters because it does not satisfy the conventional performance goal set down for in vitro glucose measurements. So this shows you the accuracy between the blood glucose monitoring and Cgms. Now this shows, compared to the plasma sample, pretty much on par. The blood glucose meter readings as well as the plasma samples are pretty much neck to neck. Whereas if you look at the graph, the comparison between Cgms as well as the plasma glucose, you can see it is quite varied. So that's the difference. That's how accurate blood glucose meter is compared to the Cgms. So interstitial fluid glucose is just not a shifted in time, but it just gives you a distorted mirror of blood glucose. So finally, let's look at some benefits and comparisons of SMBG, CGM, and FGM. SMBG is indeed time-tested, very, very cheap, very accurate, and one of the biggest challenges of CGMS is the retrospective device perhaps is cheaper, but the real-time CGMS is extremely, extremely expensive. Not many people, at least at this point in time, can afford it. And the sensor life is also quite short. We do have some in the pipeline, such as Eversense, which could give us data for even 6 months, which can be implanted. So that is going to give you about 6 months data. But at this point in time, we only have technology where it gives you data for only a few weeks, and it's extremely, extremely, extremely expensive. And that is one of the major limiting factors for CGMS use. And this is some data that we've already seen. And the US FDA has also recommended that if CGMS is inaccurate, including whenever there is a suspicion, we have to rely on glucometer. So glucometer cannot be at this point in time replaced by CGMS. And to finally conclude, I think we have the resources and technology today with us, and we have to use all available technologies and resources to improve patient outcomes. And at this point in time, I think both blood glucose meter and CGMS can be complementary to each other, and that's how we'll have to go. And to conclude, I think, yes, indeed, we still need blood glucose meter in the era of CGMS. Thank you.
Thank you. Dr. Jamitsa?
Yeah, thank you, chairpersons, for the kind introduction, and thank you all the organizers of this wonderful conference for inviting me to speak here. Let me let me just load the stop working. Yes, sir. Yes.
The computer is the fighting mode.
Yes. So I'll be discussing no to the answer. Do we need blood glucose monitoring in the era of CGM or flash glucose monitoring? My answer is no. Yeah. So Dr. Arun has already mentioned some of the pitfalls, but he clearly said that both these technologies, they complement each other. So I also agree in the initial part of my talk only that they both agree. They complement each other. So I'll be discussing very simply and very fast advantages over BGM, okay, in glucose monitoring itself, and what are the additional advantages over blood glucose monitoring in our glycemic management. So definitely the first disadvantage is what we all have with BGM is it's really painful. Okay, whatever fine needle you will take, it is going to be painful. And remember, those type 1 diabetes children, those pregnant women, they have to prick many times a day, and that will be a very troublesome for that lady or for that mother to or that child himself, and a psychological trauma also. On the other hand, we all know CGMS virtually painless initial administration. Later on, it is painless virtually at all. Also, it can lead to non-compliance whenever pain is there. Okay, remember all our children are told कि बच्चा ठीक से रहो नहीं तो आपको सुई दे देंगे, इंजेक्शन मार देंगे. So everyone is afraid of pricks from their childhood. So whenever there is a pain and pricks, it leads to non-compliance due to this psychological barrier. And this non-compliance can eventually deteriorate your glycemic control also. And very importantly, it can lead to hyper or hypoglycemia also. Also, BGM or the SMBG is still a very difficult task to perform, especially if you take the elderly, if you take the patients with neuropathy or retinopathy. It is a very difficult task. You can see there are a number of steps involved in a single SMBG, and it's very difficult. On the other hand, if you take CGMS or flash glucose monitoring, it's very easy, just touch with your device, or even with the newer advancements. Okay, you can directly have your blood glucose level flashing on your mobile and with the hypo alerts also. So it's very easy nowadays. Also, it's not always accurate. The accuracy standard also, Dr. Anu himself mentioned what are the conditions which affects the accuracy of glucose monitoring. And very importantly, he said about the accuracies, but our Indian scenario is totally different. We have so many companies with, I would say, not substandard, but less accurate glucometers, and the variability is huge with all glucometers that are not from the reputed brands or the US FDA approved brands. And the costlier one, which are more accurate, they are not affordable to each and every individuals. And there are also quality of strips and amount of blood put on strip, the time taken, it depends very hugely. Also, very rare nowadays with the advent of the disposable items, but it can cause infections. Very importantly, sharing of glucometers and sharing of these needles can lead to cross infections also. Also, very important aspect of diabetes management is data record and how you convey this data to your healthcare providers. And it becomes very appropriate to use the highly, we have multiple apps we are discussing since morning, apps and data and all those things. And CGMS has digital records and extremely helpful for us clinicians. And also very important thing, I've seen few patients, you can also correlate some of your patients who are willfully entering wrong data also. So this can be avoided. Cost, Dr. Arun has already mentioned, but even a single SMBG from a reputed brand will cost you 20 rupees just for the strip. Okay, the needles and all other things are separately, but don't let money run your life. Okay, let money help you run your life better. Very importantly, glycemic management beyond just glucose management. What are the advantages? So yes, we all know if you just take 4 readings. You can see here, definitely you will find there is just one reading above the target. But if you put on CGMS or flash, you will see the complete picture. Okay. Also, we have seen with the A1C of 7 may not represent the total values. You can see on the right side the patient is in 100% time in range, but on left side you can see there are hypos also, hypers also, and there are only 40% time in range. Trends, very important. If you see this boat with no context, it's like blood glucose monitoring. You don't know where it is going. But if you put a CGMS, you will see that the boat is going towards the danger. So there is a trend. And if you use this trend with a proper guidance and your clinician, you can also divert that boat towards safety and avoid the danger of hypo. This is again a very important when you see the complete picture with CGMS. And whenever you see there is the blood glucose monitoring is always raising down, another is demystifying. If you see a patient is 160 with the BGM, after sometimes they will have one question also, is my blood glucose going up or down? But remember with CGMS you get the trend that your blood glucose level is going down or low. Again, efficacy, hypoglycemia, glycemic variability, time range. So we are moving from time glycemic triad to glycemic hexad. And very important thing is we want to address the glycemic variability because it can lead to oxidative stress and increase the risk of complications. And nowadays we have newer metrics for measuring glycemic variability, that is time in range, that has been discussed a long time from nowadays. And it seems impossible for a single SMBG or BGM to precisely detect either glycemic variability or time in range. So do we have data for time in range? Yes. Same as what the UKPDS and DCCT trials they have mentioned for HbA1c control and the long-term complications. We have data with TIR also. For each 10% reduction in the time in range, you can see the progression of the retinopathy increases by 64%. Microalbuminuria progression increased by 64%. And the any type of pain or moderate pain of neuropathy also increases. And each 10% increase in time in range, okay, also associated with 6.4% lower risk of carotid media intima thickness. Also, the evidences are also gathering now. Few of these slides Dr. Arun showed, they were from 2003, okay, that showed the accuracy of blood glucose monitoring with the CGMS, but those slides were 20 years old. But now we have multiple evidences we are gathering for CGMS. The impact study shows that if your patient uses time CGMS, even type 1 diabetes patient, okay, who are well controlled on SMBG, if you put them on flash glucose monitoring, it increases the time in range. Okay, these are the patients who are already well controlled on multiple SMBG and type 1 diabetes. There, if you put them, you still get further increase in the time in range. Also, it also reduces the hypoglycemia rates who are already controlled type 1 diabetes on SMBG. Also, replace study shows for type 2 diabetes also, it reduces hypoglycemia. Similarly, it also showed reduced hospitalization for type 2 diabetes. Similarly, Russell et al. Also showed reduced in the ketoacidosis rates also for type 1 diabetes. Flash study also showed reduced hospitalization and worse absenteeism in type 1 diabetes and also type 2 diabetes if you use flash glucose monitoring. Similarly, it also improves quality of life. So in last, I would like to tell my good friend Dr. Arun about this question. If blood glucose monitoring will be able to answer all these questions, what time of the day are in ranges blood glucose, what are highs and lows, should medication dose be just be adjusted, at exact what time it should be adjusted, how frequently I am suffering from hypoglycemia in a single day. We have seen tremendous number of cases of undetected hypoglycemia with CGMS. For how long I was in hypoglycemia, how is my daily glucose pattern, how my daily routine is affecting my blood glucose around the day, like exercise, what's going on with food, sleep, exercise, stress decisions, what is working and what is not working in my diabetes management. I just made a change, but did it make a difference? We don't know until we put CGMS. So both CGMS and A1C, both SMBG and A1C doesn't reveal any enough data to answer these questions. So my answer is no, and I thank you everyone for listening.
Can I have Dr. Arun for the rebuttal, please?
Yeah.
2 minutes.
Sure. Yeah.
each other here. So, of course, CGMS gives you the insights, deeper insights, train all of it. But the only argument against it is, can we have CGMS for all patients in India? It is not even approved in the US as part of insurance. Even in a developed economy, patients are not able to afford it all the time. So, particularly in Indian out-of-pocket paying population, I think how many of us who have subscribed CGMS for all our patients with diabetes? You wouldn't have it. I think it might have been possibly 2 to 3% of our patients is possibly on CGMS. So the real challenge is the cost. And the sense of wear time is also shortened. So these are the real two challenges against CGMS. And that's why I feel that it is complementary. We need blood glucose monitors as well. And possibly use CGMS in patients where patients have glycemic variability, hypoglycemic unawareness, where we may have felt, okay, patient's HbA1c is okay, but patient gives us some other history of high and low sugars. These are, the ideal patients whom we have to use this resource and technology. Thank you.
Thank you.
Just to answer the cost part, so we have all seen the evolution of technology. Okay, so phone Dr. Arun is using, that was costing, if you say 20, 30 years back, we were not assuming that we will be using this phone, because the initial mobile phone, like the Glucometer you showed, was costing lakhs of rupees, just for do a single 2G call. Okay. But now we have technology, even the chai wala, pani puri wala is also using smartphone. No? He has 4G inside and he is using it for YouTube. So technology is evolving. We have seen the dramatic reduction in the cost of CGMS. We are not putting CGMS 5-10 years back, but it is now very much affordable. And I'm sure in next decade, it will definitely replace the BGMS.
Any quick response to responsible knowledge, please?
Question. A patient on CGMS, any patient, do you think that sometimes psychologically they start getting paranoid? Okay, every 5 minutes they'll check, every 2 minutes, okay, I ate this, I ate that. अच्छा डॉक्टर ने 2 नहीं 3 रोटी खाऊं. Something like that. Have you seen that in the clinical practice, and how do you deal with that?
So that can be an issue with each kind of treatment. But what you are saying, we can look it in the other way, like educating our patient in this respect. That you tell your patient to check it, and once you get to know that what is increasing your blood sugar level, what is reducing your blood sugar level, next day you can have these resources or have this information to improve your blood glucose level the next day. So that's how you educate your patient and counsel your patient. But as you said, some parallel patients definitely will have this issue.
Yes.
Yes.
Since I'm working in a hospital setup, unfortunately CGM does not come into play in hospital patients. Especially in critical care,
Correct.
I think blood glucose monitoring is the only thing that you can manage. So that part also should CGM does not have any play. Number 2 is that patients with CGM, they cannot do any kind of scan like MRI when they are on. So we do have some issues which
Actually, I didn't find any sparks of fire. Both were complementing each other. It's a quite useful machine, and it is cheaper, and it is done readily available, and it is easily understandable to the patient, and he can do of himself and interpret himself, and accordingly he can manage to a very great extent. But CGMS has its own advantage of going to the profile of the blood sugar, which is inclusive of the glycemic variability, time and range, and what happens in the episodes during the sleep, especially hypoglycemic events. So that is not being taken care by the usual blood glucose monitoring. And also needing assistance, where some company or pharma people or somebody must come inside to understand and give you the profile.
So that is the main advantage of the CGMs. But each are complementary. As I said, it depends upon patient. It's a patient-centric. Which patient you're dealing with, whether type 1 or type 2, or whether the patient needs a particular area where he goes into liquid hyperglycemia or hyperglycemia. Especially if your HbA1c is not very well controlled and blood sugars are very varying and recurrent hypoglycemia. So definitely this patient needs CGMs. But in all the cases, the usual blood glucose monitoring, I think, is easily available and it is done easily by the patient. So both of the machines are complementary to each other and everything is patient-centric and depends upon the situation. Thank you. We will go to the next session where do Indian dyslipidemia needs special attention? In fact, dyslipidemia is a big topic. It has nothing to do with diabetes. It can occur as a single event or as associated with diabetes, and is very well about 40% of the global burden of CVD risk occurs in India, and the Indians are more of atherogenic population, and something happens, the variation of the lipid profile also. So, does we need this Indian attention of the dyslipidemia is going to be taught by Dr. Rakesh Kapoor.
Dr. Raka Shiva.
Sorry, Raka Kapoor, Hindi poet. I'm sorry, you are a Hindi poet. Director, Lifetime Northern Diabetes Hospital, Sarah Northern Diabetes Welfare Society. And you've got a lot of
प्रेजेंटेशन में ये
papers
प्रेजेंटेशन में
and awards.
ये स्लाइड जा रहा है ना, ये तो नहीं आना चाहिए ना।
Achievements.
मैं किया था सर,
And
फिर
we
किया
talk on
एक मिनट
Dr. Raka Kapoor.
फुल स्क्रीन आना चाहिए।
Myself, Dr. Raka Shiva. Actually, it's my father's fault that he has not given me the Hindi meaning. Actually, SHIVHAR is real pronunciation, but because my father was in Air Force, he has copied Kapil Dev, because Kapil Dev is written as DEO and DEB also. So he has given name, and the more time I have to explain myself that it's not Shivo, it's Shiva. So, Raka is a time when Chandra gets cooled, is a nakshatra. So that's the way.
Display. See the three dots. They're trying to get the full screen actually. It's coming in the presenter. Get your 3 files here. नॉर्मल पीपीटी खोल के फुल स्क्रीन कंप्यूटर में फुल स्क्रीन करो।
जी अगर भाई आओ ना, तो मेरा नहीं है
आप पे वो पेज हटा ना, हटा।
So at the outset, I am thankful to all audience and Dr. Vansi sir for inviting us in this great debate. And I think I am very thankful to Dr. Vansi for pleasing me to have given such topic, which I feel that it's setting more of for me, and it's a real battle for Dr. Jayakumar sir. Because so there is no doubt in this topic that Indian dyslipidemia should be taken as a different aspect. Dyslipidemia in Indian, is it different? Why it's not changing?
क्लिक ऑन द स्लाइड, स्लाइड पर क्लिक कराओ ना।
Changing here but not there.
So dyslipidemia in Indians, is it different? Yeah, definitely. It is more. How? Because every Indian is different. The new diabetes, CAG in
You have
2019
pencil
NCCS
is in your pen,
guidelines say that high cholesterol
so
level is
they
not
will directly
one
place
size fits
them
all,
there.
and guidelines strongly establishes that importance of personalized care is the more personalized care, and more personalized care. Every body, every human being has to be taken as a different model from God. So multiple target for CV reduction. It can be LDL, SDL, TGFB, lipoprotein A. But it's time-honored success that LDL target is beyond doubt for CV risk reduction. And why I'm talking about LDL? Because being Indian, we are the most sufferers. Dyslipidemia Indians, is it lifestyles or genes or both? Dr. Yajnik was here. Fortunately, we have a hard discussion throughout the morning walk also, and we are going to quote his statement of YY paradox. And diet is difficult. Dyslipidemia profile seen in vegetarians is totally different. Indian diet is rich in carbs, low in omega-3, OFAs, and that's why we have high degree of acceleration of hypertriglyceridemia. And we all know that Asian Indians are physically inactive. We, from any part of Southeast Asia, we are physically less active, maybe due to fast economic development in recent years and modernization. Genetic factors, we have abnormal variant of ApoC3, ApoE3 genes coming in India, and Indians have more abdominal adiposity. And there is different hypotheses of thrifty genes which other needs to blame for these kind of presentations of dyslipidemia. So how and why Indians are different? Because we are more prone for CST at younger age, more likely to have anterior location of infarction in territory of left main, multivessel, and distal coronary artery disease. Similarly, having lower prevalence of traditional risk factors than with other populations. Prevalence of diabetes is uniformly higher in all of the part of our country. And why? We have enough explanations. We have given the concept of thin fat phenotype to world. LDL particle size tends to be smaller in us. Serum triglyceride highest in urban Asian Indians residing in India, or wherever they are migrant Asian Indians. Wherever they go, they keep their triglyceride level high. Average serum triglyceride level of rural-based Asian Indians is also higher than Caucasians. Lower SDL, LDL with lower SDL levels with higher concentration of small, less protective SDL particles are quite often seen in us. So impaired reverse cholesterol transport have been also proposed hypothesis. So how and why Indians are different? Story continues that altered adipokines may explain why lean non-diabetic Asian Indians have decreased insulin sensitivity compared with others. And this is the same Yudkin-Yachkin paradox, where we have high body fat in spite of having lower BMI. So diabetics and dyslipidemia, this suggests that there are 55 million of patients of diabetic patients in India, and prevalence of diabetes in males is less than what we find dyslipidemia in females. Our females are more sufferers. This is the study from R.M. Parikh et al. From Metabolic Clinic Research and review from 2010. In India, almost 9 of 10 diabetics have dyslipidemia because we have abnormally large adipocyte. If you compare with a South Asian adipocyte with a white Caucasian adipocyte, then you can very well find that large subcutaneous abdominal adiposity size predicts insulin resistance more and type 2 diabetes independent of obesity. This is how we compare our Indian belly with others.
There is a generalized obesity in common in Western population, but we are more fat-bellied than others. So abdominal visceral obesity associated with higher risk of type 2 diabetes and CST generally compared with the Caucasians. So average level of serum triglyceride, if you see Caucasians, Asian Indian migrants, Asian Indian urbans, Asian Indian rurals, slum areas also, we can have high number of triglycerides in Asian Indians, all types of Asian Indians. Average level of HDL, if you compare, then we have bad data as compared to them, other people. Pattern of dyslipidemia in India, we have mixed, combined, isolated single parameters. And if you talk about ratio, then most common pattern among males is isolated single parameter dyslipidemia with low HDL, and among female, we have slighter higher occurrence of mixed dyslipidemia. So Indians are in many ways different, heterogeneous population where atherogenic dyslipidemia prevails, and that's why treatment schedule we individualize. By listening all these, I can see my opponent face who is just searching and planning for this Vanprasth ashram. Is it possible in modern times? Because there is no point to take it counter. But I salute that he has taken such a hard battle, and he will try to prove himself. ACCHA 2018 guideline for cholesterol management have shown that LDL-C threshold values are very important, not given important to SDL-C, triglyceride, and non-SDL-C. Basic principles and intervention, I don't want to go what are the therapy, because my topic is not of therapy, my topic is because that Indian dyslipidemia. So basic principles of interventions remain same, taking omega-3 fatty acids, statins remain effective in reducing LDL cholesterol, and that's why we have proponent of statins and fibrates. Fibrates affect better in Indian subset because patients with high triglyceride levels, when they do not respond normally, then we can have to add. So fibrates turn to be a good fighter in this Indian dyslipidemia setups, and how long we need to go, this we need to calculate from a benefit risk score, and we have enough study data protocols in the backup which can show that lower is the better, because we are when we get accustomed to life from our mother's womb, we are having a very low LDL level, and due to our lifestyle and habits, it grows. We take birth with 20 to 30 milligram of LDL, but when we grow more, we are getting more and more LDL because of our diet habits and epigenetic factors. So Indian dyslipidemia turns to be a crucial indicator for all kind of treatment, and that's why we are getting more cardiac morbidities. And this has been proven undoubtedly in so many studies that if you go on controlling and reduction in LDL concentration with statins, then you are going to get reduced evidence of clinical morbidity of cardiac consequences. So evidence from these LDL lowering therapies have shown enough that we are born with LDL of 20 to 30, but for secondary prevention, lowering of LDL CO2 at any level can be safe. When we are talking about LDL, then we are talking about Indian dyslipidemia, and there we have Indian data which have shown in guidelines, our own guidelines in 2016 has shown, with so many of us here in this conference are the part of this 2016 Lipid Association of India expert consensus, and they have found that risk category with LDL of less than 50 should be target with very high risk. And with high risk, we have to further categorize and strengthen our treatment. If your patient does not respond to non-pharmacological intervention for last 3 months, then we need to categorize more. And this Lipid Association of India in latest 2020 guidelines have added extreme risk category also, where they have opted for less than 50 as a target and less than 30 as a target. So with this listing of these all, my opponent has now planned for pilgrimage, and Mr. Opponent, this is your travel plan. So here comes the conclusion, and I'll take pardon that I'll be in rebuttal, I'll be placing 3 more slides. The slides is here only. So conclusion that Indian population has dietary, physical, and genetic diversity, which leads to different dyslipidemia from Western counterpart. Indians in having lower total cholesterol, lower HDL cholesterol, and greater triglyceride level. The low HDL cholesterol and hypertriglyceridemia are metabolically interlinked, and their combination has been termed as atherogenic dyslipidemia, and that's the cause of metabolic mayhem, of cardiac morbidity in our country, and that's why our Indian dyslipidemia should be taken in account with any kind of clinic, whoever is practicing in India should be bothered and should be taking care of heart of a patient, because diabetics don't die with sugar. Diabetics die with either with the cardiac morbidity or due to renal complications. So statin along with fibrates can be effective choice because of that kind of dyslipidemia. I'll complete my talk. For the first part of talk, my talk is completed. I'll say to chairpersons.
Also against some cross-out patients, I call upon Dr. J.S. Kumar, who is the professor of the Health Department of General Medicine, Medical College Hospital. He is undergone training in endocrinology at Best Children's Hospital in New York, USA, and he has got several international national awards. And he is the member of various societies. I call upon Dr. J.S. Kumar.
Secret is secret. Laptop रखा हुआ। आप मिलते नहीं हो, बहुत सारा ये अलग है तो
I think you need to call your IT guy. Call Arctic and call the IT guy. I wanted one laptop also to be replaced, not this one.
Yes.
Yes.
Now it's changing or not? Change में नहीं होता
Good afternoon. Thank you, Chairpersons, for the kind word of introduction. I really like your talk, Dr. Akash Hare. I think we are meeting for the first time, but I think we have a lot of likings with each other in our thought process. I think ultimately, I think you will conclude that,
You are surrounding.
that you will say, I mean, you agree with whatever. Just give me 10 minutes. I think सिर्फ चंद मिनटों का बात है. We'll soon agree. So the question is that why? I think the brief is very clear. I mean, do Indian dyslipidemia need special attention? The question is that do they require special attention? Probably not. And reason is that I am going to, this is the synopsis, I am going to give you a case. This is a kind of a patient, a person who walks into an office, a 46-year-old man, comes for a master checkup. He has no major symptoms except for occasional breathlessness. He is not diabetic, he appears overweight, he has a BMI of 28, ECG is normal, and his lab investigations reveal total cholesterol on the higher side, LDL and triglyceride, and a low HDL. Now the question is, will our approach towards this patient differ if this patient's nationality has to be a non-Indian, if he has a different passport? The question is that we all know that dyslipidemia, forget about the primary causes which are totally, I mean, they are rare, genetic, but look at the secondary causes is mostly driven by obesity, type 2 diabetes, and probably some medications and physical inactivity. The reason why that Indians are not different, I mean, we are the same because we have not changed from our Caucasian counterparts, because our change in the epidemiology is because of urbanization. And because of that, and because of our access to the medical treatment management has improved. It tells you that our improved the expectancy of life, and hence because of the Baghdad ka Zindagi has increased the stress, and ultimately the changing of the pattern. Now is the time where we have more takeaways than what is being cooked at home. So this led to the increase in number of CVD as well as earlier onset of diabetes. And let's look at the lipid profiles of Indian versus the others. You can see the South Asians, including Indians, generally have the similar or lower LDL cholesterol when compared with other race, even though there could be some differences in the different races within the Asian population. Compared with the other ethnic groups, South Asians tend to have a lower HDL and the ApoA. But however, if you look at the risk stratification, there isn't much of a difference. The data on triglyceride, however, is varied, and most studies does not suggest any major differences between the Indians and the rest of the world. And I have the point to prove is that if you're looking between the Americans and Indians in this particular study, which I'm quoting, you could see that the triglyceride and the LDL, when you compare between the Indians and the Americans, are the same with a significant p-value. And if you're looking at the relative risk of acute myocardial infarction between the different ethnic groups, when you compare the South Asians with an overall, that is global, you don't see any great difference between the total cholesterol that is seen in South Asians versus with that you see in an overall 1.23 versus 1.16, even though you can see that the HDL cholesterol is much is 0.92, which is a bit higher than the overall I mean the global population. So you can see that even there is a subtle difference, there is nothing gross to talk about the changes in the LDL as well as the non-HDL, I mean the total cholesterol as well as the non-HDL cholesterol, which are probably more atherogenic. And if you're looking at the dietary recommendations, if you look at the global recommendation, it's the same. It's almost similar. And if there has been a difference, there should have definitely be a difference in the guidelines of the treatment part of it. So if you're looking at the non-pharmacological treatment of dyslipidemia, the Indian dietary recommendations are similar to that of global recommendation. So point number one is that as the recommendations are similar, why should we call ourselves different? That's where I need to focus my attention. I think Dr. Raka should have something to do for the rebuttal of this. And look at the exercise recommendations. We need to exercise, be you are an Indian or a non-Indian, at least 150 minutes per week of a moderate to vigorous exercise does play a part in reducing your insulin resistance. So does the triglycerides. You don't have to do anything extraordinary to decrease the triglyceride. If I look at this audience of, we are say around 20, and I'm sure that 80% of our triglycerides will be above 150 in a postprandial state. So, and the morning when you are going to check the triglycerides, I think there will be a small dip. The problem is what? Because we have been sitting in the hall for last 1.5 days without doing much, but then just occasional visit to the restroom as well as on the dining room. So the reason is our physical inactivity has led to high triglycerides rather than anything else. But insulin resistance has developed much early in our life compared to a Caucasian population. That could be the only reason that the drugs have not changed. Now let us look at what are the preventive measures between the Indians and Caucasians. If you are taking a good amount of, PUFA, I think that is, especially for vegetarians, that is quite advisable, because that is going to increase your HDL. But when I say PUFA, I mean that if you can take in natural way, as fish oils, rather than any synthetic products, they are going to reduce your triglycerides. And if you compare the major guidelines, what is the number one drug that you give for a patient, be it an Indian or a non-Indian? The first, the tool that is going to be looked into is going to be your LDL. And what is the drugs for LDL? It is going to be statin. So is a patient, if a patient or a person of Indian origin is going to be not given a statin, but something else, I think I really beg that Dr. Raka has to find an answer. If that's going to be different, why didn't our treatment change? So if you look of all these guidelines, whether it is an ACC or ADA or the International Atherosclerosis Society, the first line of therapy is always statin. And if you look at the secondary prevention, you can see the very simple methodology by which you can treat a patient with dyslipidemia. So if your patient is already on statin, make sure that you change it into add-on, along with statin, probably estimib. Or if the patient is having no statin, start with an statin depending upon the LDL level, either an high-intensity statin or a low-intensity statin. And only when after 4 to 6 weeks, when LDL is not under control, you start moving on to the next level. And when you come to primary prevention, I think we don't change. Our guidelines are almost similar. You just look at the risk factors, whether it is a minor low risk or a moderate risk or high risk. Based on this, I think we have the LDL numbers by which you can start the treatment if required, or you can start with lifestyle modification alone. So you do have these goals, the treatment goals, as well as when you start the drug, it also based on your LDL as well as your non-HDL cholesterol. Is this different from any of the other non-Indian guidelines? I'm saying it very strongly that we don't have anything that is dissimilar. So when you talked about diabetes, and of course, and India is only next to China when it comes to diabetes, I think we have this wonderful study called CARD study, which is again for the primary prevention, which was rolled out in 2004 and published in Lancet in the same year, where you have, which was seen that starting with that shadow, forget about the LDL cholesterol. The patient walks in, patient is diabetic, and you can see that atorvastatin of just 10 milligram was safe and efficacious in reducing the risk of the first cardiovascular disease, because this has proved that the atorvastatin reduced the death rate by 27%. And this trial was actually was terminated 2 years more earlier because of the report, and it was followed up for 3.9 years, and you could see that there was a reduction in almost 37 major vascular events for 1,000 such patients who were treated for 4 years. So be it a diabetic patient or a non-diabetic patient, starting with statin, you don't have to do lipoprotein small a, you don't have to do an ApoB, because that's not, for a population of India, I think almost 1 in 3 is going to be dyslipidemic in some form or other. And if you are going to want to reduce triglyceride, just reduce the body weight. How do you reduce the body weight? Lifestyle modification. You don't probably require a fibrate. And if the patient has to be dyslipidemia, do you have to be diabetic, improve the glycemic control. If you improve the glycemic control, automatically the triglycerides will drop. That's exactly you see in. So our drug treatment has not changed. Our exercise are similar. The guidelines are similar. Our non-pharmacological recommendations are same. The drug of choice is statin. So where is the cause, concern of dissimilarity, except for the two pictures of two beautiful ladies that he has got, one tanned and other non-tanned. I don't see any difference between, maybe that was a good capture for a poet. I think you can aspire, but I think when you talk about science, I think it doesn't have, the pictures don't matter. So management options are Indian. Statins are effective for LDL cholesterol, to reduce the LDL cholesterol. Fibrates probably are effective than statins in decreasing triglycerides, which are very high. When I'm talking about more than 500 or 1000, probably yes. The small niche of people, niche of subpopulation probably require fibrates. But where is the study? Field trial didn't give you any data on fibrates. So for effective management of high cholesterol, I think good glycemic control definitely plays a significant role. So this is the last slide. So apart from these considerations, I don't think that even though the Indians have circulating statins, do develop CAD much earlier than the comparative Caucasian population, we don't have anything to say that Indians are as good or as similar as non-Indians. Be proud of being an Indian. Jai Bharat.
Dr. Aka for the rebuttal, please.
Thank you, Dr. Jayakumar. Is this like that if land of law permits me for doing a crime to go to jail, then it's not a fault of society also that there should be a family counseling. So you are taking statin as a jail and you are universalizing to everything. That if an Indian will do, he will also go to jail. But we need to poke whether the parents are culprit or not. So हमें भारत के लिए कुछ नया सोचना होगा, and that's why we need a special theory that we need to be curtailing dyslipidemia and have high index of suspicion in our all patients. 3 or 4 slides only.
The laptop is gone. Yeah, it's not working.
Dr. Raka sir, you can just speak without the slides, is it possible?
He tries some pictures.
Picture is bigger than speech.
वो साइड करके दो सर.
जो आपने डाला वो नहीं आ रहा है क्या?
वही तो है. क्यों? Slides? Slides was different. Your presentation. हाँ वो सही था ना.
हमारा तो सही था. अभी उनका जो पिछले वाला जो स्लाइड देखा ना, वो हमारी आ रहा है अभी.
हाँ वो कैंसिल कर दिया उन्होंने.
Sir, food is the biggest addiction. And if your bakery chole is waiting to do damage to you, and what's the trend of obesity in children? If you are not going to teach our children that Sunday eating and Saturday eating is going out and taking chole and all good Indian food which are so addictive, and we take food as a legacy, forget about what Indians are there, settle anywhere where in the world with the Pima Indians or all society, and why paradox, why what had
अरे सर माउस ने લેપટોપ ચાલતા જ નથી
sitting with same BMI.
માઉસ અને લેપટોપ ચાલતું જ નથી અને એમને જે પેલા પ્રોજેક્શન મોડ પર નાખી દીધું હોય ને એટલે જે મેઇન LED સ્ક્રીન હોય ને એના પર પણ પ્રેઝન્ટર વ્યૂ દેખાય.
In India also, coast में पानी बदले, हर coast में पानी.
हाँ.
Then we need to think of different way. And the risk of developing MI in individual cannot be exactly predicted by any test or any SOP protocols because we don't know when the vulnerable plaque will rupture. So I do agree with my opponent that we need to have same therapy of treatment, but we need to individual. We can't say that my family is same family but like Western family and I need to design my own strategy because the problem of the risk score that we predict interior risk is no way predict between 1 to 3650. So
With this note, we are friends. It's all just coincidence, I think. Today only we were going morning walk. So thank you.
अरे वो सर के पास ही रखो ना
Any questions from the audience? Okay.
अरे अभी अभी मैं नेक्स्ट स्पीकर का है रुको सर को दे दो वापस वो फ्लाइट वो जाके क्लोज कर दो जाके ये पीपीटी क्लोज कर दो जाके अरे वहाँ पर चालू है पीपीटी रुको ये कौन सा है राकेश सर का
and epigenetic studies, and we have got genetic and epigenetic phenomena where it is being particularly very individualized in our population, especially Indian population, and it is more food centric as I told you, and definitely one needs proper lifestyle modification of diet and exercise, but more and above the Indians have more atherogenic lipid profiles, and also the plaque which is more vulnerable in most Indians, and so we need a very strict approach of hyperlipidemia in Indians compared to Caucasians, because more than 40 to 60% of the global burden of CV risk is in our country. So that is the reason why we need a special attention for dyslipidemia, and the management must be lifelong or they won't live longer. Thank you.
Thank you, sir. I'd like to discuss call upon Dr. Rakesh Parekh, sir, for the next talk, which is digital therapeutics for management of diabetes, and he's going to show us some more. Dr. Rakesh, sir. Dr. Rakesh sir is a practicing diabetologist in Rajasthan, and he has multiple editorial and reviewer of various journals, over 50 publications, including textbook chapters. Over to you, sir.
Thank you, Shikha, for these nice words. And I first thank Dr. Sabu for giving this opportunity. So, as it is customary for the conferences to have debates, we usually debate some topics which don't need a debate. Now, if you want to debate about the shape of Earth, again, that will be difficult. Now, today we are debating on a topic for which it would have been better if there was someone who is not tech savvy or who is analytic to talk against the motion. But we have Ranjali, who herself is so tech savvy, and she uses EMRs or gadgets, online consultation, and today she has to speak against the motion. So my compliments to her for taking this challenge. Now coming to the topic. So digital therapeutics is a specific area. It's broadly called digital health, and out of that is digital medicine. And the digital therapeutics basically is the niche area where you are using softwares or apps for interventions, and these digital therapeutic tools, they require clinical evidence as well as real world evidence to be approved by FDA. So it's a specific area, and I hope we'll debate only on that and not on digital health or technology in general. So to define digital therapeutics, there is Digital Therapeutic Alliance, which defines digital therapeutics as the products that deliver evidence-based therapeutic interventions to patients that are driven by high-quality software programs to prevent, manage, or treat medical disorders or disease. Now, this slide I have taken from today's presidential oration by Dr. S.R. Arvind, where he has shown that if we look at the progress that we made in 15 years, from 2000 to 2015, we had so many new drugs, technologies, so many doctors now, and still the HbA1c status of our population is worsening. The number of people who are achieving the target A1C has gone down over the period of so many years. So what is the reason for this, despite having so many medicines? The reason is that the diabetes management is not just prescribing medicine. You need to involve the patient, and the patient has to be continuously involved in his management. Now, we all know about the evidence that we have for the intensive lifestyle modification can work as good as metformin for prevention of diabetes. Now, one thing to highlight is that at least in our population, I don't know how many of you have time to spend half an hour or 45 minutes with a patient to educate him for in the first visit and do your best to make him motivated for lifestyle changes. And even if you do that, then how sure are you that the patient will come back to you? I think most of you will agree that half of the patients don't come back to you. And if they come back after 6 months or a year when the A1C has worsened. Now what happens in between the first visit and the next visit that he comes to you? In between he goes outside the chamber, then he has the mobile and the social media apps. He goes to home, goes on the OTT platforms, watches Netflix or Prime on his couch, and then he feels hungry and then he orders food. So food is also there available. So all the efforts that you took for 15-20 minutes of counseling, those are washed away, and the patient can never improve. Now how do we take care of this, or how do we handle this problem? So if we can utilize the same technology and have some apps or tools that rather than promoting this unhealthy lifestyle, might probably bring some behavioral changes in the patient and motivate him for a healthier lifestyle. So that is what is digital therapeutics. So these are basically web-based solutions or mobile apps in which the patients are actively involved in their own management. The patient's knowledge of the disease and the understanding of disease is enhanced. The metabolic status of the patient is monitored in real time on day-to-day basis. His dietary intake, physical activities, these are captured. Then these apps can be synchronized with the devices that the patients are using, the glucometers or the Cgms, and the other wearable devices that are nowadays available. And even there are apps that can give the automated doses for insulin recommendation. There can be personalized health coaching based on the data that is received by the software. And behavioral intervention is the most important aspect of this. Based on the inputs that they get from the patient, the personalized coach gives the specific interventions or advices for the lifestyle modification, and this goes on. It's not just one time, it goes on for the period of time. And these are all evidence-based interventions which are given, and the doctor gets the real-time feedback. So this is what is taking care of the gap that was there between the patient and his next visit to the doctor. So that time, rather than going on OTTs and the food delivery apps, he goes to the healthier apps. Now, so how will it help us? It will improve the patient's engagement. Now once you involve the patient in his own treatment, definitely that boosts the morale of the patient. The self-efficacy of patient improves, the adherence to therapy goes up, the glycemic status improves, the medication requirement goes down. There is evidence to show that the patients who are on such interventions, their medication requirement goes down, the cost of therapy goes down, there are less frequent visits required, the healthcare resource utilization goes down, and let's understand that this is just an assistant to us. It's the digital therapeutics is not your competitor. That's a tool at your hand for helping you. Now, these are several apps. I'll not go through all these things. You know that there are apps for which are on nutrition, physical activity, on glucose monitoring, on insulin initiation, insulin doses, and so many. And they all have the softwares in which the stakeholders involved in the patient's care are on board. So the doctor, the patient himself, the health coach, the different devices that the patient is using, these all are in the ecosystem. The whole data from the patients is captured, and based on the evidence, the individualized, personalized advice is given to the patient. Now, we all talk about evidence-based medicine, but then let's agree that there is so much of evidence being generated, the number of publications that are happening, it is really impossible for any of us to keep track of all the new things that are happening. So why not take the help of computer for that? Why not just accept this computer and this software as a friend rather than thinking him as a competitor to us? So before Dr. Anjali comes in, let me say that I am not saying that the software should replace a doctor. He cannot be a replacement for us. He's just a friend. He's just a tool that we can use. There are several such digital therapeutic options which are available. These are a few to name in the field of type 1 as well as type 2 diabetes. And this is the trend of clinical drug trials that are being done in this particular field over a period of last few years, the academic trials as well as the industry-sponsored trials. And these are the different countries in which the trials are ongoing right now. And this is the kind of money that is being put by the investors in this. So let's accept that the investors are definitely very smart and they know where to put their money in. So this is the upcoming field. The future is of digital therapeutics. And there are so many startups who are working on this field. I could just put these many logos in this slide. And these are the well-known pharma companies that we all know. They are having ties with different products. These are all digital therapeutic products which are about to be launched in the market very soon. And then Dr. Anjali would ask me, where is the evidence? So there is a huge evidence This is a meta-analysis showing all these interventions improving the patient's A1C, and the list is very long. So I'll just skip through the slides. These are the trials in which you can see that not just patient's A1C goes down, patient's weight improves, his quality of life improves, his TIR improves, and so much of evidence here which I can't cover in 10 minutes. And then let's not forget the closed loop devices that we have now, where again we are using just a software or an app or a loop to predict the development of hypoglycemia in future, or to suggest the patient the insulin dosage that is required. So this is the future. In the future, we'll have all these wearable devices which are connected to each other, which are talking to each other, which are generating the data from the patient's devices, and based on the evidence, the computer will give some advice to the patient, which will be an ongoing process. It will not be once one visit in 6 months, but it will be happening on day-to-day basis. And I think Dr. Anjali should, accept this, that the technology is there to come, and it will be better that she accepts the technology as a friend and not as a foe. Thank you.
Thank you, sir. Dr. Anjali ma'am. She's an MBBS and an endocrinologist and a diabetologist, chief founder and consultant at Endoclinic, Pune. And she's passionate about patient care research and teaching and formula curricula for various courses and community-based activities. Over to you, ma'am.
Dr. Anjali Watt. Yes.
हाँ ऑनलाइन बंद हो जाएगा that's it.
Very rightly, Dr. Parekh has said that I am a very techno-savvy person and not at all against technology. But we are not talking about technology. We are not even talking about digital health. We are talking about digital therapeutics. And this is something that we need to understand before we even say whether it is hope or not. And that is why we'll take this talk with an agenda of understanding what is digital therapeutics, what is not digital therapeutics, striking example of the biggest failure of a huge digital therapeutic company who is US based and had all the money on the earth. And I will tell you what happened with this company. What did we learn from this failure when we apply digital therapeutics to diabetes? Because we are talking about digital therapeutics in management of diabetes. What is hope and rest all is hype. So we are going to understand what is hope in all this, and rest all is going to be the hype. So as Dr. Parekh rightly told us, the definition of therapeutics by DT8, Digital Therapeutic Alliance, we'll come back to this. Before that, the definition also mentions that it not only complements, but has a potential to significantly replace the existing system. We do not feel insecure at all, because we know this is not true. This will never happen. This is not going to happen. So there is no question of insecurity. It is only question of understanding what is told to us and what we really know about it. What is not digital therapeutics? So having looked at the definition, which is, we'll come back to this again, evidence-based therapeutic interventions driven by a software to treat, prevent or manage a medical disease. Now, what is not therapeutics? Teleconsultation, audio video is not a therapeutic. Wellness mobile apps are not digital therapeutics. Medication reminders, smartwatches, speedometers, electronic medical records, digital sources of information like articles, blogs, videos, images, whatever you are reading on the net as an information is not digital therapeutics. Digital diagnostics, including continuous glucose monitors, glucometers, the applications which give you an ambulatory glucose profile, are not digital therapeutics. Digital pills even are not digital therapeutics. So what is digital therapeutics? As we saw, it is an evidence-based therapeutic intervention that is driven by a software. What does that mean? That it exclusively relies on an algorithm for its mechanism of action as well as suggesting the management. So this is an expected design of a digital therapeutics. This is a slide which tells us what will digital therapeutics in diabetes look like. Patient feeds the data, everything, food, exercise, medication, hypoglycemia, even glucose monitoring. I'm sure patient will watch Netflix, patient will order Zomato, but he will not enter what he has done, neither on app nor in front of the clinic. So this is what the patient needs to do at baseline, that he has to enter everything that he is doing. Then there will be, based on a large amount of data provided by the patient, the software will make an algorithm and it will learn what to give back to the patient. On what basis? Based on a large amount of data that is fed by reference texts and experienced experts like doctors, nutritionists, physiotherapists. They will provide their expertise, patient provides their data, and then a smart algorithm learns what to tell to the patient. So this is what digital therapeutics is all about. And then patient implements that data and comes back with a result which is improvement. And that has to be done with no or minimum real-time human involvement. You can't have a doctor sitting at the other end of the app to do this. That is not digital therapeutics by definition. The doctor has to only tell once to the software what the software needs to do, and later on the software is supposed to do it on its own, adding his own artificial kind of an intelligence to it. So this is what a digital therapeutic is. This has to go on for generating the evidence, and after generating the evidence and after proving that it is useful, it has to continue to do that. The main crux here is algorithm. Now I spoke to the CEO and creator of a large successful digital tech company, not digital therapeutic company, a digital tech company. This is a technology guy, and he told me that if you want to use algorithmic artificial intelligence in therapeutics, you have to have a disease that is well defined, that is repetitive, that is homogeneous, and that is bounded. And believe me, diabetes is nothing like this. Diabetes is extremely heterogeneous in terms of its pathophysiology, whether it is genetic, environmental factors, day-to-day behavioral factors, cognitive factors, everything is heterogeneous. Not only that, with the same patient, not all doctors have their own consensus on how to treat the patient. So the disease itself is heterogeneous, and on the same disease, different doctors have different opinions. So forget about having a consensus and giving it to an algorithm who will work on it. So it's an extremely heterogeneous process. A digital therapeutic algorithm in such cases is not only difficult, it's almost impossible. Now this is the biggest example of the biggest failure of digital therapeutic app, and this is called IBM Watson. This came up as one of the very huge player in digital therapeutics. This company had many billions of money put in this company, and what the company did was that it was sold in parts, it was sold in pieces. The data was sold to someone, the app was sold to someone. They put in many millions. The number is not exactly out, but it is somewhere around 7 to 8 billions. And it was sold for 1 billion. So all the money that they are putting into technology, and they are telling us that the market is going up and up and up, this possibly is a future of the money that you are putting into digital therapeutics, unless we know what is hope and what is hype. I would not be doing justice to my personality if I use these things. I don't like to use these words, but this is what a word which is used by Kaiser Ross, who was a technology correspondent who was following up what is happening with IBM Watson, and this is what he told about IBM Watson, that it is a piece of shit. So that Watson had, there is a long interview between Ross and the therapeutic technology person. I've just taken snippets from it. What he said was that the Watson had trouble with the complexity of patient files. We know how troublesome these patients' files are, and if we are going to believe on digital therapeutics, this is what is the future. Another word that he said, that I think the marketing got way ahead of the capabilities, and I think this is what technology guys try to do. They try to get into your mind, market it so well to you that you believe to what it is not, and that is what we have to be worried about. It is not against technology, it is not against digital, it is against telling us what it is not. Again, I had a discussion with a very senior level expert in diabetes who is working with a digital therapeutic kind of a company in India, Both of these people told me not to tell their name, otherwise I was planning to give their reference, but they told me not to use their names. Good, the presentation is going on, very good technology. People are not techno-savvy. This is what she told me. We can, of course, know that these things will change. There is a hope that people will become techno-savvy, but right now they are not. People still want human interaction. People do not upload the data. They eat everything, they comment, they tell you, but they will not upload in the app. Symptoms can be vague. मराठीत आमच्याकडे पेशंट आहे म्हणजे कसं तरी होते म्हणजे काय there is something happening, I don't know what. So how do you explain this to an algorithm? I don't know what is happening. So this is, symptoms are very vague in diabetes. Momentum fades away. In the initial part, people are very happy, they got a toy to play with, but later on it fades away. Self-motivated people do well. They do well without even digital therapeutics. Double work for dietitians and doctors because they are entering the data and then again they are talking to the patient also. Maybe good for prevention, but not for therapy. Patients are very, I would be very scared to let a computer algorithm manage my patient's hypoglycemia. A lot of resistance from the doctor's side to rely on software for the sake of patient safety. Some more unforeseen reasons. Technology is ever changing. By the time you create an evidence, the software is changed. All the list that the software list we have of digital therapeutics, now the software is different. The evidence was for some different software. It requires regulatory authority. By the time regulatory approval is done, the software is changed. Metformin remains metformin till the approval and thereafter. But the technology changes very far. If the approval is not mandatory for say, then the definition itself is hyped. If it is not regulated, it is not evidence-based. Some of them may have quality clinical research data, and in United States, they are struggling to keep up with the volume. With the kind of regulatory obsession US has, if they are not able to deal with this, forget about us being in the regulatory position of seeing what exactly these apps are doing. Technology guys are restlessly fast. The health doesn't move forward with that speed. It should not. So by the time the way the software changes, the health aspect of this industry, if I may call so, is not going to move that fast. So the digital world moves fast. You can't change the product so much that it is no longer doing what it was cleared or the regulation was done for that. Data protection, again, one of the very good foreseen problem. Constant observation and profiling of the patient. Rather than telling the patient that if this is increasing your blood sugar, don't eat this. There is a possibility that the market will tell you, this is something wrong, this is what we have to make it correct. So we have to be very sure that we are really taking the patient data and telling the right answer to that. There is a very big possibility that this data might be misused for commercial reasons. High potential of personal data breaches. The major threat to a person concerned. There is no end to what the data can be used for. And these softwares are so complex that they can be easily bugged. And anyone can control the algorithm. So what is the hope?
Excuse me, ma'am.
Yeah, this is the last slide. Not possible to replace the cognition is something we have to understand. Can you tell me what is this? What is the picture? Cat. Can you tell me why do you say it's a cat? There is a? Right. And we don't know how. We don't know how we recognize that this is a cat. We know there are 2 ears, we know there are fur, there are so many animals with that. And this is cognition. And the artificial intelligence or algorithm, we don't know how it does it. So that is a very risky thing. So there is a hope for vision, image reporting, very good, computer can do it. Speech, tireless talking. We get tired after talking to the patient for half an hour. Patient needs more talking. The Siri can do, Alexa can do. Electronic aids for repetitive procedures. The things that are coming again and again, that where there is no cognition required. This is hope. Rest all is hype. So we don't need to make a foe with technology for sure. This is a very famous slide all of us must have seen, that in 1990 the technology was fatter, we were thinner. In 2020 the technology became slimmer and we became fat. But we need to be smarter than these smart devices that we have made, and we have to know what is hope and what is hype. We need to be thin and use the technology the way we want. We should be in charge, not the software. With that, I come to summary. We saw what is digital therapeutics. We saw what is not digital therapeutics. Don't call this digital therapeutics. This is digital aid to the therapeutic, which is fine. We have seen the biggest failure. If Ibm Watson cannot make it, small companies are very unlikely to make any commercial profit out of it. And we need to be smart and know what is hope, which is small, and rest all is absolutely a hype. With that, I'll rest my case.
Thank you, ma'am. Rakesh sir, rebuttal.
Thank you, Dr. Anjali. It was expected that it would be difficult for you to speak against the motion. So, anyways, you carried very well, but you just changed the definition. So, she very smartly said that this is not digital therapeutics. So, if we are debating today about 5G, she would say that 5G has a hope, but you can't use it on mobile or internet. So, that is what the analogy is. Now, the definition of digital therapeutics and all the products which are there, they are all using the different gadgets. The gadgets are the source of inputs. You said that we have to make the entry. Now, tell me one product, one digital therapeutic product where the entry is made manually. All the products which I listed, they all are taking the inputs from the sensors and the wearable devices. Nobody makes the entry, otherwise it's a user job, so nobody do that. Now, you said wellness apps are not a part of the digital therapeutics. In fact, all the wellness apps, a few of them are not even approved. Wellness is not the FDA approved therapeutic app, and it is a wellness app. So, you try to change the definition. Then you said that there will be regulatory problems. So yes, regulatory requirement is there, and FDA is working on that, and it is approving only selected products as the digital therapeutics which are FDA approved. Software changes would happen, let the developers take care of that. They are putting in money, they are putting billions of dollars. They know that software can change and they will change it. Then I think you ultimately agreed that there is a hope. You said that there is a hope, but you said that let's not be very fast. Now I can't wait. Like, type of patients, they had a movement, we can't wait. Similarly, we can't just wait. The product is there. The product is FDA approved now. We can't just wait to satisfy ourselves and sit for years and then we'll join the movement later on. We are fast. We should take all these things. You showed a very good example of a cat population. Now the AI is so developed that it can identify not just cat but your fundus. It can find out the minute changes in your fundus. So the softwares are developed, the wellness apps are there, the products are there, and I think there is a hope that you agreed to. Probably you wanted to be a little careful and not be fast, and probably the young generation wants to be fast and adopt to the technology very fast. Thank you.
Thank you, sir.
No, I think the whole concept of digitalization, the virtuality, and the computer usage for the clinicians came into existence after the outbreak of COVID. And in fact, these recent developments have changed the entire profile of this thing. So unless you have an access or you have got the digital knowledge, most of the patients may not have a digital knowledge, or they don't know how to use the computers or the iPhone or any Android phones, and how far they can get into the real usage of exchanging their complaints or the doctor explaining the treatment for the patient. How long they can spend time and how far it is going to be remunerative. Though it is very useful because the patient is at one side and the patient doesn't need to travel a long distance, and economically it is more viable for the patient. And it solves a lot of problems economically because without going to the doctor's consultation room, they can get the treatment part of it. But in all sense, the patient needs the physical contact, the physical look, the physical touch, and also the physical conversation in close quarters, and that will solve a lot of problems for both the patient and the doctor. Thank you.
No. So you have a presentation?
Next chairperson.
It is connected.
Dr. Prasad and Dr. Vikram.
अरे मैं ये बोल रहा हूँ वहाँ पर पेन ड्राइव नहीं लगी है लैपटॉप में? हाँ तो लेके आओ, अभी टाइम है, जाओ जल्दी जल्दी पेन ड्राइव लेके आओ। हाँ अरे ले आओ, ब्रेक नहीं है, पेन ड्राइव लेके आओ। तुझे यही करके इसको चेक करो, ये अभी बंद नहीं होगा, ये चेंज नहीं होगा, और ये चेक करना है मेरे को। है दूसरा फोन? अच्छा फ्रीज कर दिया तुमने?
And we see that the previous session of debates were of mild to moderate intensity, and we expect this session to be moderate to severe intensity. Same the set of topics and the speakers. So without wasting much of time, we will go into the session.
इसका आएगा खाली, देखो अपने पास ना, ये नहीं। हाँ ये रहा, अभी अपन यहाँ से चालू। जाओ जाओ, रुको रुको जाओ जाओ।
Recipient of Award for Excellence in Diabetes Care by RSSBI in 2019. He is also a member of American Association of Clinical Endocrinologists, also part of the Committee for Diabetes, Obesity and Thyroid Disease Network at AACE. He is working as a diabetologist and endocrinologist at Desai Diabetes and Endocrinology Clinic and Advanced Diabetes Center Surat, and also attached to the Government Medical College Surat as an honorary endocrinologist. I would like to request.
मैं ये फंक्शन फ्रीज करके रखा है इसका।
So I will definitely assure, and I think my good friend Tejas and Purvi is also there, that we will make this not moderate, severe intensity. So I am going to talk on SGLT2 as a second add-on to everyone, any type 2 diabetic patient. And actually, why should we debate on this? Because there is nothing left for the opponent to compete. It is like our Prime Minister Narendra Modi. He is everywhere and he is for everyone. Similarly, I thought that if any patient coming to my clinic and if patient is already on metformin, lifestyle modification and uncontrolled, which type of different patient profile will be there? And is there any evidence that I will put SGLT2 as a second drug to that patient? New onset type 2 diabetic patient, multiple risk factor patient, prior MI, ACVD, CKD, heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, even type 1 diabetic patient and pre-diabetes. I will take you through this. Mr. Suresh, first time diagnosed, 8.5 HbA1c. I know that metformin alone is not going to work and patient might go into metabolic syndrome. I want drug in form of SGLT2, which is not only glucose lowering, it is having insulin independent action, it is having osmotic diuretic like action, it is having action which reduces visceral fat. That is exactly what our previous session was on about lipodystrophy and external lipodystrophy, along with hypertension and reduction in CVD risk factor, which is exactly our thin fat Indian Asian phenotype deserves. And if metformin is already there, which is there in first, DPP4, good drug, silent drug, mild drug, not causing any disadvantage, but it is also not giving any advantage also. Pioglitazone, good drug, but still you have to be cautious. Sulfonylurea, I think Tejas will talk on that, but it is not the second add-on we wish for. Then what is left? Glycemic control, weight loss, blood pressure, lipid profile, everything is covered with this miracle drug, that is SGLT2 inhibitor, and along with that it gives anti-inflammatory action. Over the top of that, it reduces liver fat content, exactly what Dr. Yajnik and our previous speaker was talking about, that fatty liver and its consequences is going to be a problem. This drug works on that. If patient is having risk factor, if patient is having eGFR which is low or microalbuminuria present, we have study in form of DECLARE where 2/3 of the patient were having multiple risk factor and not an established disease, and you can see this that even in that patient it has found to reduce mortality and hospitalization of heart failure. So as we have renal composite endpoint which was also unfavorable, where patient was not having any established cardiovascular disease but a multiple risk factor. And if patient is having MI, we have EMPA-REG, we have DECLARE, we have CREDENCE, we have VERTICIVI, we have CANVAS, we have number of study, but EMPA-REG has shown excellent benefit, and so as Dr. Subodh Verma's paper that it works like AC inhibitor, it reduces remodeling rate, it reduces LV mass index, that happens with empagliflozin and mostly with other SGLT2 inhibitor also, and that's why cardiology conferences and cardiologist association has taken this drug as not only second line along with metformin and maybe before metformin whenever it is indicated. Now I come to CKD. Patient already having CKD, patient already having eGFR which is reduced. Do we have data? DAPA CKD has shown us the data that it has shown excellent benefit. So as we can see the similar benefit in all other trials with SGLT2 inhibitor. EMPA-REG study, one subset analysis has shown it maintains eGFR. Though there is an initial dip, thereafter it maintains eGFR, and patients who were on EMPA in comparison to placebo, there was significant reduction in renal composite endpoint. And similar finding was found in even EMPEROR reduce also. And that's why in KIDGO guideline has also put this drug just after metformin, along with metformin, or maybe before metformin, and all rest other drugs which are used in anti-diabetic medicine are third, fourth, fifth, sixth, whatever you want, but first two is metformin and SGLT2 inhibitor. And similarly, reduced ejection fraction, we have DAPA-HF study, and I think this is not unknown to this august audience, so I will not take further, but now we have data with preserved ejection fraction. You can use this drug, and this is the single drug which has data which has shown reduction in hospitalization and heart failure even with preserved ejection fraction. Now what about pre-diabetic? Even in DAPA-HF study, we had one subset of patients who were pre-diabetic, and there was reduction in incidence and occurrence of diabetes which was reduced in DAPA arm in comparison to control arm, which suggests that like metformin in DPP study or maybe rosiglitazone study or wherever diabetes prevention program, we have number of study for prevention of diabetes. This is also one of the drug you can utilize for the benefit. What about type 1? In India, it is not approved, so don't take this with a pinch of salt. I am not saying this is for everybody, but DPIC study, here metformin is not the first drug. Insulin is the first drug, and if you want to have second add-on, can we use this? We are nowadays using metformin in many type 1 diabetic patient who develops insulin resistance, so as this drug also reduces insulin requirement in type 1 diabetes. It controls HbA1c. We have DPIC 1, DPIC 2 study, and adverse event was not that much. So when we are talking about SGLT2, because it is comparatively new drug, we think this is a new drug. Do we think as a second line just after metformin? Metformin is a time-tested drug. But first step to establish that something is possible, then probability will occur. And exactly happened with this SGLT2 over the period of 2015 to 2020 to today. When we are talking about SGLT2 inhibitor, we have number of evidences available for heart, kidney, heart failure, and everything. And that's why our ASE and ADA guideline has been changed. And ADA-ASE, ESC guidelines suggest that you should use SGLT2 early in patient with established CVD or multiple risk factor, fine. You want weight loss? Fine. If you want no hypoglycemia or less hypoglycemia, fine. Then there is one part that cost is an issue, then SU and TZ is there. But in India, when we have SGLT2 inhibitor which are cheaper, I think that is also included. Then what is left as a second choice? It is just metformin, and thereafter this is the first, best, and last choice to add on as a second patient. And so as AAC inhibitors, AAC guidelines are also saying the same. You can use as double, triple therapy or even with insulin whenever entry level HbA1c is high. But I know my opponent is searching that where it will not be. And on the other side, cardiologists, nephrologists are taking this molecule as one of the best choice and as an alternative to even metformin. And in diabetes, we are still thinking, do we use this drug as a second line? Why to wait as use this drug as a second line? Yes, there were few points he will definitely take out that we cannot use in pregnancy, we cannot use in patient with LADA or insulin deficiency, or patient having multiple recurrent fungal infection UTI. How many patients in your clinic are going to be like this? 5%, 7%? I will say less than 10%. So, I am talking about 90% of your patients you are seeing in your clinical practice who can be benefited with SGLT2 inhibitor. So in corona, we come to know that mask is very important and diet is very important in diabetes. So entry is important. So as exit is also very important. Metformin has shown glucose excretion in stool, which is helping us to reduce that. And similarly, paying sugar because of SGLT2 has caused miracle. So if you expect the unexpected, then you will win. Or I could either watch it happen or just to be part of it. So I will tell you, all of you, to use SGLT2 inhibitor as a second line drug and be part of it. Thank you.
Thank you, Dr. Piyush, for that wonderful lecture. Next, I call upon the second speaker, Dr. Praveen Kalvit. He has his MD, FICP, and FRSSDI. His present designation and affiliation is Senior Consulting Physician and Diabetologist at Kalvit Nursing Home and Infertility Center, Bilaspur. His areas of interest include diabetic food, diabetes education, metabolic disorders, and insulin therapies. He has been the organizing secretary of CG Epicon 2004 and CG API 2005-6, and founder chairman of Bilaspur Diabetes Society, editor of education book on diabetes. He started the first insulin bank in the state of Chhattisgarh and second only in India in 2012, and received Distinguished Physician Award from RCP London. He also holds membership to professional bodies like API, RSSDI, ADA, EASD, IDF, and ISCCM. Over to you, sir.
So at the outset, I would extend my heartiest thanks to organizing team for giving me this opportunity to be amongst you today evening to make a debate. This is actually what the audience really wanted, and it wanted to be firesome. There has to be some fire in the debate. Let me concede at the outset, my esteemed opponent has already used all the parameters and all the resources available at his disposal to prove that whatever he said is ultimately true, but in fact it is not. And why it is not, which I am going to tell you. Whenever we talk of debate, debate is something like we have to contest the issue. And I always am the thought that debate is much better than denial. Secondly, it's better to debate a question without settling it than to settle a question without debating it. That's what has been happening here. And debate and divergence of views actually can enrich our knowledge and perception of the subject. So looking into this, my aspect today is going to be cons about SGLT2 as an add-on to metformin whenever we think of add-on therapy to metformin. Fundamental tenets of management of diabetes is restoration of euglycemia. The concept has changed from just management of triumvirate of glycemia, from disturbed prandial, postprandial blood sugar level, fasting blood sugar level, and then glycated hemoglobin, to what we have been addressing to what is called the physiological defects, addressing the defect, the famous concepts of ominous octet laid down by Di Fronzo. And if you try to take into consideration every single pathophysiological defect, you know the drugs which are effective at each and every limb of the pathophysiological defect. And here in this chart you can find where is the position of the SGLT2 inhibitors. in the outermost lowermost quarter, where it just prevents the reabsorption. It causes increased glucosuria, it causes glucosuric effect. Barring this pathological defect, all other effects which are taken care of by the drugs other than belonging to the category of SGLT2 inhibitors, so with propriety we can say this is a drug of choice as add-on to metformin. What makes a drug desirable for the add-on combination to metformin? Basically a drug which has got the capability to answer all pathophysiological processes underlying type 2 diabetes. It should have a predictability in reducing of the blood sugar. It should have wider indication, should be used in a very extreme spectrum of the disease. It should have durable and a very low secondary failure rate. It should be tolerable than other drugs. Then it should have no clinically relevant side effects. Then it can be used in various combinations, and it should have some benefit in some comorbid conditions also. Now, if you have various drugs which are being used in management of hyperglycemia, what you find here amongst the chart is the different issues like defects which are addressed to a maximum extent by drugs belonging to the category of metformin and DPP-4. Where is the status? What is the level at which SGLT2 are found to be acting upon? Just by reducing glucose reabsorption from the tubules, PCTs. That's the only pathological defect which it is supposed to address. Rest all effects have been very nicely and very elaborately addressed by the drugs belonging to the category of OHS, different from SGLT2 inhibitors. So in the backdrop of such a situation, how can emphatically we say that SGLT2 remains as an add-on to metformin? I would say no, there are several other drugs. Then, and no sooner this baby of SGLT2 was born, you know, the threatening calls or alarms had already started percolating from the parent organizations like FDA, wherein it started thinking about the serious infections, the genital infections, which has been undermined and underscored by my esteemed opponent. The incidences of leg and foot amputations, then severe urinary tract infection, urosepsis, euglycemic ketoacidosis. These are not something, see, basically in clinical practice, whenever we try to treat our patients, we try to treat patients with a holistic approach and not only with glucocentric approach. So whenever we think of holistic approach, we have to take consideration of all these points which are very, very important in management. There are distinctive risks associated with SGLT2 inhibitors like DKA, one of the threatening complications. Severe renal adverse effects, genital urinary infections, cancer risk, foot amputations, bone fracture risk. Then SGLT2 is associated with DKA, and this association is not limited to particular demographic profile. It is found ubiquitously. In Caucasians and Asian Indians also it is found. It increases the risk when further combined with DPP-4 inhibitors. And SGLT2 actually deprive the cells of glucose supplementation. It causes decrease in ketone excretion, causing severe ketosis and euglycemic ketoacidosis we already made a mention to. It causes significant medullary hypoxia, which is a great concern, and that's the reason why as soon as you initiate the SGLT2s to a patient of diabetes mellitus, it causes a transient dip in the eGFR. And normally my opponent has taken this issue very lightly, but patients who are on the end stage of renal disease, stage 3, stage 4 renal disease, this transient dip could be extremely detrimental to the patient's condition. Then it causes, under some situation, reticular renin-angiotensin system activation. The genital infection and the urosepsis, you know, it could be very, very fulminant and sometimes life-threatening if the patient is using SGLT2 inhibitors. Think about the cancer risks. Experimentally, high doses of dapagliflozin up to 2 years have been contributed to cause increased tumor incidence. Canagliflozin has already been blamed for causing bladder cancers. And SGLT knockout mites have also been shown that they are now deprived of getting cancer infections because their receptor blockage have already been carried out. So there are differences between experimental and clinical evidences of carcinogenicity induced by these SGLT2 inhibitors. Although we say that this cancerogenesis or carcinogenesis is not an individual, it's not a class effect. The cancer effect is attributed to different individual SGLT2 inhibitors. Foot and toe amputation, twice is the incidence, twice higher is the incidence of foot and leg amputation in patients. Bone fracture risk because of the significant hyperphosphatemia and the inherent tendency of SGLT2 to decrease the mineral bone density, that has also been blamed for. Significant volume depletion accounting for severe incidences of strokes, syncope, hypertension, and a patient who is already critically ill and having severe dehydration. Then eulemic patients, we have to consider the reducing doses of diuretics, which is an add-on therapy for management of patients with congestive heart failure. We always say it's a drug which is used in half-ref and half-pref both. But then these patients who are on concomitant diuretic therapy, one has to be extremely cautious in titrating their doses. SGLT2 inhibitors should be withheld with the risk of dehydrations in individuals who are critically ill. And once in a while, in a lifetime of every diabetic individual, he has to go through phases of severe critical infections. You have to be extremely cautious using these drugs. Hypotension has been made mention of several times because of volume depletion and severe dehydrations in individuals taking SGLT2 inhibitors. It causes slight increase in the hematocrit, higher incidence of UTIs, higher risk of amputations, polyuria, dehydration, and even to some extent it has been blamed to cause slightest increase in the LDL concentration also. So there are distinct no's with SGLT2 inhibitors, don'ts with SGLT2 inhibitors. Do not initiate SGLT2, that is EMPA, as one of the component members. EMPA canine DAPA with eGFR less than 45. My opponent has given a slide wherein he said metformin not to be initiated before 45 eGFR. But these drugs, the SGLT2 inhibitors, there's a warning not to initiate the drugs when their eGFR falls to less than 45 milliliters. Then do not start. There's a different class of drug. For a higher cutoff, it has got a higher cutoff of 60 ml per minute per 1.73 square meter surface of body area. SGLT2s are contraindicated with eGFR of less than 30. There's absolute contraindication. So this is one of the, and in the contrast, I would like to tell you there are several other drugs belonging to different OHA categories, including DPP4 inhibitors, where the usage in patients with CKD is not absolutely contraindicated because these drugs will also be used in patients who are being hemodialyzed. Avoid SGLT2 patients in tendency of recurrent urinary tract infections, and of course they are not, people are using, but they are not officially approved for usage in type 1 diabetes. People are making use of this drug as off-label therapy. Then what is the status of SGLT2 in today's scenario? For you to initiate SGLT2 in any patient with diabetes mellitus as an add-on therapy to metformin, the patient must satisfy one of the following conditions: that he has got inadequate treatment response to available OHAs, or he is intolerant to available OHAs, and is contraindication to metformin or any one of the following conventional OHAs which is being used, including DPP4s, TZDs, GLPs. Patients must have a HbA1c greater than 7. Normally, we know that for individuals with a presenting A1c of less than 7.5, effectivity of SGLT2 is overscored by other available drugs, including gliptins. If the patient has got GFR of more than 60, then you are at the comfort zone of utilizing this drug in initiating therapy, and there is no dual therapy with SGLT2 and DPP4. Of course, whenever you are initiating, you have to be little cautious regarding the side effects which are most foreseen. So we have a definite take home when we think of using SGLT2 as an add-on. I would say emphatically no, wait, because there are several other choices. We are actually, when we describe these drugs belonging to category of SGLT2, what we say is we are actually in the midway in discovering the reality of SGLT2 inhibitors. We are not fully through it. We are actually in the midway of discovering the reality of SGLT2 inhibitors regarding their risk and benefits and full safety profile. Until that, the use of SGLT2 inhibitors should be limited to their specific indications. It is being used, it can be used continuously, but neither definite stipulated set of indications where the drug can be used very comfortably and very confidently. After initiation of metformin, consider GLPs as one of the most promising drugs for prevention of cardiovascular disease, atherosclerotic cardiovascular disease.
So we are running short of time.
Yeah, last slide. And DPP and SGLT2 inhibitors could be used in patients who have got cardiovascular morbidity or renal involvement associated with diabetes only. So with that, I conclude. So I would take home is there is no single size that fits all combination. Metformin along with SGLT2 or metformin along with ACO or metformin along with DPP4. This single size combo does not fit all. Every therapy has to be individualized. And every diabetic patient has to be given credibility of getting management on individual basis rather than making a generalized statement that this is the definite add-on therapy to metformin. With that, I conclude. Thank you.
Thank you, Dr. Parveen. But I mean, this is the debate, and debate is of 25 minutes.
So the first speaker has to speak for 10 minutes. The second one again will talk for 10 minutes, and there could be rebuttal of 1 minute again, and then the final conclusion if anybody wants to make any comment. So it has to be restricted. I request chairperson for the next debate, make sure that the first speaker speak only for 10 minutes and the second one will only for 10 minutes. It is strictly to be 10 minutes, and then we have to stop so rebuttal can again be done, and then we have to, because otherwise debate will not have any, it's like a lecture. Please, thank you.
Any comments from Piyush sir?
I would again emphasize my second last slide, that we are talking about only side effect as my opponent does. But what about effect? What about the benefit of this SGLT2 inhibitor? Are we going to see that 10% or are we going to benefit 90% of our patients? That's all.
Thank you. For shortage of time, I would like to get an audience poll on this topic. So how many of you go for that first? Yeah. 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 How many of you?
It is, suppose 90% was originally in favor of SGLT2 and only 10% was against it. But suppose he had changed from 10 to 12, then still he is the winner. The point is, because he could convince 2 more persons.
So,
that's the right way of
so how many of you are in favor of SGLT2 as the only add-on for patients with, all patients with diabetes? How many of you are as the first add-on for all patients with diabetes? Yeah. So how many of you are against that? Yeah, I think it.
So there are many who are not raising their hands. They have some other opinions.
I think we will quickly move on to the next session, which is.
So for the next debate, I just how the voting to be done. The preventing diabetes complication, 100 years on from insulin, which of the given classes will prevail? Is it GLP-1 versus SGLT2? Now Dr. Arvinda is going to talk in favor of GLP-1 and Dr. Purvi is going to talk for SGLT2. Now it should be in advance how many of you are in favor of GLP-1. Now then we have to count. So how many of you are going to yes for GLP-1? Only 1, 2, 3, 4, 5. Okay, so 6, 7 people are there in the favor of that. And for SGLT2, how many of them are there? So suppose 20 are there in favor of SGLT2. Now the point is that GLP-1 at this point in time only 6%. If Arvinda could convince after the debate from 6 to 10, then he is the winner. Yeah. So that's more important. Even before starting the debate, only 6 was in the favor of GLP-1. And after the debate, if 10 of them, then he is the winner. Okay, so I'm not just saying that he is the winner. Come on, we have to try. And now, all yours. Dr. Arvinda is senior diabetologist from Bangalore. This is sufficient introduction for the people. Start.
हाँ वो तो मैं उसको देख के ही मैंने ऑन किया.
So good evening everybody.
At the outset, I thank Dr. Arvind sir, Dr. Banshi sir for giving me an opportunity to debate in this wonderfully organized conference. So I'll be talking in favor of GLP-1 RA. So first of all, greetings to all of you from Bangalore. I'll tell you a story actually. See, there are 2 recent movies which was released, which were the blockbusters actually, RRR and KGF. But which one is better? That is the question. Obviously, KGF made a big name, big money because of its technology, acting, everything. So it was a super duper hit. We all agree on that. So in the same way, Dr. Purvi is supporting RRR. So I am doing KGF, rebuilding an empire. So if you go this, see this mechanism of action of anti-diabetic drugs. See SGLT2 inhibitors, only on the bottom. So decrease glucose uptake, increase glucose reabsorption, that's all. But if you take the diffranzo's ominous octet, he always tell the drug should be in such a way it should address all the pathogenic aspect of type 2 diabetes. So this is where you can see GLP-1RS. I'm sure after seeing this all of you will raise hand. So GLP-1RA work on 6 out of 8 pathophysiological pathway of type 2 diabetes. So see the mechanism of action when it compared to other drugs as well. GLP-1RA definitely scores over SGLT2 inhibitors, DPP4 inhibitors, sulfonylureas, any drug. You compare GLP-1RA scores over. You can see in this slide. So to prevent complication, ladies and gentlemen, it's always the tackling the root is important. See, hyperglycemia is the root cause to prevent all these things. We all know 1% decrease in HbA1c decreases 21% diabetes related death, 14% myocardial infarction, 37% microvascular complications, 43% amputations and death. So you can see this slide, the changes in the HbA1c, how the GLP-1RA scores over the other things. Like if you can see the SGLT2 inhibitors, it's only 0.8. Here you can expect up to 1.5 reduction in HbA1c. That is the advantage of GLP-1RA. So 5 to 10% loss. The current bench of success first proposed by Sign Guideline way back in 1996, we all know it always reduces the various complications associated with type 2 diabetes. So diabetes is a war. Just like a war, soldiers use effective weapons at the start. We doctors need to use our most effective agents to protect our patients from the reach of complication. So you can see the body weight change relative to placebo. Once again, you can see this GLP-1RA scores over the SGLT2 inhibitors. So coming to an important aspect, that is the contemporary CVOTs. See, there are so many CVOTs with regards to GLP-1RA. So 2, 4, 6, 8. But when it comes to SGLT2 inhibitors, it hardly 6. So once again, GLP-1RA scores over SGLT2 inhibitors with a very positive outcomes. So you can see in this slide, when it's compared between GLP-1RA and SGLT2 inhibitor CVOT, looking at the bunch of evidence on the right hand side, you can see GLP-1RA CVOT is 56,000 patients. Mean reduction is 12%. SGLT2 inhibitors 42,000, once again less patients. Mean risk reduction is 10%. So important thing to be noted here is the favorable results in terms of number to treat for GLP-1RA is 1:75, but when it comes to SGLT2 inhibitors is 1:97. So anti-inflammatory, anti-atherosclerotic disease modification, you can see with GLP-1RA. There are so many benefits with GLP-1RA. It increases the cardiac output, increases the myocardial contractility, whatnot. All the benefit aspects to improve the heart functions is there with GLP-1RA. So you can see in this slide the recommendations from ADA. After the 2 major study with liraglutide and semaglutide, they have changed the recommendation from as the first line add-on after metformin. So cardiovascular benefit continuing in 2019 and 20 respectively, the oral semaglutide was approved by the FDA and EMA for the treatment of type 2 diabetes to improve glycemic control. In both labels, data from Pioneer 6 included confirm the CV safety of oral semaglutide. So ladies and gentlemen, GLP-1RA is not just an agent enrooting the cause effectively, it's beyond that. So incidence of stroke, globally, stroke is the second leading cause of death. In 2019, the incident cases of stroke was 12.2 million, prevalent cases of stroke was 101 million, DALYs due to stroke was 143 million, deaths from stroke was 6.55 million. So once again, you can see here the GLP-1RA does better with stroke when it comes to SGLT2 inhibitors. So important thing is GLP-1RA can be used at any level of eGFR. You can see in the bottom line. So GLP-1RA is preferred even if the eGFR is 15 to 29. So So once again, this one study shows GLP-1RA helps in reducing the insulin resistance as well. Important aspect. Most important point to be, another important point is here glucagon. So GLP-1RA increases the insulin secretion, decreases the glucose secretion, whereas SGLT2 inhibitors decreases the insulin secretion and increases the glucagon secretion. So suppressing glucagon action should effectively decrease the long-term complications and metabolic derangements in diabetes, enhancing the quality of life of diabetic individual. Another highlight is future is good with GLP-1RA. It's being explored in other areas as well, in Parkinson's disease, Alzheimer's, NASH and PCOS as well. If you see the SGLT2 inhibitors, Dr. Praveen has shown the various complications and risks associated with SGLT2 inhibitors. So see the recommendation what they have seen. In way back in 2016, the FDA added a warning for increased risk of leg and foot amputations with CANA. In 2018, 4 years gangrene. So various complications are seen which can be very detrimental to patient on SGLT2 inhibitors. That is where the GLP-1RA scores over. So if you see the side effect thing, you can see the various aspects. The complications with amputations, hypotension, ketoacidosis, kidney injuries, fornix gangrenes, mycotic infection, bone cancers, bladder cancer, bone fractures. So many things are there with SGLT2 inhibitor. Do you want to, when you weigh between GLP-1RA and SGLT2 inhibitors, seeing at this, definitely GLP-1RA scores over the SGLT2 inhibitors. My opponent will be ready with the cost. I'm sure she will be ready with this cost factor. But see this slide, preventing a cardiac event, you are going to save nearly 2.5 lakhs. And most important is patient life. So at this point of time, you should not, yeah, I am seeing the time here. So looking at this cost benefit, definitely in preventing a heart attack, the GLP-1RA should be the preferred agent. Coming to the guidelines, you see in this guideline where GLP-1RA is placed in all the top good things when it compared to SGLT2 inhibitors. The first name comes is GLP-1RA. Next is the SGLT2 inhibitors. So it is well placed in treatment guidelines. Once again, another slide shows from the ADA, the GLP-1RA is top placed. So this is an international treatment recommendation. Very simple but very interesting slide. You can see from the top, the metformin plus or minus OADs, patient at lower risk. See the main things. The recommended drug is GLP-1RA. Weight KSU, recommended drug is the GLP-1RA. When there is a CV risk, once again the GLP-1RA scores over the SGLT2 inhibitors. To summarize my talk, to tackle the diabetes related complication, the need is to enroot the cause, hyperglycemia, obesity effectively. GLP-1RA from many clinical trial has proven itself as a powerful agent targeting the core underlying causes. Its potential in reducing MACE and stroke is noticeable. How can we forget how GLP-1 improve the metabolic derangements? How to play this? No, not this one. You have to play this. Video is that. Where? Yeah, okay. How do you play? Yeah. Powerful people come from powerful places. Hey, what? Powerful people come from powerful places and make the place more powerful. You know this famous dialogue, isn't it? GLP-1RA in Diabetes India, powerful drug comes with powerful data and makes the treatment more powerful. I hope you all agree on this. Not but that the least, see this, Diabetes India conference is there. You just observe his face. See the GLP-1 array. GLP-1 array definitely stands taller than the SGLT2 inhibitors. Oh. Over to you now. Over to you.
Thank you. I request Dr. Purvi to take up the challenge. This has really been a celebrity debate, including involving celebrity molecules. So I would like to briefly introduce Dr. Purvi. She doesn't need any introduction. She is the consultant diabetologist and director of clinical research at Lina Diabetes Care Mumbai and Diabetes Research Center, honorary consultant diabetologist at Bharati Ayurveda Hospital and Mahavir Hospital, Mumbai. She has been co and sub-investigator at various centers. She has been the organizing secretary of various meetings, including women and diabetes conferences. And she is an RSSBI social media co-team member, co secretary of Central Coast Medical Association. She has got a lot of awards and presented a lot of papers. And I request Dr. Purvi to continue with the debate.
So at the outset, let me say a big thank you first of all to Dr. Banshi sir, Dr. Arvind sir who's sitting here, and Dr. Jyotidev sir and everybody from the team. It wasn't my idea to debate against a friend, but we are just debating and not arguing. So yes, first of all, I want to say again that we should get this team of scientists who made the oral GLP-1 to work on the insulin molecule, because they were so desperate that in a matter of 20 years they just managed to make an oral pill out of something, out of a peptide. Let's get them on the insulin project as well. And the second thing I want to say is I'm also very thankful to the US FDA for being so alert and making us all aware of the different side effects that we have actually noted with these newer classes of drugs that have come up, because without this kind of pharmacovigilance, we would not be good physicians or scientists or doctors and not doing our justice in the clinic. So with that, yes, Diabetes India, and everybody wants to know what it's going to be. And the crux of diabetes management, even though diabetes is a cardiovascular disease, as we know, is essentially targeting, we can still change the destiny of somebody with diabetes if we can control all the major cardiovascular and renal, all the risk factors. If we can control them, then we can still change the destiny of somebody with diabetes. Well, older age, prior heart failure, cardiovascular events, peripheral artery disease, kidney complications are a subgroup of patients that are most likely to die because of diabetes worsening the other conditions. And obesity, one cannot really exclude that. It's one of the biggest cardiovascular risk factor, as you know, and the end is not very happening. It's all about cardiovascular events, occurrence, coronary artery disease, heart failure, arrhythmias, and sudden death. So we know the importance of that. And then again, type 2 diabetes, even with all the multidisciplinary approaches and all the chronic care model and this model and that model and everything, we know today that it is not just a glucocentric approach, but it is a multi-risk strategy, and cardiorenal protection is a very, very fundamental aspect of it. So with that, I introduce, or I quote Dr. A.K. Singh again. I quote him here to say that SGLT2 inhibitors are novel, potent, oral, inexpensive drugs for us that decrease blood glucose concentrations by reducing glucose reabsorption from the proximal convoluted tubules and by increasing urinary glucose excretion. And as Dr. Arvinda showed in his circular diagram, we just have to flip that around and SGLT2 inhibitors are right up there. it's a circle after all. You know, the earth moves around and we see the sun rising every single day and set as well. So durable glycemic efficacy, body weight, blood pressure reduction with cardiovascular benefits, as well as renoprotective actions without higher risk of hypoglycemia, leave alone the weight gain part of it that insulin might have offered. We have something that's highly, highly recommended. And again, there is evidence of reduction in beta cell stress and hyperinsulinemia as well. So of course there are problems there are problems like any other drug class that we can think of, including even a paracetamol. But again, adequate counseling, alertness and watchful vigilance can always help us prevent them from aggravating further. So overall, if I have to just quickly say that metabolic benefits starts with reduction in HbA1c, and we've seen both SGLT2 inhibitors and GLP-1 receptor agonists. Body weight reduction is there, blood pressure reduction is almost universally seen with SGLT2 inhibitors, and again, no hypoglycemia risk with both of them. But in particular, I want to talk about body weight to you. Even as monotherapy, using both, there is a beautiful dose response that you can see, both with the lower as well as higher dose response, with the lower as well as higher doses of SGLT2 inhibitors, and up to 2.5 kilograms, and that is surpassed only by the probably the oral GLP-1 receptor agonist semaglutide. And that's not it. Even as dual combination therapy, we can see, but the most impressive one is in the background of metformin and pioglitazone, we can still see that canagliflozin 300 milligrams caused a 3.7 kilo reduction, and I think that's very, very impressive. Again, there is evidence to say that the epicardial adipose tissue, which is the nidus of inflammation that causes atherogenesis, as well as the root cause of myocardial infarction, is also contained by SGLT2 inhibitors, which is very, very impressive. And again, if we compare them with most GLP-1 receptor agonists, I think they are more or less, I won't be unfair to them, they are definitely better against most, but maybe semaglutide would cross that. Now coming to cardiovascular disease, we know that the 3-point MACE is seen, the risk reduction in the CV outcomes in patients with type 2 diabetes and cardiovascular disease or high cardiovascular risk. SGLT2 inhibitors and GLP-1 receptor agonists both show favorable effects on the long-term cardiovascular outcomes, but here comes the hospitalization for heart failure, and we clearly know that SGLT2 inhibitors score much better here because GLP-1 receptor agonists are neutral. Well, in the cost analysis that Dr. Arvinda showed, there was no mention of heart failure, and today we know that heart failure exists in, even asymptomatically in so many patients. Again, in this meta-analysis of randomized controlled trials in patients with type 2 diabetes and cardiovascular disease or high risk, high CV risk, SGLT2 inhibitors showed a consistent beneficial effect on hospitalization for heart failure not observed with GLP-1 receptor agonists. Again, the real world evidence also showed that there is a consistent reduction in the same with SGLT2 inhibitors in patients with type 2 diabetes regardless of the cardiovascular disease status. In the sense, even with no prior history, we would still see a reduction. Now coming to kidney disease, well, again, hard kidney outcomes like doubling of serum creatinine or progressing to end-stage kidney disease. Albuminuria is sort of reduced by both, but these are the hard kidney outcomes that are clearly favored. There is a relative risk reduction with SGLT2 inhibitors as compared to GLP-1 receptor agonists. And again, the relative risk on worsening EGFR, end-stage kidney disease or renal death, we have seen that SGLT2 inhibitors significantly reduced that by, the relative risk reduction was 45%, while GLP-1 receptor agonists did not. slowing of EGFR decline. We don't want kidney disease to progress, right? Why bother about treating it when you can prevent it? So again, we've seen there's a consistent improvement with SGLT2 inhibitors, and which is not consistently seen across GLP-1 receptor agonists. Well, again, after excluding for macroalbuminuria, because that is something that drives kidney endpoints for GLP-1 receptor agonists, but when we remove that factor, SGLT2 inhibitors still stand out and show a consistent benefit versus GLP-1 receptor agonists. And that is why they are today the favorites of not only cardiologists, but also nephrologists, physicians, diabetologists, and endocrinologists. SGLT2 receptor agonists, as seen in this network meta-analysis, were very consistent in reduction of risk ratio for MACE in patients with CKD, but GLP-1 receptor agonists were not. And again, we can see that for renal outcomes in CKD patients, again, SGLT2 inhibitors in this particular network meta-analysis were more beneficial than GLP-1 receptor agonists. So overall, even the real-world data seems to be favoring SGLT2 inhibitors, even in terms of other conditions like hyperuricemia and NASH. We have seen benefits, clinically significant benefits with SGLT2 inhibitors as compared to GLP-1 receptor agonists. And the ethnic response, be Indian, buy Indian, and try things that are better for you. So in terms of ethnic responses, again, Dr. Mohan and et al. Have actually shown us that SGLT2 inhibitors have a significantly higher response in Asians as compared to DPP-4 inhibitors. Well, we don't know about that with GLP-1 receptor agonists. And pharmacoeconomics, again, this particular, and there are several analyses, but I think this one really showed that, well, there was better adherence because a drug is as good as it is used. And better adherence, less discontinuation, and lower cost with SGLT2 inhibitor, canagliflozin, as compared to a GLP-1 receptor agonist in type 2 diabetes. Yeah, I have a minute more. So I've even compared oral semaglutide and canagliflozin at 300 milligrams. Both are oral drugs. And again, I think you can see the table for yourself that, besides all the similar benefits that they have, there's really a lot of convenience and a lot of plus benefits that we can see with SGLT2 inhibitors as compared to the GLP-1 receptor agonists. Again, this is something that I've just walked you through. But the specific factors also we have talked about, and we know that whatever said and done, heart failure is not favored or not benefited by the use of GLP-1 receptor agonists. So 2021 was clear that all the guidances were very clear in saying that okay, first line therapy is metformin, but look at the risk factors or established disease. But 2022 has gone, probably a step further to say that first-line therapy should, include all these factors or considerations of comorbidities, patient-related factors, cost and access as well, besides generally including metformin and lifestyle changes. So I think this is also a very, very important line in our consideration of access and other things. So again, I think Dr. Piyush Desai also went through this, and SGLT2 inhibitors are definitely preferred by the KDIGO guidelines as well in type 2 diabetes and CKD. Again, the statement by the European Society of Cardiology on SGLT2 inhibitors say that in individuals with heart failure with reduced ejection fraction, with or without diabetes, risk of CV death or hospitalization for heart failure is reduced by dapagliflozin or empagliflozin. And similarly for CKD as well, they say that in individuals with proteinuric CKD with or without type 2 diabetes, the risk of kidney disease progression is reduced by dapagliflozin. So let's say that we are really progressing well, not only in the diabetes patients, but these have a myriad of benefits that go beyond diabetes. So again, the AHA guidelines say that In patients with type 2 diabetes, either established CVD or at high cardiovascular risk, SGLT2 inhibitors should be used to prevent hospitalizations for heart failure. And in patients with preserved ejection fraction, SGLT2 inhibitors can be beneficial in decreasing the hospitalization for heart failure and cardiovascular mortality with SGLT2 inhibitors. So they are definitely multitasking oral inexpensive anti-diabetic agents here to stay. HbA1c reduction and all the benefits that I talked about are all, and there is adequate guidance to use them in newly diagnosed patients, those with multiple risk factors, prior MI, ASCVD, CKD, heart failure, both reduced and preserved, potentially in type 1 diabetes, even pre-diabetes, we don't know. The risk-benefit ratio is the key. I'm just done. Adequate counseling for UTIs is not to be compromised on, and not to use in contraindicated patient subgroups. So with that, of course, I come from Bombay, and Bollywood is a big part of it, so I'm not going to just settle for RRR or KGF, what did you say? But I'm actually proposing that why not give the benefit of both the classes, which are novel, and today we have an oral option also, even though frightfully expensive to our patients. So yes, Karan, Arjun, we can use them both in our patients. Again, there are several trials with that, and then maybe with a metformin as well in the middle. So with that, I thank you very much for your.
See, whenever there is an IPL match is going on, if the overs are not done on the right time, it will be punished. So we should punish Purita. She took an extra time. Man, see, that is the thing. Already she's trying to convince and convince and convince. It's not possible. Extra time is not possible. Chairperson, you should take a note of it. So another thing is, see, that is the reason. So when GLP-1 is there, it has got a sufficient scientific data is there, cardiovascular benefit is there. Yeah, cost, yes, I showed you. 2.5 lakhs can be saved. Most importantly, heart is saved of a patient. So we have a powerful drug with the powerful data that makes the diabetics treatment more powerful. GLP-1 RA, झुकेगा नहीं.
जाओ क्लोज कर दो बराबर. अभी आया नहीं है, वो आएगा तुम्हारे पास. उसका क्लोज कर दो.
Once again at the end of the, how many are for GLP-1 receptor agonists? And how many are there for SGLT2 inhibitors? I think Dr. Ajgaonkar has convinced more people.
But what is lifting for
yeah, I think we will move quickly forward to the next session. And for my surprise again, it is a battle between Bangalore and Mumbai.
सर का है, ले लो, सर का है. डाल दो फ्लावर.
This is again another very fierce battle which is coming up. Certain areas have been unfortunately victimized. Yes or no? For yes, we have Dr. K.N. Nahar, who again needs an introduction. He is the consultant physician and Adipose Research Medical Center at Malta Hospital. And he was the organizing secretary of KISSDI and chairman reception committee of Epicom 2018, and has received multiple awards of excellence in diabetes care. And he's authored many textbook chapters or many papers and presented sessions and various conferences regional, national, and national. Over to you, Dr. Nahar.
Thank you. I think KGF won there, but we'll promise that we'll dance for RRR the banquet with some Bollywood numbers.
So before you start, how many of you with Manohar sir that
sulfonylurea are victimized? How do you feel that sulfonylurea are being victimized?
And how many of you are against? So there are so many Karan Arjun now, not from the Karan, not from the Arjun. Okay, sir. Yeah.
So IPL traditionally Mumbai Indians has done well. As my chairperson said that it's again a Mumbai Indians versus RCB now.
but I think we'll need Mumbai Indians' help tonight at the match so that we can move up the ladder. Sulfonylurea are unfortunately victimized. They are wheel caught in the plot of newer molecules. Trials, we all know, we always design it to suit the molecule in contention and defame what is good that time. Again, I always talk about this debate, but somehow I get dragged into the debate, and luckily this is not against Arvind, which I have done many times. So this was question already asked by the chairperson. So motive one, see, there is always an inherent motive by people to defame these good old molecules. Huge market, everyone knows the most prescribed drugs as an individual or in combination with metformin, even to date, even after so much of victimization, is sulfonylurea. So most cost-effective molecule, even though you slash rates of other things. It features in the essential list of medications for Southeast Asia. Well, you can debate it here, but useful in pregnancy, glibenclamide if someone is not willing to take anything else. Cardiac, renal, and hepatic dysfunction, dosage alteration, be smart, and you can still use it. It was like a neighbor's envy and owner's pride. So, victimize it is what my friend will do. 65 years on and still going strong. This is the first molecule to be launched. Oral anti-diabetic agent just behind insulin. So defame it, grow your new market. Look at this prescription pattern. Fact one, you look at it, evolution of treatment preferences, even from 2011 to 2020, still it is the most prescribed thing. You may talk something in the hall, but what are you doing when you're sitting in front of your patient? You're still prescribing it. Fact two, worsening glycemic targets over the 2 decades. This is the data where we have seen that in spite of all those fancy molecules which are shown here, I don't know, I didn't get the pointer. So still the A1C changes or the percentage of people attaining the goal, whatever we want, is still almost the same. If they were so really good, why has it not changed dramatically? Unmet need, another 10 molecules come, they keep using this or abusing this, a hyped terminology just to fit in their bracket. It's like we have a drug now, let's find a disease, let's find a space to grow it. So that's what people have victimized sulfonylureas. Prescription pattern, that's what I was telling, walk the talk. Even today, with vildagliptin, metformin being cost effective, still the number one prescribed combinations across, when you take a survey, is still sulfonylurea metformin combination. And verdict one, before we jump onto it, I give one verdict. Already all the guidelines, let it be ADA or even our own RSSDI, IDF, WHO, they still say there is a huge scope for using sulfonylurea metformin as a combination. They still remain the mainstay of therapeutic efficacy, safety, pleiotropic benefit, low cost. Still they are the answer. Then why is it? You want to victimize, there is a group, pick up the weakest, worst, and highlight as if everyone are same. Glibenclamide is shown to be the sulfonylurea. Ischemic preconditioning, severe hypoglycemia, but we are not talking about the newer variants of sulfonylureas. Agent specificity is not as highlighted as it should be when they were comparing with molecules. They are a contemporary class. They are like Bhagavad Gita, Holy Bible, or the Quran. We all started and grown beyond that after that only, but never victimize it. Of course, they may have some here and there benefits. Yes, we agree, but why do we victimize something which is done for so well for so long? I won't even dispute, I won't even go near this. Glucose efficacy, unprovenly, it is still behind insulin. False allegations, what are the people are doing? Weight gain, hypoglycemia, often hyped, and beta cell exhaustion, and CV outcome trials. Actually, it was a blessing in disguise. Talk about the Carolina trial. They thought, of course, there is a great molecule, linagliptin, sulfonylurea causes all those 4 adverse effects. So pitch it against it, and you see they are not CV safe. Hypoglycemia is a big issue. No. What did it say? Not only Carolina said it was CV neutral, as good as linagliptin, but 6-year glucose control. We never had such a long-term data about sulfonylureas. It was the same. It also rested the beta cell exhaustion hypothesis. Not only about the CV outcome, but also beta cell exhaustion was hypothesis. I think, again, I will not go into this primary, secondary outcome. Everyone knows here, very learned audience. So meta-analysis, falling short of what I was talking about the Carolina trial, even if you look at the meta-analysis, on top this glibenclamide was the main culprit actually. So, but they showed it so much that sulfonylurea are all similar, and most of the CV outcome or CV risk associated with glibenclamide was overhyped and highlighted as it belongs to everyone. So class effect and fooled us. And this is another funnel plot which included other agents like SGLT2 inhibitors and DPP4 inhibitors and other class of agents which didn't show any major pointers towards increased CV outcomes or CV hazards with respect to sulfonylureas. The second false allegation is beta cell exhaustion. Again, I will not get into it. This is another I like this trial called the GREAT trial, which was into 4 arms. As you can see, sulfonylurea, DPP4 and GLP-1 and insulin glargine. And it was a neutral trial by the NIH. And what did it say? The percentage of participants who developed A1C more than 7, it was as good or even better than what sitagliptin did. But of course, glargine and liraglutide did slightly better. But again, it reinforces the trust in sulfonylurea as a molecule. Again, the victimization concept is highlighted here. Durability, again I said Carolina already showed that it is 6 years at least as good as durable as the linagliptin, which was a contention there. Hypoglycemia, often hyped is what I will say. What is hypoglycemia? You start a clinical trial with a molecule which has the least risk of hypoglycemia. You keep on intention to treat to target, push it till someone suffers from a hypoglycemia and highlight it. This hypoglycemia was more with sulfonylurea. Of course, we know that. And nocturnal hypoglycemias are high, but put it in real practice. How many people really see as much as it is shown? We see definitely. A safe, smart approach to it, educating a bit, will undo this risk of hypoglycemia. And weight gain. This is another one. We all know weight gain is associated with sulfonylureas, can be an initial indicator of reduction of glucotoxicity. And what did the other trials, meta-analysis, looked at it at 5 years. There was no significant weight gain associated with sulfonylureas as it was hyped up. And even Carolina trial, again get back to that, 0.8 milligram weight rise was seen with glimepiride, which plateaued. 0.8 is not much, of course. So it's a weight neutralizing effect. It is also seen in this systematic review of meta-analysis, which showed the maximum weight gain was 2.1 kilogram, and statistically it was not significant there. Legacy effect, come any drug, and this is one point of highlight of talking. Legacy effect, go early, hit strong. Where did you get the data from? UKPDS, what was the molecule used? Sulfonylureas and insulin. So cost, of course, people alluded to it. Of course, nowadays the other costs are coming down, but even otherwise, if you look at the cost adjustment, you can buy statin, aspirin or ACE inhibitor for your patients. So friends, traditional bashing points of sulfonylurea. Durability, Carolina GREAT trial, I've answered it. Hypoglycemia, yes, it is a problem, but use it smartly and it won't be much of a problem. CV outcome, this was designed for Bacha molecules which came much after sulfonylurea, not before that. But there also Carolina answered it. Weight gain, yes, it is modest but not very, very significant. And my good friend will come and speak on it, and I would like him to have an independent CID investigation into how sulfonylurea was victimized, and he will agree with me. Hostile witness or approvers. These two trials are the approvers for sulfonylurea as a molecule. Carolina and Guide, they thought they can victimize and get away. No, they gave good scientific data for sulfonylurea. Glucoconfidence, glucosafety, and gluconomics. So friends, you try to victimize us. You know, sulfonylurea chukega nahi. And we know what happened to the other Bollywood badshahs, what they're doing now. So I would call upon our friend, close friend Shah to take over next. And one size does not fit all. In debate, I always believe we never lose. We either win or we learn. And for sulfonylurea, friends, you are not a victim. Sulfonylureas are the victors.
Now I would like to introduce Dr. Tejas Shah, who is a diabetologist in Diabetes Care Center. Dr. Tejas Shah is a diabetologist and director at Ibm Diabetes Center, Mumbai. He is honorary diabetologist SL Raja Hospital, Diabetes Care Center at Malad and Andhari. He is visiting teaching faculty for fellowship diabetology at Dr. D.Y. Patil Medical College in Navi Mumbai. He is also founder and president of United Diabetes Forum, organizer, scientific committee and faculty of CID 2014, 15, 16, 17, 18, 19 and 21. He is speaker at various national conferences like CID, RSSDI, Ideacon, Diabetes India, Diacon, Ideacon, and he is practicing diabetology for past 23 years. Over to you, sir.
Thank you very much. First of all, a big thank you to the entire organizing team of Diabetes India and for the wonderful show. A special thanks to my dear friend Manohar for taking me back in time. My colleagues of my PG days, Rajiv, Manoj, all are here, and it just brought back memories as if I'm in the 1990s and we had only the sulfonylureas and metformin that we were talking about that time. And somehow I went back in that era. But anyways, sulfonylureas have been unfortunately victimized is what I have to say. That I agree that I say that there is a problem, and there is a problem which I am going to highlight in the next 10 minutes. It's a simple questions have simple answers, I always believe. What do you expect from a telephone? A simple question asked maybe 20 years back, and the answer would have been it should help me to talk and it should help me to hear. But today if I ask a small kid also, what do you expect from a phone? And the list is endless. You need to talk, you need to hear, you need to chat, you need to see movies, you need to hear music, and the list is of course endless. So a simple question was asked to my dear Bansi Sabu. I have a very rare video footage of Bansi Sabu taken in 1997, where he was asked the same thing, that what do you expect from an ideal OHA? And this is what he had to say. So he had to say is that it's basically the tight glycemic control is what he is expecting from a oral drug at a given point of time. Though Bansi Sabu has not changed for last 25 years, he still looks the same. But many things have changed in the last 20 years, as we know. It's the way we watch movies, we see how we listen to music, how everything has changed, how we talk on phone. And so in the same way, something has changed is the way we manage our patients with type 2 diabetes. From talking about two initial drugs, only sulfonylurea and metformin initially, we have come a long way, and that is what we are going to discuss today. We are not here to discuss whether sulfonylureas are good or bad or the efficacy is bad. We all know, we are all using it for the last 40 years, 50 years. And we are not debating its efficacy. We are here to talk that why they have been pushed down the line, why the position of sulfonylurea is there down below, why is it a cost on, it's an option where only cost is considered, and that is what we are going to talk about. So in the last few years, we know that data has shown that uncontrolled diabetes can lead to complications and it can lead to reducing the burden of life. But there is no trial to prove the vice versa, that if we improve the control, we prolong life. Trials like UKPD, advanced VADT, all done with sulfonylureas. Remember that. They have all failed to prove a cardiovascular benefit. There has not been a single trial which showed that the cardiovascular benefit is there if you use a drug like sulfonylurea. And so the future is basically to add an event-free life rather than just to bring the sugars down. Cardiovascular disease has been the leading cause of death. We know that 50% of deaths in people with type 2 diabetes are related to cardiovascular diseases. What we also know that 1 in 3 people basically with type 2 diabetes have established cardiovascular disease, but the fact is only 2 out of 10 people actually get a drug which is meant to reduce the cardiovascular disease, or which will help in controlling the sugars as well as in reducing the cardiovascular diseases. Things were different in the era that Manohar spoke about. Things were different in the 1990s, where people were only targeting HbA1c, and it was believed that if you bring down the HbA1c, the control, the complications will reduce. But following that, over a period of time, that was a time when drugs were approved only on the basis of HbA1c. But in 2008, rosiglitazone problem was there. FDA woke up and started introducing cardiovascular safety trials. And following that, it has been believed that we need drugs which will not only reduce blood sugars, but are giving benefits in cardiovascular diseases. So overall, we move from a glucocentric approach to a vascular glucocentric approach. So the question comes again is, can sulfonylureas reduce CV events or a 3-point MACE? Do they reduce heart failure or heart failure hospitalization? Can they give us the renal benefits with over and above the glycemic control benefits that they are giving? And can they reduce the CV deaths? Manoj showed us the last picture of Pushpa versus the Indian actors. That is what again I am coming to. Are we satisfied with 200 crores and now we are aiming for 1000 crores? So that is where we are talking about, that we want something more than what we are talking about, and we want something more benefits from a drug. So the answer is no. Despite 60 years of rich experience with sulfonylureas, there has been still no evidence, and nor Advance nor Carolina, nothing has proved that they give benefit. When it comes to pathophysiologic defects, we know that it's now working on a single pathophysiologic defect does not help. A patient with type 2 diabetes from the very beginning needs to be targeted at multiple defects, and therefore using a single drug where we are talking only about insulin secretion is not going to help, and therefore drugs which will work on multiple pathogenic benefits are the need of the hour. Sulfonylureas are the most powerful anti-hyperglycemic agents. Yes, we all agree. All diabetologists cannot do without a sulfonylurea when it comes to a patient with a higher HbA1c. But the fact again is that, are we looking only at the numbers of HbA1c? Are we looking at a drug which will reduce the blood sugar, but apart from that give us better outcomes? If you look at trials like EMPA-REG or DECLARE or any other trial, the difference in HbA1c between the placebo arm and the control arm or the drug arm was negligible. Both arms had a similar HbA1c reduction, but the outcomes benefits that were given were much superior in all these arms as compared to the sulfonylureas. So will the glucocentric approach work, or do we have to look beyond the power to reduce A1c? Let us look at some of the data that we have. Game-changing clinical trials have come up in the last 10 years. 3-point MACE reduction with LEADER. If you see LEADER, SUSTAIN 6 and EMPA-REG, all have given these benefits. Heart failure hospitalization primarily with all SGLT2 inhibitors. Renal benefits. When we talk about a patient with renal disease, we are always worried about hypoglycemia when we are using a sulfonylurea. But if we have a drugs which are giving benefits as well as stopping the progression of renal disease, why are we waiting for? If you look at the results from LEADER trial with liraglutide, again a 13% reduction in primary outcome, 22% reduction in CV death, reduction in non-fatal myocardial infarction also. SUSTAIN 6 as well as PIONEER 6 showing with semaglutide and oral semaglutide, showing that non-inferiority as well as superiority. EMPA-REG trial again with patients with established cardiovascular disease, showing a relative 38% risk reduction in terms of heart failure hospitalization and 32% reduction in overall CV death. When we talk about dedicated CKD trials, all patients with established kidney disease with GFR between 30 to 60 or 30 to 90 were there in these trials, and all showed a progression.
Less than 2 minutes.
Okay. All showed a problem in progression of diseases. Yes, modern SUs are CV neutral, but again, are we satisfied with neutrality or do we want superiority? If you look at ADOPT, Advance, UKPDS, all these trials had sulfonylurea as the baseline drug. What did UKPDS show? Yes, it showed a benefit of macrovascular disease, but when you dissect UKPD, if you look at the arm where sulfonylurea and metformin both were used, there was an increase of cardiovascular disease or mortality seen as compared to the metformin arm. So the Carolina trial, we are very happy with neutrality, but it showed a problem with increased risk of hypoglycemia and weight gain. So friends, yes, we agree that we need to do something more for sulfonylurea beyond sulfonylureas. So Manohar, definitely I think you should plan to quit ahead, or should I go ahead? Then the question comes of apoptosis. We have been talking about apoptosis with sulfonylureas for a number of years. Any drug which causes increased insulin secretion can lead to beta cell exhaustion. Hypoglycemia is not a small factor or not a small thing to talk about. It has a problem, and it is a major cause of cardiovascular disease. Meta-analyses have shown increased risk of hypoglycemia with all sulfonylureas. And that is why now we are talking about in 2022, where the problem is that sulfonylureas are right here only when cost is a concern. So friends, cost is not a concern anymore when we have a drug like a Vilda or a dapagliflozin available at a cost of sulfonylureas. Why are we even talking about cost here? So they are the cost compromise options now in today's times, and they have not been unfortunately victimized. There is a scientific evidence behind this. There is no CV protection, there is short glycemic durability, there is increased beta cell apoptosis, there is weight gain, there is increased risk of hypoglycemia, and of course cost is not we are going to worry about. Last not the least, there is something more. Today again I encountered our dear friend Dr. Bansi Sabu after 25 years, and this is what again he had to say. So, as I told you, don't concentrate on how he looks. He looks same for the last 25 years. I told you all in the very beginning, just listen to what he has to say. Thank you.
I think
that was black and white era, this is a colored era. Slide change nahi ho raha. That's what he had to say, that we are now in an era where we are looking beyond glycemic control and we are looking at mainly drugs which can improve the outcomes and which will reduce the complications. Thank you.
Dr. Manohar, for your rebuttal.
I have a very big point to make here. See, what is the topic? Topic is victimizing sulfonylurea. I never said sulfonylurea is better than the newer drugs. No. So that is the whole direction in which the debate went was wrong is what I felt. What I meant is, we know there is hypoglycemia, we know there is weight gain, we know there could be a beta cell exhaustion. We overdid it. We showed to the world it's a crime to put sulfonylurea. But Carolina and Guide trial said no, that is not the case. Secondly, technical point, he told about CVOT trial, their A1C was similar. It has to be similar. At the end of the study, 0.4 or more if the A1C difference is there, then the glycemic benefit will outweigh this thing. So what I'm trying to tell friends, I'm sure all of you would agree with you, is sulfonylurea lambi race ka goda hai. It's a marathoner like. Thank you.
At the end of the discussion, we will have the final word. So, shall we wind up this session? So, I think I thank the organizers once again. And for the next session, we invite the chairpersons, Dr. Manish Sachdeva and Dr. Anushree Mehta. Please take over the session. Thank you.
अरे भाई.
So we have a very interesting topics lined up. Our first speaker is Dr. S.R. Arvind. He is the Director and Chief Diabetologist at Ajgaonkar Hospital, Bangalore. He is also the course director for PG Studies of Health University, RGUHS and RSSDI. He is the vice president of
नहीं सर,
RSSDI.
जैसे हाँ इंट्रोड्यूस करेंगे ना आपको, ऐसे वहाँ पर चेंज हो जाएगा.
अभी तक लेकिन लोड नहीं किया है, तो उस टाइम में लोड करूँ मैं.
पेन ड्राइव है ना आपके पास? हाँ, so give it to him, he will do it.
Manohar, I think I should have called both of them who did that particular thing. Okay, so the fun is out. They're
Hello.
having a lot of fun, but
Yes.
I'm here to talk only about the science because
Yes.
that is something that makes us decide whether the modern sulfonylureas are really standing tall today and are they likely to be standing tall. Okay. Now, whenever I and you choose a particular drug, the kids' game is over, so they have gone, so we don't have to worry now.
Sorry, I didn't get you.
We all have to look at the basic things of what are the properties of
For which class?
OAD.
Let us straight away start with the glycemic action, durable glycemic control.
So
Okay?
I'm
And not compare
maybe
these
who have
alkaline
given
urias
you
with
my
any other
number?
drugs. Here, I'm not even bringing in SGLT2 into this. Now, the contenders for a sulfonylurea is only what
So
we have been
basically,
informed.
I'm not
Very
aware of the
simple.
things as
The
of
best in
now, and
class
I'm in conference. So can I call
HbA1c
you
reduction
back
is the
later?
best as far as sulfonylurea is concerned, and
Okay,
everybody,
thank
even
you.
in this debate, agreed that we should not even talk about the efficacy of sulfonylureas because they are still the best. Now it's next only to insulin, and everybody agrees. There's absolutely no dispute. Which is the best drug after insulin with respect to HbA1c reduction? It is sulfonylurea. Then why do you even want to retire your best? This is a question that I have been asking everybody. Don't retire your best. And they just said, अगर आप चाहते हो तो आप retire हो सकते हो. But why do you want to retire your best? Even now, if there is an Amitabh Bachchan movie, I mean, I would be the first one to be standing and taking it. Okay, we go to the next point. Important thing. Weight. Everybody is talking about weight. Let's look at what happened to the metabolic weight in Carolina. All that you gained was 1.5 kgs at the end of almost 6 years. And the doctors here who have come to the conference have already gained 1.2 kgs after 2 dinners. Okay, and this is what it is. You know, you have to pick something and start blaming. You know, sometimes I feel, you know, these critics are like my wife, you know. When she finds nothing wrong one particular day, she says, this shirt is not matching you, you know. She has to pick something that day. I said, okay, ho gaya comment, or is there anything else? Okay, you change and come. Okay, if that makes you happy, I'll change and come. That's what it is about the weight. You have to pick something. And look at this, 1.5 kg more than linagliptin participants, and that's a big point of contention. And I'll go back to advance and say glycoside, weight change was 0. Okay, now let's look at the next thing, you know, how the people bluff about sulfonylureas. Freedom from hypoglycemia as if it's a big problem. Such an unfair comparison. That means whoever talks of hypoglycemia will never be able to give insulin to their patients, because when once insulin is used, people don't even talk about hypoglycemia. Only when insulin is not used, you are talking about it. See, hypo is not a side effect of a drug. It is the effect of good efficacy. Okay, when DPP-4 came, I still remember, they said it does not cause hypoglycemia, especially sitagliptin. And when we did the Ramzan study in 5 countries, we showed sitagliptin arm actually had hypoglycemia. And that was the first time. And then the MSD agreed, yes, it does cause hypoglycemia. Now, any insulin, any oral agents, all patients, and this is the frequency of hypoglycemia. And I said, hypo is a good effect of the drug. All that it needs is education. If somebody complains about hypoglycemia, I complain about the doctor and say, look, you have not educated the patient about hypoglycemia. Why do you even talk about it? I will even skip this because there are some data to say that there's a very small difference, etc., etc. Let's come to the summary of the Carolina trial. And summary, they very clearly said hypoglycemia with glimepiride was 3 times higher. I agree. They had the data or something like that to show. But what they did not show, all of us, was hospitalization due to hypoglycemia was higher in the linagliptin group compared to the sulfonylurea. Nowhere that data has been shown in the Carolina trial. Cleverly hidden. 3 times higher, fine, but no death. Hospitalization was more in those who were taking linagliptin and hypoglycemia. Sometimes it's very clever medical writing which hides most of these things. And all about hypo, I mean, I don't even have to go about it because the titration was a little funny, 1 to 2 mg and from 2 mg to 3 mg and 3 mg to 4 mg. All this happened in 16 weeks. And we never do this in our real practice. When you very quickly up-titrate a sulfonylurea because it's a potent anti-hypoglycemic drug, the chance of hypoglycemia can be a little higher.
And then somebody who wrote the protocol also wrote down and convinced FDA that 4 mg of glimepiride is equivalent to 5 mg of linagliptin. I have no idea till today. I have asked people, where the hell did you get this data that 4 mg is equivalent to 5 mg? It all depends on the pancreatic effects. So with this kind of titrations, it can happen, but in real world, you always start slow and gradually titrate over a period of time, making sure that hypoglycemia does not occur. And Carolina, HbA1c was 7.2. With 7.2, I would start, if I had to start a sulfonylurea in my patient, I would start with 0.5 once a day. And then probably I will push it up to twice a day. And still teach the patients even with 0.5, if you get hypo, then you reduce it to half. I would not start with 4 mg like what they did in Carolina. Advanced trial, severe hypoglycemia 0.7 with glycoside. Now, cardio safety. I think this was shooting in their own luck, especially the DPP4 group, because when they designed the CVOT for Carolina, I don't know how the FDA also approved this. The bold step was to compare linagliptin with glimepiride. I think they thought that glimepiride would lose, and that never happened. 3-point maze, absolutely equal. Curves are hugging each other. 4-point maze, no difference between glimepiride and the linagliptin. And Lina had to say, we are not inferior to glimepiride. So we are not saying glimepiride is superior. Linagliptin said, we are not inferior to glimepiride. And again, hypoglycemia is something. Okay. Now there were charts of ADAs 2021, 2022 guidelines, and this is what ADAs say. Why are our doctors not showing the RSSDI guidelines? This is something that, you know, if there's any pharma person here, he should really ask this question. Why show the ADA guideline and say, look where your glimepiride is right at the end? Now the same big names from the American Diabetic Association, none other than Rosenstock, who was a part of the Carolina, he very clearly said that at least now I know the cardiovascular safety. It should no longer be a doubt. And somebody, the past president of ADA, Dr. Robert Eckel, clearly said, you know, I would take people off sulfonylureas, and if there was an option through the insurance that I could use other drugs, I was scared of hypo, but at least now this study has helped me that I can continue sulfonylureas very safely now. And that is coming from two great names in ADA, not coming from anybody in India. Well, cost effectiveness, I'm not even going to talk about it because we know 70% of patients pay out of pocket. And well, people can argue that, okay, now generics have come, the generics are, you know, same, equal and things like that. But again, the efficacy of sulfonylurea is so good. And then when you start a DPP4, a generic DPP4, and suddenly the patient checks the sugars after 2-3 weeks, if the sugars are not normal, then he's going to change his doctor. So it's better to start a glimepiride, especially in Indians, cost effective, teach them all about hypo, and then it moves on. So a very important thing is a patient-centric approach, and this is something that we have known. A good physician treats a disease, a great physician treats a patient who has the disease. So today the role of modern sulfonylureas in type 2 diabetes continuum is there. It's going to continue. I'm sure it is going to be there for many, many years. Winners never quit, and anybody who wants to quit will never win. And with this great person who continues to act and thrill us for so many years, sulfonylureas have remained winners for a long time, and winners will never quit. And sulfonylureas in 2022 and probably 2030 or maybe longer will continue to stand extremely tall. And even in my practice, I don't even hesitate to start a sulfonylurea. Somebody elderly, hypoglycemia is a problem, staying alone, I cannot teach. Yes, DPP4 is good, but otherwise, cost-wise, all otherwise, HbA1c reduction, everything, you look at it, sulfonylurea is the drug of choice. Thank you so very much for the patient listening. I end there because we are running late by almost 45 to 50 minutes. So I don't think there'll be any questions unless there's one quick question and then I leave.
Thank you, sir. Yeah, I have a question we can have from audience, if any.
ये सर का है अभी यहाँ पे था ना हैंड
I think the normal sulfonylurea is glimepiride. One of the biggest advantages of glimepiride is it's available in a combination with multiple other things. Glycoside is also a great drug, but it's not really cost effective like glimepiride. It's still a little bit more expensive. It still has to be given at least 10 to 15
ये
years.
दो का है फिर ये इनका है बस
I don't think there is any head-to-head trials between glycoside and glimepiride. I mean, glimepiride and glycoside, but both are good sulfonylureas. And glimepiride obviously is a little longer acting and became a little more popular.
Less dosing frequency also.
Less dosing frequency also.
Thank you, sir. We will now conclude this and we will invite another speaker, Dr. Ajgaonkar. He is going to take us through one of the most important topics in our practice, which we don't touch upon, sexual dysfunction in diabetes. Many times we fail to ask this question.
excuse me.
He is an MBBS from Aurangabad and with more than 30 years of clinical practice. He has many affiliations including RSSDI, API, MAPCOM, and he has written multiple chapters for medicine update on hydroxychloroquine, ABPM, many publications to his credit. I invite Dr. Ajgaonkar.
Good evening. At the outset, I would like to thank Diabetes India for giving me this opportunity. I would like to thank my friend for his introduction. The topic which has been given to me is sexual dysfunction in type diabetes. Basically, in our clinical practice, day-to-day practice, we see so many patients of sexual dysfunction, but no one comes and tell you that I have got such and such problem. This is the great problem which we face in our day-to-day practice. And basically, when the patient comes to you, the history is very important, and you have to ask the leading question to the patient that whether you have got a sexual problem. Patient himself will not come and tell you that I have got such and such problem. So I will, in short, go through one of the cases which we see in day-to-day practice. It is a 48 years old man having a history of type 2 diabetes with since 9 years, and he had a history of hypertension also. He complains of generalized weakness and feeling less energetic since last 3 to 4 months. He reports frequent quarrels with his wife and his significant marital strife. He smokes at least one pack of cigarette a day, but follows all the lifestyle modifications, including exercise. And on further probing, he admitted to having an erectile dysfunction, which is very common, which we see in type 2 diabetes. Almost, it is 3.5 times more common than the patients who are non-diabetic. On further probing, he admitted to having erectile dysfunction, which is becoming progressively more disturbing both his wife and himself. And he still has a strong sexual desire, but most times he cannot get an erection. On physical examination of this patient, his BMI is around 27.4. He is a little bit overweight. His blood pressure is normal. His cholesterol levels are high, which we see in most of the patients of type 2 diabetes. His HDL, LDL is normal, but triglycerides are high. HbA1c, that diabetes is not well controlled. His HbA1c is around 8. And he is on medications like metformin, glipizide, vildagliptin, metoprolol, and hydrochlorothiazide. What are the key questions in these patients particularly? What are the risk factors for ED in this particular patient? What are the treatment options which we have got? And should testosterone be obtained routinely in the initial evaluation of erectile dysfunction? This is as already I have said, sexual dysfunction is a problem in majority of the patients of type 2 diabetes. It is very common. Is underreported. Most of the patients, they don't come and tell you in history that I have got such and such problem. Is missed equally by patients as well as doctors, because doctors also they tend not to ask this type of questions because of time and all these things, and when so many times patients come to your OPD, he is not interested to tell all these things. He is close to the heart of both structurally as well as emotionally. What are the sexual problems, sexual health problems in diabetes? Mainly it is erectile dysfunction, which we see very commonly. Then there is a testosterone deficiency, but all type 2 diabetes patients, we don't investigate for testosterone. Then there is a loss of libido. Then there is a retrograde ejaculation and balanitis, which we see very commonly in type 2 diabetes patients. Patient usually present to your clinic with balanitis. In female, there is a vaginal dryness, there is a loss of libido, and decrease or absent sexual response. As already I said, there is a high prevalence of erectile dysfunction in diabetes. It is 3.5 times more than non-diabetic patient. There are so many studies and analysis of 145 studies. The prevalence of erectile dysfunction in diabetes is almost 52.5%. What are diabetes and erectile dysfunction is a complicated connection, because diabetes complications are associated with endothelial dysfunction. Mainly there is a, when patient has got a erectile dysfunction, that is said to be the earliest sign because of the, if you see the peroneal artery and brachial index, it has been reduced less than 0.6, and that is supposed to be one of the indicators of some cardiac problem, underlying cardiac problem. It can be distinguished as a macro or microvascular complication, and major diabetes comorbidities which lead to erectile dysfunctions are hypogonadism. It may cause less testosterone level. Then metabolic syndrome, that is obesity, hypertension, and dyslipidemia, which we see in almost all types of type 2 diabetes patients. And there is obstructive sleep apnea. So what are the organic causes of erectile dysfunction? It is either vascular, it can be neurogenic, it can be hormonal, or it may be because of penile injury, or it can be sometimes which the drugs which we prescribe in day-to-day practice, which I will be discussing in next few slides. What are the psychogenic causes of erectile dysfunction? There, depression is the most common cause. Then there is a performance anxiety, relationship problems, psychological problems, and psychological distress. What is the etiology of erectile dysfunction? It is a whether it is a psychogenic or whether it is organic. Erectile dysfunction commonly involves a combination of psychogenic and organic factors. Pathogenesis of erectile dysfunction, psychogenic, is a performance anxiety you see in this type of patient. There is a depression, relationship problems. Then vasculogenic, there is atherosclerotic penile arterial disease, corporal venous leakage, or traumatic arterial stenosis or occlusion. Then endocrine problems or metabolic problems like diabetes mellitus, hypogonadism, hyperprolactinemia, sulfonylurea, subthyroidism, and end-stage renal disorders. Then neurogenic, there is spinal cord injury which we see after the accidents. Then end organ damage. Then there is iatrogenic problems because of most of the times drugs. What are the risk factors for sexual dysfunction in diabetes mellitus? It is mainly a poor blood sugar control. Then there is high levels of cholesterol, high blood pressure, and patients are overweight. Age of the patient is most of the times it is more than 40 years. Smoking and physical inactivity are other risk factors for type 2 diabetes mellitus causing erectile dysfunction. Erectile dysfunction is a marker of systemic complications, which already I have said is arterial disease. Underlying cause may be arterial disease. There is a strong link of retinopathy, intermittent claudication, that is smooth muscle insufficiency. Then neuropathy, there is a depletion of neurotransmitters, reduced nitrous oxide levels. Then there is endothelial dysfunction, which is a precursor of getting patient likely to have cardiovascular problems. And then there is compounded by lifestyle factors. This is the, when you see the patients of erectile dysfunction, don't forget that hypogonadism is so many times the problem. In such patients, you get a low levels of testosterone. But in all type 2 diabetes patients, this is the study which has been published, where you don't get low levels of testosterone because we don't test it. Unless the patient has got hypogonadism, we don't test the patients of testosterone level. So in all type of type 2 diabetes patients, we don't test testosterone levels. Hypogonadism in diabetic versus non-diabetic men, which has been shown in this figure. In non-diabetic, it is almost 10 to 2.3%, and in diabetic patients, it is more than 34%. The testosterone diabetes connection is a symptomatic common ground of low testosterone and diabetes level. So low testosterone symptoms are decreased strength, loss of lean body mass, and osteoporosis. And in patients of diabetes, you see insulin resistance, advanced body fat, and elevated fasting blood glucose levels. Both these things cause fatigue, depressed mood, depression in sense of well-being, and sexual dysfunction. So these are the causes why we get erectile dysfunction in type 2 diabetes patients. Sexual health and function in women with diabetes. Sexual dysfunction for women with diabetes is more common than for women without diabetes. Lack of vaginal lubrication, pain during sex, and inability for orgasm can be a consequence of high or low blood glucose levels. Higher rates of depression in people with diabetes can lead to low sexual drive. Wearing of diabetes devices such as pumps, glucose monitors, or lumps from lipo hypertrophy around insulin injection sites may affect body image and self-esteem, and inconvenience of self-managing diabetes may affect the spontaneity of sex. What is the impact of sexual dysfunction? Whether it can be on the individual or on the partner. So there are on the partner it is anxiety, frustration, anger, and deflated self-esteem. So all these things, whether it is on individual or on the partner, it can cause a relationship problem. It may cause unhappiness on sexual relationship, impaired communication, sexual or non-sexual, violence due to jealousy, marital breakdown, divorce, and poor role model for children. So how you evaluate these patients of erectile dysfunction is physical examination is very important, particularly history is very important in these patients. Femoral and peripheral pulses, as we see in all type 2 diabetes patients. Then penile brachial index, which already I have said it is done by Doppler studies, where you see the index goes below 0.6, then it is said that this patient has got a erectile dysfunction. Then you can see for femoral bruise for finding out the stenosis of the arteries. Then visual field defects, focal neurological deficits. Then breast examination of these patients you have to see, and this patient has got a gynecomastia. Then penile stricture, then testicular atrophy also we can see, and features of hypogonadism. Do not forget the history, which already I have said. History is very important in these patients. The most important part is how you treat these patients. Most important is control of blood sugar levels, blood pressure and lipid control, address end organ damage, avoiding or substituting medication that may contribute to erectile dysfunction. There are some medicines which may cause erectile dysfunction. These medicines you must omit. Then once erectile dysfunction has developed, oral agents are considered as first line therapy. So what are the frequently used medications that are associated with erectile dysfunction? Mainly antihypertensive drugs, which we are using in day-to-day practice to treating patients of hypertension, because diabetes and hypertension are they are coexistent. The drugs which are used and cause erectile dysfunction are thiazide diureters, beta blockers, calcium channel blockers, angiotensin converting enzyme inhibitors. Antidepressants are very important. They also can cause erectile dysfunction. Then antiarrhythmics, e.g. digoxin, anti-androgens, and histamine receptor antagonists like cimetidine, which we are using in the past, and recreational drug agents of abuse, that is cocaine and marijuana. What are the treatment options of erectile dysfunction? Main is oral drugs on demand or daily. These are phosphodiesterase inhibitors. They are mainly used, that is like tadalafil, sildenafil are the drugs which are used commonly. And the patient's education is very important in these types. Whether you should replace with testosterone therapy in all these patients, unless there is hypogonadism, you are not supposed to give these drugs, whether like testosterone substitutes. Then you can use these implants and all these things in these type of patients. And the most important thing in this patient is the counseling. Erectile dysfunction is a common complication of diabetes. It can impair quality of life, self-esteem, and relationship with partner, which can impact day-to-day life. Refer to psychologists for couple therapy, which will open up communication and ease tension. So management of erectile dysfunction and coronary artery disease share the risk factors like dyslipidemia, hypertension, smoking, diabetes, all these things. Erectile dysfunction may be a predictor and precursor of cardiovascular disease, and erectile dysfunction confers 1.46-fold increased risk of cardiovascular disease. Then men with proven or suspected vasculogenic erectile dysfunction or multiple vascular risk factors, especially diabetes mellitus, should be screened for silent myocardial ischemia. So these are the patients who have got erectile dysfunction are likely to go for the myocardial disorder, coronary artery calcium score, and coronary computerized tomography angiography. This is a consensus guidelines for management of erectile dysfunction. You can see here. And these patients should be treated. Mainly the counseling is very important in these patients. And you have to grade the patient whether he has got high risk, medium risk or low risk. Accordingly, you have to treat the patients if the patient has cardiovascular disorder in addition. Effects of novel anti-diabetic drugs, which are GLP-1 receptors, DPP-4 inhibitors and SGLT2 inhibitors, ultimately they improve the blood sugar level and endothelial function as well, which will try to improve their this erectile dysfunction. In summary, sexual dysfunctions are common in people with diabetes. It may arise from a variety of vascular, neurological and hormonal derangements. Sexual problems related to diabetes extend beyond erectile dysfunction and include sexual desire and ejaculatory dysfunction in men. Variety of sexual concerns are common in women, and management of underlying diabetic condition may markedly improve sexual quality of life in patients with diabetes. Thank you very much.
Thank you, Dr. Narayan. We have time for one question, if any.
Is there some rule of low dose, like sildenafil take?
There is a study which has been published. There is a role of tadalafil, low dose tadalafil. 2.5 to 5 milligram tadalafil can be used in this type of patient for a long term. So this can be used, but sildenafil, the effect is very short, it is 4 to 6 hours. But the effect of tadalafil, I think it is almost for 24 to 36 hours. So tadalafil can be used in this type of patients. Yes.
Hypertension drug of choice in ED.
Yes.
Drug of choice for hypertension in ED.
Basically, the history is very important. If the patient, almost all anti-hypertensive drugs are causing this type of problems, but depending on the history and quality of life of the patient, you can use the drug. Because almost all the drugs which we use in as anti-hypertensive cause erectile dysfunction. There is no specific drug which can be used here, because almost all the drugs we are using in day-to-day practice.
Could not cut it down that how you got some except the erectile dysfunction problem.
Yes.
So I think that should be avoided.
Yes, sir. Even beta blockers. Even
Beta blockers, yes. But not cut it down as a specific problem with this CD.
Mainly it is the beta blockers which we are using very commonly in patients with diabetes.
But which beta? Not all beta blockers.
Not all beta blockers, but
basically bisoprolol.
Yes.
Isn't it?
Sir, as neglibolol releases nitrous oxide, can be choice of hypertensive in EDs?
I think so. You can. Yeah.
For tadalafil, what is the period of trial that you spoke of 5 milligram? Till what duration is it?
Actually, there is a trial which has been published almost it is a trial of almost 1 month. And they is not more, it is of 1 month trial. And they have said that it is useful. So long-term use of tadalafil is advisable in these type of patients. Even daily tadalafil is used, and depending on the patient's response, you can continue it.
Sir, actually, in those group of patients, have they done the baseline LHFS and testosterone in all patients?
He is asking whether hormonal study, LHFS, testosterone need to be done in all ED.
No, it is not. It is not advisable. There is one study which has been published. They said it is not required to do in all type of patients unless the patient has got a hypogonadism.
No, but if you are not doing, how can you know patient is having hypogonadism? And suppose patient is having hypogonadism, you have not replaced.
Then the study which has been just I shown the one study. They have said that because in non-diabetic as well as diabetic, you can get a low testosterone levels.
Also, diabetes itself is significantly associated with hypogonadism. Those who are diabetic, their free testosterone is low, and all studies have clearly shown in comparison to the normal population, those who are diabetic, actually they have increased risk of hypogonadism. Yes. If you are not doing a LHFS testo, suppose someone is having hypogonadism, you are not replacing with testo and you are giving tadalafil. Are you going to get the benefit?
Basically,
probably not.
No, basically.
First you have to give testo, then you can plan for tadalafil.
Yes.
So if you are not doing a baseline hormonal evaluation, probably it's not a generalized thing for everything.
But as in general, in all type 2 diabetes patients, they are not advised to do a testosterone levels.
Absolutely.
Unless the patient has got a hypogonadism. So this was the study which has been published, and these are the recommendations.
Thank you, sir. We will start with another speaker. Thank you, sir.
Thank you, sir. Thank you.
We have another speaker, Dr. Amit Saraf from Thane. He is an MD physician, and he will be guiding us through urinary tract infection when to treating diabetes. He is attached to Jupiter Hospital in Thane. Head Quality Control, Jupiter Hospital, International Advisor, India for RCP London. Reviewer of BMG and Annals of Internal Medicine, MRCP London Examiner, DNP Teacher and MD Examiner, National API Government.
While they are setting up the screen, I just want to answer the question on top of everybody's mind. Kitna slides hai? 15 slide. First slide has to be the title slide. Last slide has to be the thank you slide. So 13 slides. Okay, that is the question. When I was a delegate for years together, I thought a disclaimer should always say kitna slides hai. So audience could plan their time. So 13 slides, bear with me. Actually, my take-home message is in a single slide, but since to make up for the time, I have made a little of a presentation, so please bear with me. And another thing is, somewhere on the brochure, it is symptomatic bacteria in a diabetic to treat or not treat it. There is no, so that's a no-brainer. My topic is asymptomatic, them is the A. So I think that's another point. So congratulations, I think at the outset to Dr. Bansi Sabu, Dr. Manoj Chawla, the entire team of Diabetes India 2022. I think a phenomenal job. There is a big round of applause, and I think a wonderful job. Very well done for the entire team. As always, I start with my conclusion slide. If you have understood this, my job is done right on this slide. So what are we trying to conclude from treatment of asymptomatic UTI in a diabetic patient? What are we trying to say? UTIs are extremely common, but you need to look for them. You need to ask a diabetic. We look for sugars, we look for their symptoms. But why not a simple routine microscopy? Still one of the cheapest tests available in microbiology lab. Look for the UTI rather than waiting for the symptoms to develop. Second concluding message, treatment of UTI without a proper diagnosis may lead to an antimicrobial drug resistance. So UTI dikha, antibiotic diya, that's not the way forward. You need to actually find out if the symptomatology is there. Third point, treatment with antimicrobials obviously then should be as per the culture reports. So most of the guidelines abroad have to be as per culture, whether it's a blood culture sent out, urine culture sent out, any infection, any antibiotic of choice is strictly as per culture report. So we talk about so many guidelines here, physicians, all of us, we talk about ADA and so many guidelines. I think when it comes to antimicrobial policies of ours, we should as a consensus say that we need to send a culture on day of admission or the first consultation, and then we choose a broad spectrum and change as per the culture sensitivity. After that, only bacteriuria with symptoms of UTI should be treated with antibiotics to avoid the spread of a drug resistance pathogen. And the last point, diabetic females, diabetic overweight and obese individuals are the patients with highest risk of UTI. So having said that, why is it that a diabetic has most common UTI amongst other patients? The idea also says that not only once in the lifetime of diabetes, this patient has a lot of chance of recurrence of UTI as he goes along. And diabetic female, as I said, overweight and obese individuals are the highest risk. And why is all of that so? One, it's a high glucose concentration in the urine. We are all aware of that, and that leads to colonization. So because of the high sugars, everybody loves sugars. We love sugars, the organism also loves sugars. They want to colonize in the urinary tract and thereby grow there. High glucose concentration in the urine is leading to thereby a rapid and a rich bacterial multiplication. So they are alive and they are thriving. It's like humanity, it's like Bombay City, just alive and growing up, skyscrapers coming up, sprouting up at every junction now. So that's how the organism, they're loving it. They love the sugar in the urine and they're multiplying. Top it off, a diabetic, the poor fellow, has immunological defects. He has impaired neutrophilic function, he has reduced T cell mediated immune responses, a lower level of prostaglandin E, which works locally there for innate immunity. The thromboxane B2 and the leukotriene B4 are also low in a diabetic. And a bladder dysfunction is going to contribute all of that to aiding formation of UTI. So that's why a diabetic does have UTI pretty commonly. What are the types we see? Asymptomatic ones. So these are the health checkup guys who walk into your OPD. They have a health checkup report, a lady most commonly, that typical pus cell count of 7 to 8, you ask her any fever, any dysuria, and she's absolutely asymptomatic, sugars a little on the border. What do we do? So that's one category of people, asymptomatic infections. Acute cystitis, they run to you. That's a very, that's a situation which we end up seeing a lot in diabetics, unfortunately. Complicated lower UTIs, which are mostly as catheter indwelling devices associated ones, uncomplicated pyelonephritis and complicated pyelonephritis with urosepsis are certain types of UTIs we end up seeing. The pathogenesis we saw in a nutshell in the previous slide. This is a bit more in detail. There is contamination of the periurethral area with a uropathogen, sometime from the gut, most commonly E. coli. This organism colonizes in the urethra and migrates to the bladder. After that, two things happen: colonization and invasion of the bladder, mediated via the pili and the adhesions, and inflammation response to the bladder and fibrinogen accumulation by the catheter, all lead to neutrophilic infiltration, bladder bacterial multiplication, biofilm formation, epithelial damage, ascension to the kidneys, colonization of the kidneys, host tissue damage by bacterial toxins, and finally bacteremia. So that's how it ascends and causes a lot of problems in a diabetic individual. How do we diagnose all of this? So as the age-old dictum goes, midstream urine. Tell your diabetic to hold the sterile container, pass the initial bit of urine, then quickly collect in the midstream sample and then give it to the lab for examination. Pyuria is most likely seen. So what does pyuria mean? Just presence of pus cells in the urine sample. Sometimes bacteriuria is missed. So colonization in the absence of a pyuria on a microscopic assessment can suggest colonization. So don't forget this, instead of infection, especially when there is bacteria. So you can just find at times a sterile sample, but colonization can still be present. These are the samples you should need to send for culture examinations. Microscopic examination can allow visualization of the bacteria in the urine, and a dipstick test, very, very important for the presence of urinary nitrite. You have to see that on a urine routine. If the nitrite is positive, most likely some colonization, some infection is happening. And what do we pick up? Most common E. coli, as we said, feco-oral contamination, urinary contamination, pretty much common. Klebsiella, Proteus, Pseudomonas, the top four, which are majorly, as physicians, we dread these. Enterobacter aerogenans, Proteus mirabilis, the Citrobacter furundii, Streptococcus, Staphylococcus aureus, and S. epidermidis, all of them contribute to causing UTIs. How do we manage? Depends upon various factors. Are the symptoms? Is it upper UTI, lower UTI, presence of urological abnormalities, severity of the systemic symptoms, and whether occurring with metabolic derangements and renal function derangements as well. But mostly, in a nutshell, acute cystitis management is basically first control the sugars. Probably put in the patient in indoor management, start with insulin, control the sugars. Treatment is tailored again as per a culture report. First line before the culture comes in hand, nitrofurantoin, phosphomycin, and your age-old Septran. These are guidelines even today taken from the NHS. This is 2022 Jan NHS guideline. They still talk about Septran, your trimethoprim sulfamethoxazole, not about a higher antibiotic. So nitrofurantoin, phosphomycin, and Septran will do the trick at times. Then the culture comes in hand, you tailor make as per the culture report. And second line, then you can shift to quinolones and beta-lactams as per the culture sensitivity. Pyelonephritis, the infection has gone up to the kidneys. Hospitalization, obviously, IV antibiotic therapy, cephalosporins, piperacillin, tazobactam, and carbapenems are the top ones. The others also use, and they are all guided by the urine culture report and sensitivity. This is my talk on a single slide. Do we treat asymptomatic UTIs in diabetics? In 3 lines. 1, zero advantage found over some years of research. So to answer what I said first, a person walking into your clinic with a health checkup report, typical 54-year-old female, diabetic for last 15 years, some 8-7 pus cells in the urine, asymptomatic on the urine front, borderline sugars. Do we treat? No, because no advantage has been found in treating such a patient. That's the first point. Second, this leads to antimicrobial resistance. Remember that point. So just treating, then you try to get the pus cell count back to normal, and it's somewhere as physician we need to see, because I don't know how many of you have encountered this. Most of the stringent health checkup guidelines are from pilots and army. So a lot of people come for fitnesses, especially would-be pilots and would-be army recruits, saying that my so-and-so officer is saying that till this count doesn't come back to normal, he will not give me fitness. So somewhere as physicians we need to know, and we need to write back that if it's asymptomatic and it's just going to lead to antimicrobial resistance, we will not put an antibiotic just to get the count back to normal. And the only indication for asymptomatic bacteriuria in a diabetic to treat without symptoms is GDM, a gestational diabetes mellitus. Only indication, you are justified in doing so, obviously for the risks involved to the mother and thereby the fetus. Conclusion again, so UTI is pretty common. Look for them rather than they looking for you. The treatment is as per proper diagnosis, and otherwise will lead to antimicrobial resistance. Treatment is based on the culture reports. Only bacteriuria with symptoms should be treated, and diabetic female looked into, overweight people looked into, obese people looked into. As I said, 15 slide. Thank you so much for a patient hearing. अभी लेट हो गया यार, डिनर का टाइम है, ड्रिंक्स का टाइम है, क्वेश्चंस सर तो पूछेंगे या
Culture positive total count is slightly high. Second, in relation is we see quite a
they repeat a culture 2 to 4 weeks later after stopping the antibiotic, and they come with highly resistant, even CAR-bar resistant assays. So what do we do in that context?
So that's a very, so first part of your question is easy to answer, that culture positive symptoms treat with a sensitive antibiotic. Second part of your question, which again as physicians we encounter a lot, say if cholesterol sensitivity here, others are intermediate, mostly are resistant. I think the mostly to look at the MAC is very important. Look at the minimum inhibitory concentration onto the culture report, and sometimes even picking and choosing a resistant antibiotic with a choice, with a combination of another one can work, especially if you control the sugars well, repeat a urine routine, repeat a culture, try to find out more, and don't forget fungal colonization. Most of the time we fail to send across urine sample for fungal cultures as well. We concentrate only upon the bacterial colonization, and sometimes a coexistent fungal infection can also be there. Yes, sir.
GDM patient with bacteriuria and that culture negative, which antibiotic?
Standard. Penicillin group, safe, yes, sir. Mostly advocated. All of them are very safe for a mother, her fetus, to be started.
And how long?
So till the culture is in your hands. If the culture is then negative, then a 7-day course should suffice. And then at the end of it, again a very valid point. When do we stop? Easiest answer, repeat a urine routine. Because GDM है asymptomatic है. Sir is rightly asking symptoms in it. How do you stop? When do you stop? So ideally start of the treatment at a urine routine microscopy and a culture, and then end of therapy 7 days के बाद simple urine routine. First cell count is down. Hopefully the bacteria are down. You can stop the antibiotic.
Dr. Saab, very nice presentation. Just you told the asymptomatic cases, culture negative. You have not to treat, but how to tackle that case? Because many times many female patients coming and showing the results, and they really headache to the physician.
So again a very valid question. So ideally you refer them to a gynecologist. The pelvic floor musculature of a woman post pregnancy has become very lax. The orifices have become very lax. They will keep on coming to with routine and repeated UTIs. The gynac teaches them pelvic floor exercises. And that simple remedy actually goes a long way in preventing repeated UTIs in a woman, especially a woman. Because mostly due to pregnancies, normal deliveries, cesarean section वाले नहीं, उनमें हो सकता है, but mostly the normal delivery वाला, the laxity will keep on causing that rectal and urethral cross contamination.
Post-menopausal period, in spite of using all kind of precautions, having repeated candidal infections, in how long can we use antifungals and how should we proceed?
I'll have to scratch my head to answer that. So point is, as Dr. Devakar also mentioned in the slide, they have a dry vagina, a lot of problems happening because of diabetes and age itself. Hormonal deficiency and sugar rise is a bad combination for such a female. So ideally speaking, the answer to your question is dictated again by the cultures. You start with a fungal culture, isolate the organism, isolate the antifungal towards it, start the antifungal. End of 7 days or 14 days, you repeat a urine routine microscopy and decide then. That is what I would do, but then gynacs are better well versed because they give a lot of local applications, vaginal pessaries and stuff.
So in spite of local pessaries, that patient is recurrently
No idea. Absolutely, anybody can answer.
Just if the patient is on SGLT2 inhibitors, then they should.
No, she is not on SGLT2.
I'm sure Dr.
I'll meet you at the bar.
Yeah.
Actually, there is a general question.
Can I invite the chairpersons for the next session? We have Dr. Suresh Purohit, who is a diabetologist from Mumbai.
अभी सर आएंगे
He's
इनके
also an
साथ.
MBA. In Gujarati we say that means Mahal to And we have Dr. Abhishek Srivastava, who is a chief endocrinologist from Jabalpur, Madhya Pradesh.
Thank you, Anushri, and thanks.
Hello. Yeah. Thanks to organizer for inviting us and giving this opportunity to chair this session. So I will invite our first speaker. We are already running late, and our speaker is Dr. N.K. Singh. He is a diabetologist physician in from Dhanbad, and he has lot of accolades to his credit, and we are running short of time, so we will start as soon as possible. Yeah, Dr. N.K. Singh, please.
Good evening. I think it is really too late, but I will try to finish as early as possible. Thank you, chairpersons. Thank you, Diabetes India, for giving this very unique topic, that is unleashing the potential for renal protection with SGLT2 inhibitors. What are the clinical perspectives? कहाँ से आ रहा है यार? Change नहीं हो रही देखो. Yeah. So my agenda is, when you give SGLT2 inhibitors to the hearts of untreated diabetics, lots of things you know that is going to happen. What is happening with the kidneys if you are giving the SGLT2 inhibitors? Is it the same? That is to settle the agenda today. Today we are in the 2022, and the great leap forward is there. Initial concerns about the SGLT2 inhibitors that was focused on possible detrimental effects on the renal system, particularly to increase genitourinary infections, compromise bladder health, and aggravate acute kidney injury. That my worry in our mind that has eased today in this 2022. And the apprehension with this drug molecule, that if you give the SGLT2 inhibitors that cause a temporary dip in eGFR and cause a persistent reduction in plasma volume and blood pressure, that has again taken a positive shape. So again, this is something very unique is happening in diabetology. And cardiovascular outcomes trials and the real world studies have identified the potential advantageous effect of these molecules to reduce the risk of onset and progression of several cardiovascular conditions and to preserve kidney functions. So my vision is that we have a great leap forward with this molecule, and as you know that this molecule comes from this florogene that is isolated from apples, and you are well aware that an apple a day, today we can say more precisely an analog of a chemical in the bark of an apple tree, that you give SGLT2 inhibitors to a patient in case the heart failure and kidney failure away. So this is again a very important message. Now in short, what is the relation of diabetes and kidney? Rishta kya hai? So over the last 2 decades, at variance with this cardiovascular morbidity and mortality, which has progressively declined in patients with diabetes over the last 2 decades, the trend in microvascular complication has remained substantially unchanged. So आप दवा देते जा रहे हो, लेकिन microvascular complications they have not changed. This is unchanged. So in particular, this DKD, the diabetic kidney disease, that accounts for 60% of new patients beginning renal replacement therapy. This is worldwide data. And its prevalence has shown only a slight reduction in the recent years. And even if you give it the Indian study, which like this study of ICKD study, we have a huge problem with diabetics, with diabetic kidney disease and CKD. So one of the most common these complications of diabetes is very important is CKD and DKD. And as I told you, this is the leading cause of ESRD, that is accounts for 45% of all causes. So DKD is a major contributor to CKD and ESRD, and it also portends worse outcomes within a 5-year survival rate of less than 40% if the patient has got ESRD. So this DKD has been shown to be a large contributor to the excess risk for all cause and cardiovascular disease mortality amongst type 2 patients. So this is a scenario. So the greatest increase in this prevalence has occurred even in the low to middle income countries like India. So incidence of cardiovascular disease in patients with type 2 diabetes has improved. That is very important things has happened. But this effect has not been associated with any substantial reduction in type 2 diabetic patient associated renal impairment. So this is a crux of the problem today. And what is happening? So today you have got the RAS blockade and has been the last successful drug class for your GFR preservation, independent of the effect on the blood pressure. And you are well aware of all the renal trial and this IDNT trials that showed that losartan and irbesartan, they reduced this composite kidney endpoints around in the tune of 15 to 20%. But unfortunately, this disease, the diabetic kidney subjects, and you are giving the RAS blockade, still progress to the kidney failure and at a very significant pace. So this is the problem. And so nephrologists today feel that what we are going to do, that we are trying to using these daggers to fight the fire, breathing dragon with this dragon, diabetic kidney disease, and our weapon is so weak. So today the CVOT has showed that these agents may fit this bill, the canvas and EMPA-REC, not only showed CV protection, but well aware, you are aware that also kidney endpoints. So while advances had been made in the treatment of various glomerulonephropathies, the mantra for DKD seemed to be fixed on the time-tested but erect principles of the managing any kidney disease, namely the blood pressure control, proteinuria reduction, and we have got definitely the ACE inhibitors in ARB. But this approach has been unsatisfactory and high rate of kidney failure and death is occurring. So what to do? So what next? So it is important to remember that the majority of our patients, more than 80%, in the early SGLT2 trials were on the ACE inhibitors or ARB and all the patients. And in CREDENCE, we are on maximally tolerated dose of the ARB and ARBs. So CKD inhibitors work in patients with DKD or RAS blockade, which produces efferent vasoconstriction, but the crucial question still remains. And so today it is time to change the terminology of this group of molecules, that is, it is a cardioprotective drug and the nephroprotective drug, and I say it is a new nectar in the diabetes. And I'm not going to tell you all the details of the effects, but in 2 slides, let us see what is happening. What is happening in the DKD? There is persistent hyperglycemia, upregulates the glucose reabsorption, and secondarily, sodium and chloride reabsorption in the proximal tubules. We are well aware. And this decreases sodium and chloride delivery to the macula densa, which is mistaken for the decreased kidney perfusion. This results in decreased adenosine production and a decrease in afferent arterial tone, encouraging blood flow to the glomerular signal. So this is happening. But if you are using SGLT2 inhibitors in such cases, the glucose reabsorption is blocked in the proximal tubule. This increases sodium delivery to the thick ascending lip of the loop of Henle. This increases the activity of the sodium potassium chloride co-transporters as energy requiring process where adenosine triphosphate is broken down to adenosine, and increased adenosine, this acts in paracrine manner on the afferent arteriole smooth muscle cells and leads to afferent arteriole vasoconstriction, decreasing this blood flow to the glomerulus. So this afferent vasoconstriction combines synergistically with the efferent vasodilatation produced by the RAS blockade to reduce the intraglomerular pressure and glomerular filtration. So things are just changing. So when patients are using these SGLT2 inhibitors, in such cases, the whole process is reversed. Inflammation decreasing, fibrosis decreasing, the oxygen consumption is decreasing, hypoxia is decreasing, and alteration in energy metabolism is changing, and so we are getting the cardio protection and also this kidney protection. So like this is like a Hunt's remedy, which never fails. And SGLT2 inhibitors increase also the erythropoiesis and may improve the anemia in patients with CKD and HREF. So this is again an important slide showing that the kidney body is as a direct modulator of intracellular nutrient signals is talk of 2022. So in diabetes, happening renal mTOR C1 hyperactivation, and if you are giving the SGLT2 inhibitors, the ketone body is increasing, so leading to this altered intracellular nutrient signals. this hyperactivation of the mechanistic target of this mTORC1 and strongly associated with the both this proximal tubular epithelial cell and podocyte damage which is happening, that decreases the inhibition of overactive this mTORC and signaling and represent a therapy for non-protonic and protonic DKD. So this is what is happening. So there are lots of renal and extrarenal mechanism of actions of happening. Renal you are showing here and the extrarenals, I'm not going to repeat it. So ultimately with all these mechanisms of action and clinical effects, renal protection is happening. Next part is, what is the data today we have? In 2020, this that stands the test of time. How this renal protection by SGLT2 inhibitor happening? So we have data from the CVOTs and we have data also from the renal trials. And all starts with this, as you know, the EMPA-REG outcomes. And EMPA consistently, where we consistently showed EMPA-REG that the rate of eGFR decline across all risk categories. This is quite evident here from the cartoon. So this resulted in regression of albuminuria status in patients with type 2 diabetes and prior albuminuria from the EMPA-REG outcome. And solid kidney outcomes using different definitions of substantial loss of kidney functions with EMPA-REG, CANVAS and declared TIMI or VertiCB, you can see what is happening with the HR. So this is just really very, very impressive. But the first landmark trial that highlights the power of SGLT2 inhibitors, I say, was the CREDENCE. And this was a silver lining in the dark cloud of the diabetic nephropathy. And the conclusion of CREDENCE trial are certainly exciting for us managing DKD and CANA with significant benefits in both renal and cardiovascular outcomes even in individuals with more advanced CKD. They used a more advanced CKD, and the fact that this benefit is observed even on a background of maximal ACE or ARB was very encouraging. So I'm not going details of that. This CREDENCE trial is very important, showing all the key renal and CV outcomes which favor this CANA. But later on, more good news came and from the CREDENCE, and that was the DAPA CKD, Emperor reduced, Emperor preserved, VertiCB, and now the EMPA kidney. So these are very, very landmark trials which have shown. And ultimately, if you see the kidney outcomes using generally consistent definitions, even the pooled estimates, that all favors the SGLT2 inhibitors these days. And if you see that this confers the meaningful kidney benefits, regardless of the even the patient is diabetic or non-diabetic.
Sorry, excuse me.
2 minutes only. Yeah, I'm just finishing. And we have got the Emperor reduced study, which also giving the same message, and this low, even this will be well shown here. And if you go with EMPA, I've not escaped this slide. So you see here also from the Emperor preserved, the summary of key results is again favoring all the key secondary endpoints in favor of SGLT2 inhibitors. And this, so EMPA protects the kidney by significantly slowing the decline in kidney function. And there a catalyzed change came with the deep DAPA CKD, giving the same message that reduce the risk of kidney failure, reduce the risk of CV death or heart failure, hospitalization, and prolonged survival. And so later on, this shows very that there was a significant victory with the without diabetes also. And then there came this EMPA kidney, which is the third major trial of an agent which tested in patients with CKD to be stopped early because of positive results that made a pre-specified things. So there are lots of this side again important, that the EMPA kidney expands the scope of types of patients with CKD which we are using in our clinical practice. And CREDENCE tested CANA only in patients with type 2 diabetes and diabetic nephropathy. But DAPA CKD, 2/3 of enrolled patients had type 2 diabetes and all had CKD. And EMPA kidney, 46 patients of the 6609 enrolled patients had diabetes, including a very small number with type 1 diabetes. And another departure was very significant, that the EMPA kidney, 20% of patients did not have albuminuria. So this gives again a very, very important thing in the field of this nephrology with diabetes and also. So EMPA kidney is very, very important trial. I'm not going to details of the trial, but you can see here, this is a reflective of the CKD population globally, where the majority of the patients do not have severely increased albuminuria. 50 to 70% of CKD patients do not have type 2 diabetes also. So this is a very, very important message coming from the EMPA. There are lots of real-world studies. This shows how the flow, what is happening next with this flow or another remodel trial all will come. But message from Diet 19. I will not go in detail, but it is also giving very safety signals of the DAPA in the COVID cases also. So lastly, the big picture which is emerging with the SGLT2 inhibitors, that the slowing in the eGFR decline by 0.5 to 1 ml per minute predicts long-term risk reduction of the CKD events. You can see, and this is shown after this canvas reduction of eGFR decline. So average patient would develop eGFR by over 15 years. This is one calculation. Dr. A.K. Singh is here. He will say whether this calculation is valid or not, but this is also from the NEGM, that 15 years you get if you use this. Lastly, this very important point that the SGLT, if you are using the SGLT inhibitor and GLP-1RA, then there is lower risk of MACE in those with atherosclerotic cardiovascular disease, but this only SGLT inhibitors exert improve HHF and kidney disease progression. So somewhere it is scoring over that, I think. And also the guidelines are quite clear with the ADA KDIGO guidelines. Even the eGFR more than 25, you can use it. So let's go in details of that. Just concluding my talk, the final points are that in the 2022 therapies are effective down to eGFR of 25. It is critical for cardio, kidney, metabolic physicians to discard the old obsolete eGFR threshold of 45 or 60 that were based on glycemic factors rather than heart or kidney protection. So this is a crystal ball SGLT2 genomics where you can use it, and don't go, the SGLT2 inhibitors are an important weapon in our arsenal against not only type 2 diabetes but also the conditions that we encounter that go in hand in hand, including the CKD and the cardiovascular disease. Lastly, the frontline clinicians should initiate SGLT inhibitors for patients with type 2 diabetes and diabetic kidney disease who have an eGFR of at least 30. So you must start it. And differing initiation of SGLT inhibitors to a specialist, you are suffering that you are going for nephrologist or endocrinologist, that will result in a faster progression of diabetic kidney disease, irrespective of the glycemic control, and it is crucial to initiate these medications as early as possible. And prescribers should be aware of the initial reversible drop in eGFR of approximately 5 to 8 ml. That will happen, but in the next first 2 weeks after starting this molecule, which is due to hemodynamic effect of the drug. So using SGLT2 inhibitors can slow the decline in eGFR, reduce the onset of micronuria, and slowly reverse the progression of proteinuria. Thank you very much.
Thank you very much. Yeah.
Thank you.
So you concluded well in time.
Yeah.
Thank you very much. And now we'll invite our and if there is any question, we will take at the end. So I invite Dr. Puneet Saxena. He is a very well-known figure in the field of diabetes. He is from Jaipur, and he will be taking over the next lecture.
बोले तो
Good evening, everybody. And I've been given this task of speaking on paradoxes in diabetes, and there have been many in the past which have been resolved by observations in science, and there have been going on every day there is something has been observed and it is classified as paradox which does not match the notion or the popular belief, and it doesn't fall in line with the guidelines that falls into the category of paradoxes in diabetes. And I am going to discuss few. There may be many more, and many more may come up with passage of time, but so I always start with some part of epidemiology just to stress upon that we are discussing something very important. So diabetes, one of the top killers, first 10 causes of death globally, and it increases the risk by 2 to 3-fold. And so every deliberation and every talk on diabetes makes it more important than what we are discussing. So hyperglycemia is the manifestation, and you can say the primary biomarker, but there is a disturbance of carbohydrate, fat, and protein metabolism which is underlying, and which gives rise to the paradoxes. And there are certain paradoxes which I am going to discuss today. The first one is the paradox of diabetes and obesity. What is that? So despite the role of obesity in development of chronic comorbidities, once these conditions are manifested, being overweight may provide some protection. So this is providing protection rather than being adverse. So this has been termed the obesity paradox, and it's based on the observation that obese patients with cardiovascular disease survive longer than their normal weight counterparts with cardiovascular disease. And the studies have shown that individuals with established CVD and heart failure with moderate degrees of obesity present a more favorable prognosis than those who are normal or underweight. So our common belief is that the obese people will suffer more in terms of morbidity and mortality, but it is not like that. And why it is so? Obesity has been called the mother of all diseases, and is strongly linked to diabetes, and mainly its abdominal form is considered the major risk factor for not only type 2 diabetes but for lipid disorders, hypertension, coronary heart disease, and certain cancers also. And if you see that for characterization of relative risk of mortality and morbidity, the rates in underweight, overweight, class 1 obesity, class 2 obesity, and class 3 obesity are compared with those in normal weight subjects to understand that why obesity and what obesity is causing in diabetes. So the common belief is that mortality increases as BMI increases above 25, and as the BMI decreases below 25, there is a survival benefit. But during the past decade, rather not a past decade, it was more than 2 decades, there is an increasing evidence that the patients, especially the elderly, with several chronic diseases and elevated BMI may demonstrate lower all-cause and cardiovascular mortality compared with the patients of normal weight. And the association of diabetic complications with obesity has consistently shown paradoxical results. And in people with diabetes with a higher body mass index up to class 1, please note that it's up to class 1, obesity seems to have a protective effect. It's only class 2, class 3 and above that the diabetics face worse outcomes, but up to 1, it's in favor. So in patient with type 2 diabetes and cardiovascular comorbidity, overweight and obese patients, lower mortality compared with normal weighted subjects have been seen. And not only this, weight loss and not weight gain was associated with increased morbidity and mortality during the mean follow-up of 34 months in one of the studies. So normally what we are advising to our patients is go for weight loss. But what has been seen in this study is that weight loss is creating more problems. And not only this, amputation risk decreased in diabetic men with increasing BMI. High mortality rates were observed in hemodialysis patients who were diabetic, suffering from end-stage renal disease because of diabetes. And those who exhibited lower BMI and weight loss, they fared better, they fared worse than the people, those who were obese. And a partial explanation was given was that there is a lower BMI weight, the obese people, they have lesser muscle mass and therefore they have lower creatinine levels for their body mass index. See, another meta-cell is from Scotland. Almost 30,000 overweight and obese patients were studied of type 2 diabetes in terms of cardiovascular complication, and it was concluded that within patients with BMI up to 40, there was no difference in the incidence of all-cause mortality, myocardial infarction, congestive heart failure, even peripheral vascular disease and cerebrovascular disease. So even up to 40, no difference between the lean and the obese. And only when the BMI was more than 40, an increase in incidence of all-cause mortality and congestive heart failure and other complications was seen. And the current belief in the scientific community is that obesity induces insulin resistance, and which is true, which is proved more, and hence is causally related to onset of diabetes. But subsequent development of chronicity with diabetes seem to lead to same adiposity becoming protective also. So this again is a paradox, that while the incidence of diabetes is increasing with obesity, the incidence of complications is decreasing, not decreasing, is not that high as compared to the normal or underweighted people. So another factor that needs to be considered is that not all obese patients are going to develop diabetes, not all. And adipose tissue expansion is an active phenomenon at the onset of diabetes, but seems to confer protection from the development of diabetic complications as the disease starts to be chronic. An increase in the amount of fat stored in adipocytes alters their metabolism and energy homeostasis. There have been explanations for this paradox. Fewer free fatty acids are cleared from circulation and more free fatty acids are released into circulation from adipose tissue as its capacity to store triglycerides is saturated. And moreover, obesity has shown that there is expansion of beta cell mass in rats as well as in some of the human studies. And there have been other mechanisms and postulations to explain increased survival in people with higher BMI and chronic complication of diabetes, and that includes secretion of soluble TNF-alpha receptors and lipoproteins from adipocyte tissues. Few more studies. There have been growing evidence for obesity paradox, and one of these studies almost 1 lakh patients concluded that in patients hospitalized with principal diagnosis of diabetes and its complications, obese patients had a significantly lower mortality rate. Hence, there seems to be a growing evidence for obesity paradox, and this was published in 2020 in Diabetes, so not very old also. And you can see this very interesting figure now, right? So on the left hand side you can see the blue one is the underweight, and on the right hand side is the morbidly the obese class 1 to 3, that is BMI more than 30. The topmost line is showing you that the mean blood glucose is increasing as the body weight is increasing, but the second line shows you that the overall mortality is consistently going down as the person is getting obese. And the third line is that the incidence of hypoglycemia is lesser in the obese people. And probably there was a postulation that probably this less incidence of hypoglycemia is also contributing to lesser morbidity and mortality in the obese people as compared to the lean ones. And this is a list of studies. List of studies which have studied the association between BMI and mortality in diabetes with a follow-up of almost 4 years. And what have they shown? That obesity paradox most likely represents a non-causal association between higher BMI and mortality in diabetes. Then obesity we are calculating by BMI, and BMI is not the true indicator. And you can see here, who would you consider more obese? The person on the left, the BMI of 35 but too much of muscle mass, and the person on the right with the same BMI but the different waist circumference, and probably the amount of adipose tissue is different. So probably in all of these studies they've considered BMI and not the waist circumference or the amount of or the quantification of adipose tissue. Then fitness also plays a role. So effect of fitness on association between BMI and mortality among patients with diabetes. Very, very good slide. If you see here in the lean patients on the left hand side, what is happening? The mortality is higher. Then between 25 and 29 BMI, which is just overweight, the mortality is lesser. But as you come above the BMI 30, then mortality is further reduced in type 2 diabetics. And if these patients are doing good exercise, which is shown by the blue bars, in each respective category you see that the benefit which is achieved is maximum in the obese patients. So lower mortality risk with higher fitness level regardless of BMI, but the maximum benefit conferred is in the obese group. So again a paradox. So what is the reason? Is the obesity paradox for diabetes simply bad statistics? Because there have been limitations of all these epidemiological studies which have studied reverse causation. The confounding factors have not been matched, balanced, or excluded. There is a selection and the survival bias, there is a treatment bias, there is a one-time management of weight, and then there are limitations of BMI because body composition is not studied. The body fat distribution is not taken into account, and the cardiorespiratory fitness, which definitely plays a role, is not being accounted. So there was another study, and it has come in 22 only. So normal weight people with diabetes have more emergency room visits, inpatient and office-based physician visits than do obese diabetics. But study did not find an obesity paradox in any of the 6 major ones. Smokers and persons ever diagnosed with cancer or cardiovascular disease were excluded. So in this study, the confounding factors and the other risk factors were excluded. And once they were excluded, then the obesity paradox was not seen. And thereby, the recommendation of this study was that physicians should continue to focus on efforts to prevent obesity in people with diabetes.
Sir, last 2 minutes.
Yeah, I am going to conclude. So there is a term which is metabolically healthy obesity and unhealthy obesity. And on the left hand side you can see here that if you are metabolically healthy obesity, then the subcutaneous fat is more, the insulin sensitivity is there, the systemic inflammation is not there, the adipokines are favorable, where the adiponectin is low, the leptin is high. On the right hand side you can see the metabolically unhealthy obesity, where the visceral fat is higher, the adipokines are unfavorable, and this kind of obesity is going to pose risk for type 2 diabetes and CVD. So another study which was look ahead study, it refuted that there is a obesity paradox. So I have to rush. So not associate, there is another paradox, that what happens to the critically ill patients of diabetes. So diabetes is not independently associated with mortality in critically ill patients, which we think otherwise, that all the critically ill patients, if they are diabetic, they will have worse outcomes, but it has been shown by a few papers that it is not so in all the patients. So there is another paradox which is called a salt paradox in diabetics. What is that? That the impact of dietary salt intake on GFR and the glomerular pressure is altered in diabetics. And how it is so? It has been observed that the typical relationship between the salt intake and GFR is disturbed in individuals with diabetes and animals with experimental hyperglycemia. And the anomaly has been explained because the proximal salt reabsorption appears to be more sensitive to the inhibition by dietary salt loading in setting of diabetes than those without it. And therefore, the diabetics, even if they are consuming high dietary salt, then their GFR is getting reduced rather than being increased. The another paradox is the stress cardiomyopathy or taxonomic cardiomyopathy, which is a stress cardiomyopathy which happens, we see in younger people who are stressed or who are emotional or who are having hypertension surge or sympathetic overdrives. The temporary there is cardiomyopathy and there is a stunned myocardium and they will end up into heart failure. So diabetics won't have that stress cardiomyopathy. And why? Because the sympathetic nervous system or the autonomic nervous system is damaged, and the sympathetic or the catecholamine surge which comes in a normal person may not be there in the diabetics, and that's why it acts as a savior. Then there is another paradox, which is the treatment of the benefit paradox of cardiovascular and kidney comorbidities, and which is just an observation. It's an observation that the people.
Sir, can you conclude?
Yeah, this is the second last slide. Yeah.
Okay.
So the people who or the diabetics who are having cardiovascular disease, heart failure, and nephropathy, and who are eligible for GLP-1 and SGLT2, which my previous speaker was saying, they are less likely to start these drugs because they are terminally ill, they have lost hope, and the cost of treatment is such high. So this has been an observation. So something on bone mineral density and fracture. So despite normal bone density in diabetics, the incidence of fractures is higher. And all the measurement tools like the DEXA scan and all, they are misleading in diabetes, and this again is a paradox. And something from the incidence or the prevalence of the diabetes, then there again a paradox. In the National Family Health Survey, fourth Family Health Survey, which was done in 2014 and 15, it was seen that the distribution of diabetes in India is not explainable according to the socioeconomic and the other factors, and it needs further study as pertaining to the ethnic phenotype, genetic factors, and probably other factors like the elevation from the sea level and other things like that. So this again was the paradox. So the conclusion is that the findings of obesity paradox should not change the current clinical advice regarding the importance of weight reduction in patients with type 2 diabetes who are overweight or obese. We should not recommend that patients with chronic diseases gain weight, and paradox of diabetes like regional differences of prevalence, less mortality in critically ill patients with diabetes needs further research. Thank you very much for your patience.
Thank you very much. And now we will invite our next speaker, Dr. S.V. Madhu. Dr. Madhu is very well known figure in the field of diabetes. He has been actively practicing with us 35 years, and we have seen him in all the conferences. And I will not add much as we are already running having shortage of time. So we will ask him to proceed with his proceedings.
Thank you, Chairperson, and I thank the organizers of this conference for inviting me to share some of my work. I had proposed, I think that's the slide we are all waiting for. The right slide has come.
It's usually showing for last half an hour.
I know, but we are persisting with, Okay. Okay, see, the idea of this talk, actually this talk is based on 20 years of work, so I'll not bore you with all that now. We are all waiting for dinner. The fact that we are predisposed to atherogenic disease or atherosclerotic disease or cardiovascular disease in our country as a whole, and particularly our diabetics, led us to do research in certain areas trying to understand why this happens in our country. And over the last 15-20 years, certain type of data which led to newer perspectives which I thought I could share. So what I'll do actually would be to run through in a fast forward mode. Yeah, and this is what I proposed actually to do. The first section was all our work on postprandial hypertriglyceridemia and how it affects atherogenesis and type 2 diabetic in our country. Second was testosterone deficiency and CV risk. We've heard about testosterone deficiency earlier in this session in the context of hypogonadism, sexual dysfunction, and so on. But a perspective with regard to CV risk was another angle which I thought I will project. A recent biomarker, which is basically a monocyte CD36 marker for atherosclerotic burden and type 2 diabetes, was another area I thought I'll touch upon. Age, rage, and diabetic macrovascular disease, which means we all know that the advanced glycated end products, the receptor for the same, and the genetic polymorphisms in these could be good markers and help us also understand macrovascular disease in diabetic patients. That was a third. And the last, which we're actually coming up just now and it's yet unpublished, is bone alkaline phosphatase in atherosclerosis. We all think about bone alkaline phosphatase in the context of osteoporosis, bone turnover, and so on. But there is a link between this and cardiovascular risk because it leads to a vascular calcification. It's associated with vascular calcification that also affects cardiovascular risk and mortality. So these are certain areas where I thought I would, what I will do actually is summarize the whole thing. This is all we know. We know the traditional risk factors. And what I'll do is just go to the summary slide. This was an emerging cardiovascular risk factor in the early 2000s. And this is when we got interested into it and showed that in diabetics and in pre-diabetics, especially with macrovascular disease, we had elevated postprandial triglyceridemia, and it was graded from NGT to pre-diabetes to diabetes in large cohorts of nearly 200 patients, was associated with endothelial dysfunction and other surrogates of CVD or macrovascular disease in diabetics, published recently, and also was associated in pre-diabetes with endothelial dysfunction, especially if they had a family history of diabetics. So just the sum and substance of all these studies with respect to postprandial triglyceridemia and cardiovascular risk was that pre-diabetic subjects, no, this is not the conclusion, the next slide, yeah, these studies actually indicate that patients of diabetes, particularly in India, based on all the studies that we did, have significant abnormalities of PPTG metabolism as well as postprandial endothelial dysfunction. The endothelial dysfunction tends to worsen in the postprandial state in every patient, particularly in those who are pre-diabetic or diabetic. And therefore, the cardiovascular risk that emerges in pre-diabetics and diabetics is far more than in patients with NGT, and therefore, this could be a significant contributor to severe risk among Indians with glucose intolerance of any degree. That's one section. the second section is hypogonadism, and we heard some time back that third of men with type 2 diabetes actually have low levels of testosterone. While this can also be associated with ED and sexual dysfunction and all the other comorbid conditions and psychosocial impacts, it also strangely or coincidentally is associated with cardiovascular risk, because we know that this is the slide which tells you why it is important even from a cardiovascular perspective. Patients with type 2 diabetes and CAD, the presence of a low testosterone showed doubling the risk of cardiovascular mortality in 19 months. That means those patients who had CAD and also had a low testosterone actually twice the number of such patients, diabetics, died in 19 months. So that's an important connotation. And a recent prospective study in elderly men also showed that there was a 1.4 times higher risk of the overall mortality in higher tertiles of or higher quartiles of testosterone among patients of diabetes and CVD particular. In LDL receptor deficient mice models also, testosterone administration reduced atherosclerosis. So it seemed to have some anti-inflammatory effect. Therefore, testosterone deficiency in general, apart from its own direct effects, seems to have enhanced cardiovascular risk, particularly in diabetic patients. And this study actually shows that the CRP and has been shown to be significantly higher in type 2 diabetes patients with hypogonadotropic hypogonadism. Therefore, a higher inflammatory state or a pro-inflammatory state, nearly double compared to those who don't have this condition, and therefore again this probably contributes to the higher risk of cardiovascular disease. And we did a study comparing the same, which is published in IJEM, not go through it in detail. What we actually found that testosterone deficiency is found in significant proportion, again close to 30-35% as reported elsewhere, and low testosterone levels could contribute to a significantly higher severe risk in Indian subjects, because we found it to be lower in those with macrovascular disease. Now coming to the third aspect, again quickly run over this and focus on the last aspect. Monocyte CD36 expression is associated with atherosclerotic burden in a diabetic patient. What do we mean? What is monocyte CD36 at all? It is a potential non-invasive tool to detect atherosclerosis in patients with type 2 diabetes mellitus. It is a class 2 scavenger molecule, receptor expressed in monocytes, and its role is actually to scavenge oxidized low density lipoprotein, and not scavenge but increase its uptake into the cell and cause foam cell transformation, which we know is associated with atherosclerosis. Therefore, if you were to do a flow cytometric expression of CD36, you would find that you could find abnormalities which could mark for cardiovascular risk. We studied 70 patients and showed basically that the expression of this CD in the monocytes was much more, and particularly in those in whom the A by B was also negative. So we all know that ankle breaker index is used as a marker or detecting early atherosclerosis in a type 2 diabetic patient particularly, but even in those in whom the A by I was negative or was non-conclusive, even there we found that CD expression or CD36 expression could actually detect several of these patients with cardiovascular disease. Therefore, we believed based on this study that MCD36 plays an important role in atherogenesis. With reference to ABI, it performed robustly as a marker of ATH, because wherever ABI was positive, this was also positive. Furthermore, it could stratify subjects within the ABI uncompromised group, that means ABI negative group, commensurate with the conventional clinical pathological atherosclerosis. That means it could be used as a marker to stratify patients with cardiovascular risk and could in the future turn out to be a good biomarker. This stat I'll totally skip. Just to say that polymorphisms and expression of RAGE gene in diabetes mellitus are associated with elevated AGE levels and macrovascular complications, and therefore even genetic markers could be used to identify and understand cardiovascular risk in diabetic patients. I think that would be enough. This area I'll touch about 2-3 minutes before we close. This was a recent observation last 2-3 years, and many of you might have observed in your clinics as well, that some of our patients of type 2 diabetes tend to have higher levels of alkaline phosphatase for no apparent reason, and their liver functions would be normal. and they would not have any bone problem as such. So when we looked at our electronic records, I seem to observe that, a large, maybe 20-30% of patients seem to show high alkaline phosphatase, and I was wondering why this could be happening. And then we planned a study and looked at this subset of patients. We cleaned some of the data, got into the groups which are clearly normal or clearly abnormal, alkaline phosphatase, not bone alkaline phosphatase, and then planned the study. And that's when we understood that actually this could be actually indirectly reflecting a cardiovascular risk rather than anything else, rather than a bone abnormality. The background of the study, therefore, when we looked up literature, was individuals living with type 2 diabetes, of course, are at risk of atherosclerosis. The pathogenesis of atherosclerosis includes calcification of atherosclerotic plaques, as we all know. ALP, particularly the bone alkaline phosphatase, is associated with vascular calcification in end-stage chronic kidney disease. That was a known fact. It was already known in literature. Elevated ALP has been associated with increased mortality in CAD. This has been reported. Unexplained elevations in serum alkaline phosphatase, perhaps bone alkaline phosphatase, occurs in diabetes mellitus, and therefore we explored the possibility that this could be associated with CV risk. Bone alkaline phosphatase actually is expressed in vascular smooth muscle cells also. And vascular smooth muscle cells release matrix vesicles which act as a nidus for vascular calcification. And some matrix bound vesicles have high concentrations of bone alkaline phosphatase. And therefore, bone alkaline phosphatase is believed to increase calcification in the vessels by several methods, including inactivating pyrophosphates, which inhibit calcification, inhibiting osteopontin, and also hydrolyzing organic phosphates, which release phosphates. And therefore, a change in phosphate to pyrophosphate ratio is what is thought to lead to excess calcification in the vessels. That is a hypothesis. When we looked at data, and as you all can see in this slide, whatever you can, except for the alkaline phosphatase and few lipid parameters, they're all matched for age, female sex, duration, the sex ratios, duration of diabetes, BMI, the glycemic parameters, and so on, and also the calcium phosphate and PTH profiles, more or less. And also the ABIs were similar, and yet you find two groups of patients who were carefully selected who had on the left low normal alkaline phosphatase, and the middle row significantly higher alkaline phosphatase. And then we looked at their bone alkaline phosphatase and few other parameters. What did we find? Significantly elevated bone alkaline phosphatase as expected, just showing that the elevations in alkaline phosphatase were actually coming from the bone. Their leptin levels were normal, which is also studied, and their vitamin K2. And mind you, vitamin K2, and I think there was a talk on vitamin K. I'm not in this conference. Also has something to do with atherosclerosis, and it is believed that vitamin K2 actually prevents vascular calcification. And therefore, in this study, when we looked at this group with high LPs, we found lower vitamin K2 levels in them. And there was good correlation between the bone alkaline phosphatase as well as vitamin K2 levels, inverse correlation, suggesting that the two, either one leading to the other or the two together, promotes vascular calcification in individuals with high ALP. And therefore concluded from this study that there is several, we concluded from that study that bone alkaline phosphatase could be the underlying factor which is causing unexplained alkaline phosphatase elevation in many of our patients, and to find that on the basis of that we could substratify our patients who are actually at elevated or increased cardiovascular risk. It may be a simple measure, could be a biomarker, and could just by looking at the alkaline phosphatase in those individuals you might focus your attention about preventive measures for cardiovascular disease. So what have I concluded? 3 or 4 aspects, but I focused on the most recent aspect, which is of course yet to be published. There are several facets of diabetes-related atherogenic risk which are being explored recently, which is beyond what we all traditionally understand, and which are contributing immensely to our understanding of what is driving this risk in type 2 diabetes. Because the traditional risk factors do not account for all the excess atherosclerotic risk in diabetes, all that we know. And therefore, there are several unknown areas, and some of them were highlighted in this talk. And some of this research can lead to the development of useful early biomarkers simple as well as complex, to identify diabetic patients with a higher CV risk. With that, I conclude. Thank you.
Can I have one question? Thank you. So you spoke about the postprandial or non-fasting triglycerides. Is there a cutoff? When we start doing it, because of point of care testing today, a lot of us are doing non-fasting lipid profiles. But there is no real cutoff. How do
ये
you
सब निकाल के
differentiate that?
वो भाई का कौन था हमारे भाई का कौन सा होता था मेरे को दे देना हमारे भाई से कौन सा आया था एक तो एक है ये दो ये एक दो हाँ तो वही आपको कोई दफा हुआ केबल विजय केबल ये सब
We are in the process of finalizing the diagnostic cutoff based on our own studies. Now we have about 700-800 such studies available to us. So we are working on that. We'll probably come out with that.
अरे तो क्या हुआ ये ले जाना पड़ेगा ऐसे लगा कर नहीं छोड़ सकते ये सब भी ले जाना पड़ेगा ना लैपटॉप निकालूंगा फिर इसका क्या काम
That is also, actually it was slightly lower in the group where there was higher glycosylates. We have explanations for that, but it was not due to that, due to vitamin D deficiency.
ऑलमोस्ट सब जगह तो अभी खत्म हो जाएगा
The myths that increasing TG is associated with increase in CV risk. I'm talking about primarily hypertriglyceridemia. In absence of low HDL, number one. Second, as he asked, there is no cutoff.
8:30 बजे तक आना पड़ेगा सुबह 8:30 बजे तक यहाँ आना पड़ेगा हाँ तो 8 बजे निकल जाना तो 8:30 बजे पहुँच जाना 8:30 बजे यहाँ पे आना है सब जगह पे अरे कल खाइए ना 12 बजे तक नहीं है दोपहर को हाँ इसके लिए सुबह जल्दी आ जाओगे अपन 1 बजे भी फ्री हो जाएंगे सब खाना खाने का टाइम ये तो क्या आज दोपहर को चालू हुआ 2 बजे तो ये 8 बजे तक खींचा कल सुबह का 8 बजे तक होगा तो ये 2 बजे फ्री
I don't know whether some of you are aware of a study of Pat Shetel, who actually showed why we believe everything is low HDL. The fact is that the low HDL is a consequence of a high DG. That's the actual issue. So in a large study, I think this was the 90s, where cardiovascular risk was studied, HDL was a very important cardiovascular marker. And the most important cardiovascular marker in the relation analysis, the moment you add PPTG, the HDL value should PPTG to go. As long as you added fasting TG, HDL was the most important risk marker. And they were the first group to suggest actually that probably it's the post-prandial TG which are looking at the fasting TG, so we're not getting into the right thing. Once you start looking at post-prandial TGs, then it will become far more important. And therefore, that was around the 2000, late 1990s, when this was emerging as a good or important cardiovascular risk factor. And that's when we got on to it in Indian diabetic patients. The second question is regarding the cutoff. There are no data at the moment, I'm sure, and we are working on that, probably will come. The 200 cutoff is only from one study, which is a Japanese study, only based on a CIMT surrogate marker, which is a surrogate for CVD. It was not a long-term or a study in humans where you could say that you are associated with future cardiovascular mortality. No such thing. It was just one study. I just mentioned it was asking for a cutoff. It's not a cutoff in the true sense of the word based on longitudinal studies. And the third thing, that's where I'm coming. The third thing is TG risk or a PPTG risk as a risk factor of cardiovascular disease is not the same as if you control TG, will it reduce CV risk? They are two separate questions. We need to understand that. So just saying that excess TG or excess PPTG is associated with higher CV risk doesn't necessarily mean that by reducing the TG you are going to reduce the CV risk, and that is the problem. That's where the problem is. So that 200 cutoff, if you reduce it to below 200, will it reduce? That question is a different question altogether. That is not answered by these
That's
studies.
what I asked you, because in the 90s and in 2020, if you look back, all the trials which was primarily done to reduce TG or to increase SDL, all failed.
That's all.
So we did a meta-regression analysis to find out why it was happening. You look into any trial, starting from the failed to accord lipid to SPS to thrive to aim high, all trials failed. Summarily, all the trial till date done to reduce TG has failed to show the cardiovascular protection.
Correct.
Now, if you analyze all those trials put together, the consensus came out that yes, the TG could be a CV risk factor in a background when there is associated decrease in SDL. Right? So there was one cutoff was made that okay, if you have got a TG of more than 250 milligram per DL or SDL is less than 35, these are the groups where you might get subset of patients by using fibrates or any other drug that lowers TG or increases DL might improve the CV outcome. So the entire, the 1990s theory of TG, I don't know how far we are at the moment in terms of cardiovascular risk, just based on a caloric intima media thickness. There are a number of trials that reduces CIMT reduction with many drugs. All SU reduce CIMT, or none of the trials showed any positive outcome. If you remember, even DPP4 trials all suggested reduction in the CIMT, no reduction in the original trial. So CIMT is a very good soft surrogate. We do not say, a lot of things unless the drug reduces the CIMT.
I'm totally okay with that, and the fact is that reducing TG has not been shown to be associated with decrease in cardiovascular risk.
बॉस लोग को बता दो उन्होंने बुक करा अपने तो आया नहीं था और इतने परेशान था
It is increasingly believed that those people who has got a primary hypertriglyceridemia that tends to produce more cardiovascular disease. So these are newer things.
In fact, the first 7-8 slides were more focused on that aspect, but I skipped those
But
slides.
unfortunately, everywhere in the world we do a fasting TG, right?
Yeah.
The Denmark is the only exception where they do a prandial TG.
Yeah.
It's the only country in the world.
Actually, postprandial TG and HDL, fasting HDL are very closely related. And the PPTG actually drives the HDL. This is also a theory, and a lot of metabolic pathways are there for that. And that's why people say that focus more on reducing PPTG rather than fasting TG, you might have better results. So those trials are required.
So did you ever see any relation with the increased uric acid and the risk of CVD mortality in the diabetics?
We didn't study that aspect, but yes, there are some studies which have shown that uric acid is a factor, but we didn't look at that. We didn't look at those aspects.
In your study with alphos, did you do the isoenzymes or it was just the alkaline phosphatase?
The alkaline phosphatase, and then we looked at the bone alkaline phosphatase, bone specific alkaline phosphatase.
Thanks so much. Thank you. And a hearty thanks to Dr. Watson for such a nice talk. Thank you all. Thank you.
Sir, इनका एक क्वेश्चन